Morning, ladies and gentlemen. Today we are pleased to welcome a very special guest, Dr. Saleh Al-Rajhi. He's a consultant and specializes in a family and obesity medicine. He graduated from the University of Minnesota. He is the founder of the first clinical obesity program at King Fahad Medical City. He's currently working as assistant professor at King Fahad Medical City. Please give your full attention to Dr. Saleh Al-Rajhi and help me in welcoming him to the meeting. Please, Doctor, continue your session.
Good morning everybody. صبحكم الله بالخير، حياكم الله. الصباحيين هذول يشجعون دائما وجودهم. مرة مهم الموضوع اليوم هذا لأنه it's new. Good morning to everybody, and I've seen some people exercising this morning, which is really good. Some people jogging, walking. It's really excellent. Today we'll be introducing KCI. KCI is key care indicators, and we think lifestyle medicine would be amenable to this, especially research in lifestyle medicine, where we need to show the effectiveness of lifestyle medicine practices to the rest of the medical and scientific community. Now this is open for discussion. We'll be applying this to all the research this year, inshallah ta'ala, with different institutions. So we'll talk about definition, scope, application, impact on health and wellness, and also impact on healthcare cost. This is a preliminary definition of KCI. Key care indicator is this chronic disease quality of care measuring care management outcome in areas of well-being, quality of life, burden of disease, cost accounting, pharmaceutical burden, and chronic disease comorbidity. Examples would be common clinical care indicators such as A1C, number of medications used and discontinued, reversal or remission of chronic disease, and their comorbidities. Now, other definitions, this is very important because I think we need to establish this in a more detail. What is well-being? So we need to define it in order to measure it in our patients. Well-being is a holistic, vibrant, and active living with the least burden of disease, where an individual and family are proactive in their own wellness and prosperity. This is one of the key issues of lifestyle medicine is the patient is an active participant in their own care. A quality of life is secure life and living in legally just and consistent, stable community where cultural norms, faith, and value systems are complementary of each other, supporting individual, family, and social rights to stress-free, threat-free, and healthy living. Key indicators of quality of life include religious freedom, wealth, employment, environmental safety, physical and mental health, education, recreation and leisure time, social belonging, religious beliefs, safety, security, and freedom of movement. If you look at the world today, there is a lot of problems related to these issues. Burden of disease is one of the biggest things we focus on, is the sum of mortality and morbidity measured by a metric called disability adjusted life years, DALYs. A lot of you in research know this, and we will be using this in our studies this year, inshallah ta'ala. DALYs are measuring lost health, standardized metric that allow for direct comparisons of disease burdens of different diseases across countries between different populations and over time. Conceptually, one DALY is equivalent to losing 1 year in good health because of either premature death or disease or disability. And we're facing the burden of type 2 diabetes, obesity, hyperlipidemia, and hypertension. And also, we see a lot of osteoarthritis, knee pain, low back pain in our patients from a young age, which is really concerning. One DALY represents one lost year of healthy life. Now, cost accounting, this is one of the major focus areas for the transformation in all industries in Saudi Arabia, including the healthcare industry. In patient care, providing detailed information that can be used for analytics and decision making. Now, in the past, what we used to be measured is direct cost, what is paid by the government. What we're going to look at is the cost to the patient, to the community, lost days of work, and other costs. It is the process of estimating and classifying costs of healthcare incurred by governments or other organizations. This will be related to supply chain, scenario planning, cost control planning, and allocation of resources, and calculating reimbursement value. This will be focused also on value-based healthcare, which is one of the issues we'll be discussing over this year and next year. And we'll be discussing this also with private insurance companies to cover lifestyle medicine services. Now, pharmaceutical burden, which is huge in this country, a lot of patients have large numbers of medication. Usually when the patient is not controlled, if they have type 2 diabetes or obesity, more medication is being added and medication being added to control the side effects of another medication. So the burden is huge. I'll give you an example. We get a lot of patients with PPIs, proton pump inhibitors, Nexium, omeprazole, and others. And when we start lifestyle medicine intervention, usually we stop these medications. Now, we need to study why people get reflux, related to their lifestyle. One of the observations we have is sugar consumption, processed food consumption, fats and oils if they are high, and also eating too much, and sometimes eating, especially at night, and going to sleep. So we'll be looking at cost to government and third-party payers, cost to patient and family, intake, adherence and compliance, side effects and medication use, comorbidities, and management costs, drug-drug interaction, disease maintenance versus remission or cure. One of the things that lifestyle medicine solves is that the most common practice with classical medicine is disease maintenance. It's not health maintenance. So we're looking at A1C. If it's 7 or around 7 in the MENA region, everybody's happy. If you practice lifestyle medicine, you're not happy until you see remission or at least better control. Polypharmacy is a big problem. And also we have to look at, when we look at the pharmaceutical burden, disease versus holistic care focus. Chronic disease comorbidity, called multimorbidity, morbidity burden, or patient complexity. Now, in our society, when you look at what's the most common chronic disease, probably obesity. And obesity, we did a review on obesity and how many comorbidities come with obesity. 240 plus diseases come with obesity. And to the point that many of the consultant specialists, they are not aware what obesity does. Even policymakers and politicians, they don't have this knowledge, so we need to spread it, from heart failure to low back pain to infertility, to reflux disease, to cancer. So there is a lot of problems with this. Now, this is more of classification into comorbidities and clinical care, and that classification system, we'll be using that in research mostly. Now, what is the scope of KCI? And this is for you who are doing research. This is very important. Chronic diseases, pre-chronic disease reversal, we have a big window to work on pre-chronic disease, pre-diabetes, pre-hypertension, hyperlipidemia when it's starting. Also, we will be using it on preventive healthcare services, preventive wellness management, and well-being maintenance. Now, the well-being is left up to the patient to come. It's not a system-driven well-being maintenance. So we need to, or we will be actually calling for system-driven maintenance practices, i.e. a patient will be called for maintenance. Now, if you drive a car, probably the dealer will remind you to bring your car for oil change and maintenance and all that. But the healthcare system does not call patients to come for health maintenance. Cost accounting comes again, pharmaceutical use up Zaid's area. Community resource utilization, like we did in this conference, we use a lot of community resources. This is the first time that we employ every resource that we can, and also bringing people into the fold, because a lot of government agencies, organizations are not aware that they have a role in this. Individual and family measure of active wellness participation. Is the family motivated and seeking preventive services, well-being maintenance, instead of disease management? Now, preventive healthcare services, percentage of individuals receiving preventive care without asking for it. يعني كم عدد المرضى مو من المرضى، الناس اللي يجون عشان حنا نناديهم السيستم، وزارة الصحة تطلبهم to prevent problems. يعني we'll screen you. We know you're healthy. We know you have no complaints, but we want to measure how many people are willing to come for health maintenance. So we need to be used to getting healthy individuals coming in for healthy checkups to make sure they stay healthy. This is the role of lifestyle medicine. Now, this is combined with classical medicine. It's not excluding your regular practice. So this is system-generated preventive care, and we're hoping that when you turn 40 and you're a female, that you'll get a message, okay, happy birthday, you have an appointment for a mammogram. Or if when you turn 50, we'll say, well, happy birthday, we need to get a colonoscopy done. In addition to weight maintenance, screening you for diabetes, hypertension, hyperlipidemia, and the regular intervals, just to make sure you're not having this. In addition to this, you will receive lifestyle medicine intensive care or regular care. Now, well-being maintenance is a proactive and preventive healthcare services at individual, family, and community level. Proactive care, this is when you have a chronic disease that started. So we will not wait for you to come. We will be following you and to bring you to the system, so you are part of your own care, and this will hopefully become a norm in our society. Now, pharmaceutical optimization, application of necessary pharmaceutical products for NCD permission, which is non-communicable disease remission, reversal, and prevention of comorbidities with reduction of medication burden as a KCI. So this is one of the major components, because expenditure on pharmaceuticals is very high. Now, over time, this will increase as the cost of these products increase. Now, community resource utilization is not being employed enough. Now, Hail is a starting point, and hopefully we'll continue with that. And there is a proposal that the momentum of lifestyle medicine will continue on a monthly basis, each month in a different province with a different theme related to lifestyle medicine. Now, percentage of community resources proactively engage with citizens to improve quality of life and living. There is a lot of talk about quality of life, about all ministries, all organizations, either government or private, getting involved, but very few actually get involved on the ground. We have big mega projects, but these mega projects do not affect people individually. We need to work on a smaller scale in the community to get people involved i.e. these organizations or ministries. Let's take the municipalities itself. Urban planning is a problem in our country. يعني لما نطلع نمشي الرصيف عادة للوحات وما هو للأوادم، ولا تلقى حتى أماكن النزول من رصيف إلى رصيف تلقى كم بعضها يمكن 40 سنتي، المفروض 15 سنتي إذا كانت زي الدرج يعني، أو إنها تصير تنزل نزول كذا. There is no safety pathways for bicycles, for hikers, walkers, runners. We don't have it yet. And we're hoping that حائل will be the first one to designate and dedicate special pathways that are lined on the streets for walkers, runners, and cyclers. Cyclers last night were complaining or indicating there is a lot of accidents. The bikers are suffering. Traffic police is not involved, and municipalities are not really providing areas for them to cycle. Now, application of KCIG would be a preventive wellness care, proactive chronic disease management. Now, proactive chronic disease management is not, we don't want to maintain disease. We don't want to either put disease in remission or improve it. Improvement could be in the number of medication, taking less medication, employing lifestyle interventions in chronic disease management. And if you practice this, it's really effective, extremely effective. We see it in patients with cardiovascular disease, hypertension, hyperlipidemia, even atherosclerosis if they have it bad, and also diabetes type 2 and pre-diabetes, infertility like PCOS. This is very effective. Now, comorbidity interaction using diabetes as an example of a disease that can affect the diagnosis, treatment, and prognosis of a second disease. You know, diabetes complications include renal complications, could be neurologic complications, could be ophthalmologic complications, could be cognitive. There is a lot of things. So the more we are proactively engaging patients, and patients are participating in the decision-making. I know physicians, sometimes they like the power they have, but I think if you engage the patients, like, which one would you like? In my practice, in my clinic, I give patients choices. Do you want to go pharmaceutical only? Oh, you like lifestyle interventions? We like a combination. Sometimes, usually I don't go pharmaceutical alone. I go combination sometimes just lifestyle intervention. And the patient is really appreciative. You're not going to give me a pill? I said, we don't have to. You know, we could get your diabetes improving, but I'm going to see you every 2 weeks or every month, and we're going to measure this. We're going to measure your waist, your weight, and also A1C and other functions, especially if they have hyperlipidemia. Now, prevention of new onset, this is impact on health and wellness, prevention of new onset chronic disease, prevention of pre-chronic disease. And we have a big chance here in this country to push this forward because we have a lot of, you know, obesity, overweight, pre-diabetes. And the number of pre-diabetics, according to some studies, if we have 30% of the population have diabetes type 2, probably there is another 30% with pre-diabetes. And I get patients who have pre-diabetes. Well, السكر مرتفع شوي ما عندك سكر. It's not really true. You have to tell them you are on the way becoming diabetic. Now, there is one observation. If you get patients with hypertriglyceridemia, triglycerides are high, probably within 3 to 5 years, from my observation over 25 years, they will end up being diabetic. So you really have to follow them. And we're going to do a study to follow up on people with hypertriglyceridemia over 10 years to see how many of these people turn to be diabetic and how soon, how fast. So we need to qualify this. Improve well-being and quality of life and living. I'll give you an example. People with knee pain. A lot of the knee pain that we see is related to poor muscle. We have sarcopenia, muscle wasting. So if the muscles of the thigh and the hips and the lower back are weak and يعني في ضمور في العضلات, patients will have low back pain, pelvic pain, and also knee pain. If you improve that, but also check for vitamin D. If the vitamin D is low, they will also have pain. So if you start them on an exercise program, you will see the pain improving even if they have osteoarthritis. Now, improving cost containment and healthcare spending, reduce comorbidities and disabilities, and economic returns, productivity and longevity. And also we will reduce other comorbidities such as depression, social isolation, other problems. Now I'll open it for discussion. I don't know how much time I have, but this is food for thought. We will be working on this. دكتورة حصة. بالنسبة لهذه. المدن الصحية صح؟ فهمت عليك، يعني مثل المدينة الصحية في الكيري هذول. حائل is working and becoming a healthy city now. And Hail also is, they are working really strongly to becoming the healthy lifestyles province in Saudi Arabia. We think Hail إنه ذكي. احنا نقول حائل إذا فكينا حائل فكينا الباقي. إن شاء الله تعالى. We are working on it in Hail, but I'm not really aware of that. I know the program, but I'm not the best person to ask. أي أسئلة أخرى? This is food for thought. This is not a done science. We will be working on this to establish it for Saudi Arabia. I don't know, Dr. When? Anything in the States like this? Are you doing anything, any research related to measuring the quality of care, key care indicator, you know, like reducing the number of medications and etc. And do you have the same word, which is key care indicators? But key point indicators are there. A lot of countries are using them, but key care indicator, measuring these things, I did a quick search before I wrote this presentation. Australians are beginning something not exactly the same, but close to it.
Yeah.
In Australia.
The field of lifestyle medicine definitely needs more research that defines its value, and this is going that direction. So I think it's wonderful.
I don't know any in the States if there is anything like that.
I don't think so. Not that I'm aware of.
Hopefully you will start something like that, or get the colleagues there to start. I don't know. What do you think? I mean, as far as doing a international multi-center studies related to this issue.
I think it's a good idea. Yeah. Something to bring to the World Lifestyle Medicine Council.
Because we want to push a little further, you know, into WHO and putting this as part of their work related to improving healthcare, especially in rural areas, poor countries, because this is a really good tool, very cheap, doesn't require a whole lot of infrastructure.
And if done right, you can get some good grants for it too.
Inshallah. زي ما قلنا, this is food for thought. هذه الآن راح تدرس على 10, will be 10 studies this year. I think I mentioned that multiple times. We will be actually using K-care indicators as part of these studies to see how much we can get from these and how much can we affect the decision making, policy making. Dr. Mohammed.
Thank you, Dr. Saleh. I just want to raise a point. Maybe we can discuss it with Dr. Khalid Abdul Karim when he's here, inshallah, with us. Now, the transformation in the MOH is based on value-based. So value-based practice, I think it's interacting or intersecting with what you are proposing, the key care indicators. I'm sure that there is a huge team working on the standards and values, how to measure it, how to calculate all the outcomes in a matter of numbers, and for the decision maker to give this fund or this cluster or increase it or decrease it according to value. This is the whole idea behind value-based. But I don't think they are including the holistic approach that you are proposing, which is really important, that we are not only talking about how much hemoglobin A1C is dropping, but we are talking about how much this person life is being changed toward a healthy life. So I think this idea should be discussed because we are still in the infancy of this transformation, let's say, in a matter of the standards. There is a lot of things being done, but the standards, as far as I know, is still ongoing process. Thank you.
Sure. He's very excited actually about this, and he's looking forward. He told me looking forward to seeing the results of these studies and also quantifying and qualifying key care indicators, because at the end of this year and next year, we hope to, inshallah ta'ala, publish a few studies on this, and also with the collaboration maybe with colleagues from other countries to standardize across the world. So will push lifestyle medicine a little further, and also will help a lot of countries decrease the cost of healthcare delivery, and also improve access to care. Access to care, there's a lot of definitions. For example, access to care here is available, but accessing care on time and getting the right service at the right time is the key issue. There is a lot of facilities, a lot of providers, but sometimes we're not getting the right service that we need. But the system has been so far is reactive for either acute or chronic problems such as cancer, heart disease, or car accidents. So we want to move from reactive healthcare system to proactive and preventive healthcare system. And hopefully we'll see some reversal in some of the chronic disease. But like we said in one slide, on the first day, we have only 20% of the game. 80% of the game is everybody's business. It's not only healthcare business. Any other questions, comments, recommendations, critique? Dr. Nasreen?
Thank you, Dr. Saleh, for this very promising talk, actually. I like what you put a spotlight on quality of life. Now we have it as a unit, and it's really acting very well. So we can cooperate with them in this, because we have, as you know, quality of care, quality of life measurement and objective things. They can use it, and we can collaborate everyone together, not only as a health sector. Everyone can share.
Dr. Nasreen from King Abdulaziz University, Dr. Nasreen and her team, Dr. Raja Al-Raddadi from King Abdulaziz University, and from Cluster 2 in Riyadh. We're collaborating in a few studies, and they will be with us on the other studies also, inshallah ta'ala. So if other universities, other institutions interested, talk to me later. أسئلة أخرى, comments? Thank you, everybody. Let's move on to the next one.
Thank you, Dr. Saleh. Our next speaker is Dr. Nasreen Al-Hamdi, is here to discuss the physician and the provider personal lifestyle impact. She's a consultant and specializes in family medicine. She's graduated from King Abdulaziz University, and she is working as a lifestyle medicine. Please help me welcome Dr. Nasreen Al-Hamdi.
السلام عليكم ورحمة الله وبركاته. كيف حالكم جميعا? Today is the third day of this very great symposium. actually, today my talk will gonna be about physician and provider personal life impact. Little bit this talk, it's maybe embarrassing for some of us as physicians because we are a human being. So we have unhealthy habits. We have a lot of things that we can do, and our patient seeing us doing that. So when you are advising your patient, today we're going to discuss how much it's affecting your health, your patient health. So we're going to do like evidence review and see how much this is going to affect. I like this. Yesterday we went after we finished our gathering with our Ha'il ladies to see this Ogda, I think it's called. Okay, so our objective today, lifestyle among scientific data supporting that physicians who practice healthy lifestyle are more likely to counsel and improve patients' outcome, and this is right or no. Discuss the impact of physician as a role model for their patients and communities. And we're going to describe some strategies for incorporate a wellness program for providers into clinic, medical office, or another healthcare setting. Okay, let's start with this study. This is Saudi study, was done at Riyadh. Healthy lifestyle among primary healthcare professionals. The objective was from this study to assess 4 main determinants of healthy lifestyle: smoking, diet, exercise, and body mass index among primary healthcare professionals. It was cross-sectional study, was done at December of 2012 for a year, and including 322 participants from primary healthcare physicians. It was using stratified random sampling method from 4 primary care centers of King Abdulaziz Medical City, and also National Guard, Health Affairs, Riyadh, Kingdom of Saudi Arabia. A trained nurse used approved questionnaire for data collection. So the result was prevalence of smoking was 8.4%. Most of participants score more than 50% of healthy diet. Only 38.8% of participants have normal BMI, and 21.1% were physically active. So we're talking about more than almost 79% physically inactive. So as a conclusion of this study, healthcare professionals in primary care setting and in another healthcare facilities need to be targeted by health promotion programs for their own health benefit and better to be good role model for their patients. This is another study was done. It's examined personal health behavior and wellness, health-related lifestyle and prevention screening practices among licensed physicians. There was a questionnaire mailed to a random sample of 1,875 physicians practicing in California. Data from 763 returned questionnaire, there was 41% analyzed. Results showed 7% of sample clinically depressed, and 13% reported using sedative or tranquilizers. Over 53% reported severe to moderate stress, and only 38% describe level of daily stress as light. So as you are seeing here, it's a huge percent. About 4% self-reported recent marijuana use. More than 6% screened positive for alcohol abuse, and 5% of gambling problems. Also, 35% of participants reported no or occasional exercise. About 27% self-reported never or occasionally eating breakfast. In addition, 34% reported 6 or fewer hours of sleep daily, while 21% self-reported working more than 60 hours per week. I think most of these can be also applied here. So as a conclusion, physician excessive number of work hours, more than 65 hours per week, was associated with lack of exercise, not eating breakfast, and sleeping fewer than 6 hours per night. All these unhealthy habits, there was a significant correlation with the long working hours. On the other hand, California physicians report breast and cervical and colorectal and prostate cancer screening behavior that exceed population estimate in California and Healthy People 2010 national goals. So they are moving to screening for cancers in their practice more than do prevention services. And the recommendation was from this study, which was done at California, additional intervention designed to improve physician lifestyle and personal health behaviors should be encouraged. There was strong personal clinical correlation for prevention and health promotion topics ranging from dietary, fat intake, sunscreen use, mammogram and physical activity, smoking, alcohol use, and others. And one of the strongest predictor of health promotion counseling by primary care physician is practicing healthful behavior oneself. And in fact, physicians who were attempting to improve poor habits counseling patients significantly more than physicians who were not doing any behavior change for himself, regardless of the provider's actual health status. And this is very important. And we're going to show you also another study for that. If the physician is doing behavior change and patients seeing them, they are motivating to do behavior change. They are more motivating to listen to the physician and be confident of this physician advice instead of the physician is not doing any behavior change in himself. This is very interesting study actually. It's impact of physician BMI on obesity care and beliefs. Study design was, it's a national cross-sectional survey in US of 500 general practitioners, family physician, general internist from 9th of February to 1st of March 2011. The characteristic of study sample, it's including more male, it was almost 67% male, white also it's 70%, age 40 or older, overweight or obese, most of the participants, almost 53% of them, and general internist, less than half reported that they are currently seriously trying to lose weight, 41%. 36% reported very good or good obesity-related medical training in medical school or residency. They exclude 2 underweight from the study, so they end up with 498 participants. This schedule showing us the patient BMI image in the upper here. Okay, here in the upper row, we have the patient BMI image, and lower we have the physician BMI and the physician practice regarding the physician BMI and patient BMI. So in the upper row, we are seeing here patient BMI starting from normal, the first one. Second one is overweight, and the 3 is the obesity, stage 1, stage 2, stage 3. And the physician BMI practicing in recording obesity or starting to do discussion and in advising patient for obesity effects. So if the patient, for example, normal weight at the first one, the physician weight also was normal BMI. So both of them, physician and patient BMI normal, the recording obesity diagnosis and starting in patient advice for obesity was higher. But if the physician is overweight or obese, as you are seeing here, and the patient is normal weight, the physician never ever open even the discussion for weight management. And second one, you are seeing the patient BMI is overweight and obese, and the physician BMI is also obese or overweight. So both of them, patient and physician, obese or overweight, initiation, obesity diagnosis or session for obesity management, it's higher. So what's the conclusion of this? That means if the physician and patient have same BMI or more, the physician become motivated to diagnose obesity or talk about obesity management, and compared to if the physician is overweight and patient is normal. Okay, why this happened? Why if the physician is overweight or obese, he cannot open discussion with the patient about weight management and compare with normal BMI physician? This slide showing the physician regarding his image in front of the patient. So physician should be role model for their patient. This is one of the questions was asked to the physician, if he is normal BMI or overweight BMI. Maintaining healthy weight, the physician when he is normal BMI, his beliefs regarding maintaining normal weight, it was 72%. So if the physician is normal weight, he's seeing that, yes, I have to be role model for my patient. I have to exercise regularly if the physician is normal weight. But in the other column, when you are saying if the physician is overweight or obese, their beliefs regarding maintaining role model for the patient or exercise regularly is less. So it's almost 57 or 56. So again, why the physician, if he is unhealthy BMI or obese or overweight, he cannot open a discussion with the patient about weight management because he have beliefs that he is not capable to do that or unconfident to start to type of this discussion with the patient. Okay, let's see the patient confident in the physician on the other hand. So this questionnaire was asked for the physician and in the other hand asked the patient. They asked the patient if your physician BMI is overweight or obese. What is your confidence in this patient when he start to talk with you about the weight management? Actually, physician, patient, if it's normal, if the physician overweight or obese, and the first row, the confidence of patient to advice of this physician is very low. It's almost 4% or 10% maximum. But if the physician is normal weight, the patient confident in the physician advice is almost more than 75%. So you are giving a message without even talk with your patient. If you are normal BMI, you're gonna be confident when you're talking with him about weight management. But if you do all approach, but your BMI is not normal, the patient will take message that I will not be confident of this physician. So this study suggests physician BMI impact obesity care. Normal BMI physicians are more likely to provide obesity care to their patients and feel confident doing so. And as a recommendation, physicians' self-efficacy to care for obese patients regarding of their BMI may be improved by targeting physician well-being. And this is the message here. We have to deal with the physician as a human being. They need a lifestyle intervention. They need enhanced quality of obesity related training in medical school and residency or continuing medical counseling. There is very interesting actually information regarding the physician as a source of information versus others. How much your patient is really confident about what you are talking when you discussing with your patient anything, Kruter et al. Found that when physicians discuss health promotion issues with their patients, they are responding more, almost 35 to 55%, if more than if they are just taking material or listen to, for example, any program talking about promotion issues. So it's the responding rate regarding quit smoking, make change to their diet, doing exercise, more responding when the physician talk with them other than taking material, written material or something. Okay. What about barriers? Barriers of physician. Posted questionnaire survey for random sample of 430 GPs in UK reports spending an average 16% of practice time on prevention and 79% educating patient about lifestyle risk. So this is very good actually. So in UK, they are educating their patient. Versus 2000 US National Ambulatory Medical Care Survey, 15.7% of office visits to primary care providers include health counseling on diet, physical activity, or stress reduction. So it's big different. This is the comparison between UK and USA. Barrier to increasing counseling rate are significant, such as difficulty counseling patient on behavior that they struggle with themselves. So this is one of the indicators. If the physician cannot do behavioral, healthy behavior, they cannot counsel for that. Also, long hours, as we mentioned before, if the patient have long working hours, it's very difficult for them to start to do healthy behaviors in their life, and it's in the this will gonna reflect on their practice with their patient. This also study, it's a national survey, personal exercise habits and counseling practice, primary care physician. This study was designed to obtain information about personal exercise behavior and counseling practice of primary care physicians, to determine whether physician specialty is associated with practice. So the cross-sectional study was made randomly selected sample of primary care physician in US. Questionnaire was used to obtain detailed information on personal exercise habits, counseling barriers, and barriers to counsel of the patient, physicians, and regarding both aerobic exercise and strength exercise. The participant was almost 298 primary care physicians, comprising 84 family practitioners, 79 pediatrician, and 58 geriatrics, and 77 internists. Frequency, the main outcome measures, the frequency of physician exercise, exercise counseling, and relationship between both practices. What they found, it's physicians perform aerobic exercise regularly are more likely to counsel their patient to benefit of exercise. So if the physician is doing aerobic exercise regular, they easy to them to counsel their patient for exercise. And especially that physician who's doing strengthening exercise also. Also, they found fun thing that pediatrician and geriatric, they are fewer to counsel their patient regarding exercise compared to family physicians and internists. Counseling regarding strengthening exercise is less common in all physicians. Almost 50% did not advise exercise for any of their patients. Inadequate time was noted also. This is one of the barriers in all studies. 61% and inadequate knowledge, inadequate experience, and by 16% almost, responded at the major barriers to counsel regarding aerobic exercise. So in conclusion for this study, physicians who exercise are more likely to counsel their patient regarding exercise. Inadequate time and knowledge and experience regarding exercise are most barriers and was significant really to prevent them to do the counseling. These findings suggest strategies that might increase physician exercise counseling behavior. This is last study. This was done at Columbia, British Columbia. They are describe the physical activity level of counseling attitude to Canadian undergraduate medical students. So one of the barriers, as we mentioned in the previous study, was inadequate knowledge, inadequate experience. So they choose the undergrad 4th year in Columbia, and they start to do as a course, condensed course for them regarding exercise especially. So 4th year medical student at UBC from 2007 to 2010, total of 546 out of 883 student participant survey, almost 64% Society of Exercise Physiology 2011 recommendation for physical activity. The main outcome measures: physical activity level, relationship between exercise behavior and attitude toward counseling. This is one thing. And the student perception of training in area of exercise prescription. Results, attitude toward the healthy living were related to physical activity level, but the rate of counseling patient about exercise was not. So the 4th year student, when they are receiving this training for exercise, it's reflecting on their lifestyle, but not much on their counseling. However, students who engage in more strenuous physical activity were more likely to receive exercise counseling to their patients. So as a conclusion from this study, overall 69% of the students perceive exercise counseling to be highly relevant to clinical practice. But 86% of through their training in this area was less than extensive, which affect the attitude toward perceived counseling of the patient. As I think here also in Saudi Arabia, you have this issue. Recommendation: encourage more student participant in strenuous physical activity and encourage academic training. And this is the most important in the area of exercise counseling might be important next step in preparing future physicians to effectively prescribe exercise to their patients. Okay, so this most of evidence talk about physician lifestyle and its impact on patient lifestyle and physician practice. Here we're gonna just give you a clue about some programs and interventions about lifestyle of workers and public. Here in this 4-year control trial that address lifestyle behaviors over course of medical student receiving the intervention class of 2003 at Emory University School of Medicine as a healthier environment than did control student. So they put some patients for 4 years on healthy environment with a healthy course lifestyle, and the other hand was controlled student as usual. By senior year, control male reports, and this is really shocking percentage here. It's twice the tobacco use reported by male and the intervention with significant p-value. Also, diet and exercise, behavior and counseling were strongly positively related to intervention. Alcohol was inversely. So the message from this intervention and control trial was done that if we can offer the healthy environment from undergrad as a medical student, because as we said, if you act on the physician lifestyle, everyone will gonna be healthy lifestyle because he is the role model. He is the one who is delivering the message. He's the one who is doing the practice. So if we can improve his lifestyle from the beginning as undergrad student, a lot of things gonna be changed. This the WHO do like promoting healthy lifestyle at workplace. It's called as Be Change, Be the Change, and they have this all like topics talking about diet, exercise, weight management, all these. You can find it if you want to search about it. They have a lot of beautiful ideas actually in workplace that you can offer ladder instead of elevator. You can doing like walking area in the place. You can offer healthy food, all these things. They are doing like competition and all these things in the same workplace. This is also 5 tips to kickstart an employee wellness program at your workplace. They have 5 steps here. Any workplace can use this and start to implement it. And actually, physicians. I can find some program specific for physician well-being. It's not moving. Okay, so some ideas just we can see it here together regarding the physician well-being and workplace. This was done this year. It was Jeddah Move 2022. Everyone was shared, physicians, we shared in that. It was from all health sectors, and also they have kids, they have our heroes, the handicapped, and they have like also our children. Everyone was walking. It was for almost 4 hours. It was very great, and everyone was gathered here just to apply lifestyle. We are physicians was walking in front of our patients, and everyone looking to us as a role model. So we can do a lot of things like this to engage our community in healthy lifestyle. And we have also Hail Move, right? Here as a, yes, we have it. Okay, so as a take-home message, healthy lifestyle decisions are more likely to be adopted when primary source of information is the physician. So we have to act on the physician as much as we can. Physician, personal, and professional health promotion activities are affected by long working hours. So we have to act on the system, because as a physician have very overloading in the work. This is affecting his health, because when you are talking about lifestyle, not talk about only exercise and diet, talk about also the psychological issues and social issues. So this is very important. Inadequate time during the clinic, also this is very important to act on. Lack of knowledge and experience regarding healthy lifestyle interventions would represent the most common barriers. And I think Dr. Muhammad will share with us some points regarding how's the involvement of lifestyle in the training or education, the undergrad and the student or in the curriculum. So this is all what I have. I'm sorry, it's long talk and it's a little bit bothering because evidence review, we have to review the studies together, but it's a message for every physician here. You are the role model and your patients really trusting you, whatever you say. So be a role model in yourself and live healthy lifestyle. Thank you.
Thank you, Dr. Nisari Hamdi and Dr. Saleh Rajhi for this lovely and beautiful presentations. Now we will take a few minutes to welcome. 2 minutes.
Assalamu alaikum. Thank you, Dr. Nasreen, for this informative presentation. And we saw a lot of studies who discussed different culture, different qualification. I think as healthcare providers, we have responsibility to investment in the children to improve the perception, improve the background about the healthy food, healthy exercise, healthy practice. This is very important. You discuss about the high qualification and different culture. There is some lack of knowledge, really, lack of of practice. I think our message as healthcare provider must be investment in the from the childhood, because this child will be growing up and go for healthcare or whatever and different practice. Thank you very much, and really this is very important presentation. We discuss it, and we hope to be implement all the recommendation in this conference in our practice in case.
Okay, sorry. Okay. Thank you, doctor, for this comment. This is really important for the kids, and I think إنه برضه من التحول الوطني من التوجه المرشد الصحي الآن صار حيكون مفروض في كل مدرسة إنه يكون عندهم مرشد صحي. المرشد الصحي يتم تأهيله بworkshops, and I think we are health workers. We can really engage on that to do scientific workshops for these people who are responsible for the health in the schools. And we have Dr. Salih Al-Ansari here, have very huge experience for that. He can give us something. Thank you so much.
شكرا. لا احنا حديثنا عن الاطباء الان، ما المدارس لها قصه ثانيه. شكرا جزيلا دكتور، الله يعطيك العافيه. الريفيو كانت مره مهمه اننا نعرف قديش العلاقه ما بين موضوعين، حركه ونشاط الطبيب وقدرته على الاقناع او قناعته بنمط الحياه. احنا بشر واطباء وان كنا اطباء نعرف كثير من التفاصيل، لكن معرفه التفاصيل لا تغير السلوك، ومنهم من يدخن ومنهم من فلذلك احنا لازم نتعامل مع الطبيب وكانه شخص عادي من الناحيه السلوكيه طبعا، وليس من ناحيه الاحترام والتقدير ك يعني ملاك الرحمه وكذا. لكن من هالناحيه نرجع نقول ما الذي سيغير سلوكهم، ما الذي سيجعلهم اكثر قربا من النمط المعيشي والنشاط البدني والتغذيه والامور هذه. صحيح انه ظروفهم مختلفه، لكن انا اعتقد انه من هالناحيه كل يعني صعوبه اقناع الانسان بان يقوم ويتحرك. والمثال اليوم قلنا لهم الصباح تعالوا يمشوا، مشيت انا ومحمد والدكتوره شوق والدكتور العثمان اسف، فقط اللي من من مشاركي هذا الملتقى اللي شاركوا في المشي فجرا. بس ابغى اقول حاجه، اقول انه من ناحيه النشاط البدني انا عندي قناعه انه يستطيع الجميع ان يدخلوا من الخمول الى الرياضه عن طريق باب المشي. حقيقه وانا اللي يبغى يعني يدخل في التفاصيل دي يبحث في جوجل مقال بعنوان بالمشي نبدا. اذا كان بالمشي نبدا، سواء الانسان كيف يتحرك من الخمول الى الرياضه، لابد يبدا شويه شويه شويه، ولا اجد رياضه تجعل الانسان يصطلح مع النشاط البدني والحركه والجهد والعرق والتعب الا رياضه المشي. وهنا ادعو الى ومن اراد ان يتواصل معي لاحقا لنبدا باقتراح، الا وهو انشاء مجموعات المشي ما بين الاطباء فقط في نهايه الاسبوع، فجر الخميس فجر الجمعه وفجر السبت نسوي شيء مع بعض. وفي تفاصيل وعندي خبره طويله جدا في انشاء مجموعات المشي. وهذا الكلام كمان يجعلني اتساءل، هل عندنا مساحه استثمار في هذا الموضوع؟ يعني حقيقه حتى الاطباء يحتاجون الى الاستثمار، تدريب، استشارات، دعوه، محتوى، فيديو بسيط يربط ما بين صحة الطبيب وانعكاسه على مريضه، تفاصيل زي هذه. هنا أتحدث مع القائمين على النظام الصحي الجديد ولا الرعاية الصحية الجديدة ولا الموديل اوف كير، ونقول لهم هل مستعدين تستثمروا في هذا الاتجاه وتحسنوا صحة الأطباء؟ نعمل سيرش وبنش ماركينج ونشوف كيف الناس تأثرت وتغيرت ما تغيرت، لكن ليس بالوعظ والإرشاد وليس بالدوز ودونتس، لا، في أبروتش خاص. وهنا سنحتاج موارد إذا أردنا أن نحسن النمط المعيشي بلوشي. مرة ما يحصل. وأخيرا يعني إحنا محتاجين لنقاش طويل. هل هم الأطباء فقط الذين يقدمون النمط المعيشي؟ إذا كان هم الذين سيقدمون فمحتاجين استثمار مرة عالي إنهم هم يحسنوا نمط معيشتهم في البداية عشان القدرة على الإقناع. إذا لا والله بنتحدث عن الهيلث كوتش كده ممكن نتنازل شوية ونقول للطبيب الله يبارك فيك شكرا إنك تكتب وصفة صح وعالج صح واهتم بنفسك قد ما تقدر، لكن في الهيلث كوتش هو اللي حياخذ قصة النمط المعيشي. هذا يمكن يكون حل.
شكرا دكتور صالح، الله يعطيك العافية. وقد يكون يعني حضرتك أنت initiate something as a role model أنا أعتبره. يطلع يقول للناس أمشوا وهو نفسه بيمشي كل يوم ما شاء الله، يمكن بتوصل ذيك اليوم قلت لنا كم 30,000 أو شيء. ف when I hear this from physician, I know I have a lot of barriers as we review together today. I have no time, I have a lot of responsibility. But when I see my colleague, he can do it. So I tell myself, yes, I can do it. So أنا معاك 100% في فكرة جروبات المشي، لأنه هذه كثير بتحسن، لأنه بتحفز الفيزيشن إنه يطلع. We need to change our system. We need to have a support as physicians. We need to have a lifestyle intervention, real lifestyle intervention for us as physicians. But again, we can do our best as we have as resources now, and we can raise this, yes. But we can start, yani why not? We can start as much as we can to act on ourselves because it's reflecting your practice. Believe it or not, it's reflecting. You have no that confident to talk about lifestyle if you are not doing good lifestyle. This is real. And when patient negotiate with you until I have no time, I am a mother, I have, you really empathize with her until, yeah, yes, inside yourself, me too. But if you are doing that, you can talk about it very strong, and this is by evidence. So we need this, definitely. We need to raise this to our health system, to have, for example, physicians need to have a coach. A coach, he can help you to implement lifestyle from the beginning. So if you have a group of physicians in any health sector, they have right to have a coach. They have right to have walking area. They have right to have healthy food. They have right to have all these. So I can implement and improve my lifestyle, and this is reflect on my practice. Thank you so much.
Thank you, Dr. Nasreen. It's really interesting to hear this, and I totally agree with you. You cannot change your patient unless they see the changes on you. My comment is, I noticed that we have a hidden problem. Nobody is noticing it. We are, as a physician and as healthcare providers in general, we are treating ourselves. And this is really a problem that we are facing. We are not dropping our ego and go as a patient to one of our colleagues to say, I'm here, your patient. I'm not a physician telling you what to do. Please do whatever you're supposed to do with me. So I have a personal experience. A lot of our colleagues, they are from different specialties. They are so expert in their field, but they know zero or almost zero about obesity and lifestyle. And this is true. And this is there is no shame in this. We have to admit that we have some illiteracy about some of a lot of medicine. So my point is, maybe this could be part of our discussion in the model of care and well-being of the practitioners. we should be really going back to family medicine practice, all of us. And from there, you can build up such a program because you are there, as Dr. Saleh said, that you are a human being before you are being a physician or care provider. And you will be easily talking to your physician, telling your strength and your weakness and the behavior that you cannot change. So I think this mindset will be probably changing the picture. Thank you.
Thank you so much. This is really important, as you said, Dr. Muhammad. And inshallah, we're looking forward with all these mindset here in this symposium. And it's one of the recommendations we can just add on to spotlight on this. Thank you.
Just a quick comment on this. I remember one patient just standing at the door and looking at me straight in the face and said, if you were obese, I would not come to your clinic. I mean, this is the most straightforward statement I ever got. But patients really look at you, how you eat, how you interact. And remember, if they see you in a social setting, it's more powerful than your talk in the clinic. So if you preach what you practice, and it's extremely important, and make sure they don't see you doing things against what you said to them or you instructed them to do. And also being friends with them. And remember what Dr. Saleh said, being human like they are, which is التواضع والخلق الحسن مع المرضى. Physicians have, and providers in general, you have a power to use, but use it wisely. People look at you as a role model, you like it or not. If you smoke, if you eat junk food. Now, also when you have guests in your house, you have Pepsis and 7-Ups and juices and sweets and stuff. Oh, you have salads and fruits and maybe some good protein. And also remember, portion control is very important. I practice that even with our elders, even though they disagree sometimes. They think it's not good not to be very hospitable, put a lot of food on the table or on the ground. But it's very important to practice what you preach. And I've done it so many times. And actually, I broke the taboo multiple times, the hospitality taboo. And I get actually, from when the eldest of the elders, he was not happy. But I got help from the other ones, and they actually got a lot of support, and we changed the way we practice hospitalities in our home. And even with my kids, we do the same thing. So you could do it. It's not easy, but remember, mothers and fathers, physicians and providers, you are role model everywhere you go.
Yeah, thank you so much, Dr. Saad. This is very important, and this was mentioned very clear that your patient can see you in social gathering, and they are just seeing what you are doing. We are still a human being. It's okay, but do your best and at least preach what you are doing as a practice. Thank you so much.
Thank you, Dr. Nasreen. This is Ahmed Al-Saif again. You are talking about two main programs in the new model of care. One of them is workplace wellness programs, which we are pioneering in the Eastern Cluster. There are almost 8 teams now. They are starting their interventions to take care of the healthcare providers, including also healthcare workers, including physicians, allied health nurses, and also admin. Inshallah, we will see the fruits in the near future. There are some interventions without measured outcome, but the well-designed and measured outcome will take place, inshallah, in the upcoming couple of months. This is one. The second one is
excuse me, just which sector? I didn't
Eastern Health Cluster, which is E1 or first health cluster in the Eastern Province. The second one is Walk with the Doc. That was initiated here the first time in the kingdom by Dr. Nadan Naji, also in our team, Keep Well in Eastern Health Cluster. So they invited WHO, and it was registered with Walk with the Doc in the US. Dr. Saleh Al-Ansari also attended the opening ceremony in Qatif Beach there. It was started just before COVID. Several teams worked where a physician and patients went Corniche and walked. So it was started in several cities in Dammam, Qatif, and Gig also. So that was very good initiative, and it created a good atmosphere between physicians and their patients. There was like a small talk before the starting of the walk, then all the team in collaboration with the local walking teams. Unfortunately, that was stopped. Then virtual walking was started as a shy initiative, but did not continue. One of the main barriers that Dr. Saleh have already mentioned, pain point, that what's in it for a physician, for example, for a physician to go and walk and from his or her own time afterwards. So that was a big barrier that may be handled or stopped the initiative from continuing. Thank you.
Thank you so much, and very interesting that your target is health workers, right? This is very important, and we so great to hear from you, inshallah, the outcomes, because we can make it as general practice and experience for everyone. Thank you so much.
I have two announcements. One is that there is a proposal or recommendation will go out. Provinces here, Saudi Arabia, and also from countries in the MENA region, Egypt, and also UAE. And maybe other countries. What I'd like to, from the people who are from other provinces, there is a strong recommendation that will be put up to have lifestyle medicine themed conference. Each province will have 1 month, i.e. Eastern province will choose a month that's suitable for the conference. There will be a theme related to that. So we will be having 12 conferences every year. This is to help you train, to help spread the word, and also get more people involved, and to be really practice what we are preaching now. So kind of preaching what we say, and we say in what we preach, or practicing what we preach. So those from other provinces, and even if you're not really representing everybody there, but you could be the link to your province. So we could move on, because we'll be planning actually in a week time after this for this. The Crown Conference will be, these are the jewels. The Crown Conference would be in Hail once a year. So Hail is will be designated, and hopefully officially designated, as the capital of lifestyle changes, positive lifestyle changes. You could clap if you want. It's really a great idea. And there will be competition. We will measure your outcome. So if you have achieved lower or improved obesity scores, diabetes scores, hypertension scores, and any score related to chronic disease, so there will be a winner every year. Either could be cluster, it could be a municipality, it could be whatever. And also in the recommendation, we'll be asking for designated pathways for bicycles, walking, etc. We need to humanize our city in reality, not just talk. We've seen a lot of that stuff. So I'm happy with the Eastern Province initiatives. And also for those who are interested in research, please let us know. And we need to get contact those are interested from each province. So let me know before the end of the conference or before you leave, please. Thank you.
We will take the last question, please.
Thank you, Dr. Nasreen, for this informative presentation. Me, myself, as a general practitioner who's been privileged to work at 3 different primary care centers, I just noticed that there is a list of mentioning to workload. So me, within working 3 different primary care centers, I've noticed that most of lifestyle coaching that's happening at low workload centers. So the highest one, well, the physicians there weren't really couldn't actually coaching for lifestyle medicine actually. Although even at medium workload center, there was quite mentioning of lifestyle medicine there. So what do you think of workload affecting physicians in promoting lifestyle medicine? Thank you.
Okay, thank you, doctor. This is very important. Actually, it was mentioned one of the barriers of practicing lifestyle counseling with the patient, that the duration spent with the patient is really not enough, and the long working hours. So both the workload and the long working hours was barriers for the physician to counsel their patient for lifestyle, because lifestyle, as you said, need time, need experience, need knowledge, and coaching. And coaching, tomorrow, inshallah, we're going to have a talk about coaching at 8 a.m. It's a long process. So you need time with the patient and you need to act on behavior change. This is very important barrier. Because of that, one of our take-home message was regarding the healthcare system. We need to act on the healthcare system regarding this issue to give a space for the physician to act on lifestyle intervention, which is decrease the whole load and cost for all other chronic disease for the patient. Thank you so much.
Saleh, we'll transfer now to the next section with the moderator, Dr. Talal Al-Bishri. Welcome.
بسم الله السلام عليكم ورحمة الله وبركاته. It's my pleasure to be with you this morning and to moderate this session. Dr. Hassa and Dr. Dina, if you allow me, please, to take 2 minutes. I have announcement. I'm being instructed to introduce a guest for this session. He's very important to be with us. I think he representing more than 7 million people in Saudi Arabia. So he will be the guest of this session. I would like to introduce Mr. Ahmed. He's إذا هنا أحمد. طبعا أحمد صالح الراجحي راح يكون معنا ضيف في هذه المحاضرة، خصوصا أن هذه المحاضرة هي تتعلق بالأطفال. ومن بداية المؤتمر وأنا قاعد أشوف ما شاء الله أحمد في الصف الأمامي قاعد في جانب والده محاضر لهذا المؤتمر، وكان واحدة من الريكومنديشن اللي طلبنا الدكتور صالح أن يكون فيه activities خاصة بالأطفال بالشباب. As we see, there is a concurrent session along with the academic or the scientific presentation. Dr. Saleh and Dr. Farhan announced there is education program for the adults, but I think and I believe there we should have activities or presentation targeting the kids, the children, the youth. And welcome, Mr. Ahmed. Can I ask you about the conference? How did you find it?
It's awesome and it's very good.
أهلا وسهلا فيك يا أحمد. طبعا أحمد مشارك يعني بالمؤتمر وحاضر ويعني حافظ يمكن أكثر الأجندة. وش بدك تقول يا أحمد؟
شكرا أيها الكبار، عملتم وأبدعتم لأجل جيل الصغار. نحن صغار السن كبار الهمم بكم. شكرا للملك سلمان وولي عهد.
ما شاء الله ما شاء الله تبارك الله ما شاء الله. لو سألتك يا أحمد عن رؤية المملكة لها 3 عوامل رئيسية، وش هي العوامل تقدر تذكرها لي؟
وطن مجتمع صحي وحيوي، اقتصاد مزهر، وطن طموح.
الله يعطيك العافية. ويلكم مستر أحمد، وأنا لي الشرف أني أكون مودريتور وبضيافة الأستاذ أحمد. It's my honor and pleasure to moderate this session with the guest Ahmed. And also, I would like to thank Dr. Hassan Dina for giving me this a chance to introduce Mr. Ahmed. The next speaker, Dr. Hissa Al-Husseini. She's a consultant in clinical nutrition, and also she former director of the Ministry of Health for the Diet and Physical Activity Program in Saudi Arabia, focused on the healthy lifestyle, mainly in the primary health care setting. After the introduction with Mr. Ahmed, I think it's leading for this topic, which is optimizing the health in children with the whole food. Welcome, Dr. Hassan.
Good morning, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Salatu wassalam ala Rasulullah sallallahu alaihi wasallam. أنا يسرني جدا أن أشكركم على إتاحة هذه الفرصة لي للمشاركة في هذا المؤتمر القيم، وأتمنى أن أكون مشاركة باستمرار. My lecture is about optimizing children's health with the whole food, basically plant food. I will be touching 4 main points: the impact of childhood nutrition on diseases, adult diseases, nutrition needs, and then I will be touching importance of the breast. I will be touching does a plant-based food affect the children's growth, and what supplements are we needed? And then I will conclude my talk. We know that the children nutrition, our preferences about and the taste, usually it's not acquired, but it's not acquired, but it's that we do it with our preferences, our man-made epidemic of chronic diseases. Early nutrition environment is very important for the infant. It's very important to set up the early nutrition environment that affects the onset of adulthood and the onset of diseases that cardiovascular, obesity, diabetes, and metabolic diseases. Diet and nutrition play a key role in also teeth health, whether it's whether the flesh or the bone itself. Difficulty on the part of some patients to make and sustain healthy changes. So healthy changes or healthy habits is very important to be changed from time to time to be better. Food as a medicine and exercise as a medicine is now the trend. It's defined as a therapeutic method in which food and is used as the prevention and treatment of chronic diseases and non-communicable diseases. I mean, lifestyle medicine is committed to raising what? To raising the level and of competency in food as medicine for the healthcare professionals. We fully recognize the healthful eating patterns not only impact progression for encourage overall well-being and influencing the patient's success in other lifestyle pillars, in other pillars. What's the impact of children nutrition and pediatric disease? We know that the only taste that's acquired is the breast milk, or we are born is the mother's milk. It's only the acquired taste for us. All other tastes are learned and not acquired. Early flavor experience build the foundation for lifelong taste preferences. So when we build it for children, they need to grow up with them. As Dr. Muhammad said, tastes are set by the age of 2 to 6 years old. So when you give your child candies, sweets, then this will stay, the taste will stay with them or will sit with them at the age of 2 to 6. We teach children how to prefer high fat, high sugar, high salt food, and we can do the opposite. So this is our rule, is to do the opposite and give our children more healthier food. What's the impact for children as a cancer? Children food, we know that less fruit and vegetable consumption will be less fiber, and less total plant fiber will be less fiber, so that the more cancer we have. More meat consumption at earlier age is very important, as a lot of colleagues talked about the consumption of high processed food, meat, and more red meat. So this is very important, and evidence-based studies on cancer, nutrition and cancer risk. Overweight also is a problem to get cancer. Higher calories is a problem to get cancer. Also, a person with an early stature, high stature, or taller poverty will get more. It's one of the risk factors to cancer. International Agency for Research of Cancer, what did they say? They said two things: processed meat and red meat. Processed meat is children, they eat every day processed food, hot dogs, burgers, beef, jerky, canned meat, some deli meats. Our kids are eating this every day. There is evidence through enough to conclude that these substances cause cancer in humans. Processed food, a lot of colleagues talked about that. Red meat or mammalian muscle meat there is a long but not conclusive evidence that this causes cancer in people. Obesity and diabetes in kids. We know that obese kids tend to become obese adults. A child obesity health risk, even if they lose the weight in adulthood, they will have the risk of disease. Type 2 diabetes follow as young as 8 years and cuts almost 20 years of life expectancy. Asthma, there is some correlation between asthma and the plant food, and we know the more plant kids eat, the less asthma they get, or sensitivity, actually. Constipation, this is very important. Most of our kids get constipation because fiber deficiency. They don't eat fruits, they don't eat vegetables. RDAs is very small, only 19 grams to 38 grams, but our kids are eating chips and fries. Average intake is 13 grams. They haven't reached the 19 or 38 grams. Inadequate fruit and vegetables is very important issue to be addressed in children, whether it's at home or at school or at college. 60% of kids don't eat enough fruits, and 93% of kids they don't eat vegetables. And I will show you the studies or the surveys in Saudi Arabia. Heart disease also is a big risk factor. We know that fatty streaks can be start as young as 3 years and then getting larger. Sugar consumption is one of the risk factors. How or what are the recommended daily allowance of sugar? We know that the WHO recommend 10% of calories to be from sugar. What do we mean when we say 10%, or how many spoons? It's better to change it to spoons to know how much the 10%. As a maximum, 90 spoons is the maximum for each child to have, even whether it's in, we know that a can of Pepsi or a can of soft drink is 9 teaspoons. Then if he has a can of Pepsi, then that's it. And it's better to have a 5%, not 10%. And the 5% is almost 6 teaspoons. That's it, which means half of a soft drink can. What we mean, as Dr. Weiss said yesterday, it's a balance. We need to be balanced between what we eat and what we exercise and what we don't eat, what to take and what to not to take. We emphasize on fruits and vegetables, fiber, whole grains, whole food, liquids, liquid plant oils, olive oil, canola oil, and we should cut what? We should cut the soft drinks, energy drinks, sugary drinks, all sweets to be balanced. This is my, I love this slide, and it summarizes everything about children nutrition. This slide is it, don't drink your calories. Try to have things from different sources. Our child diet should be good quality, small quantity, and nutrient dense. And what we mean nutrient dense is we don't eat junk food or sugary drinks. As the Prophet Muhammad ﷺ said, ثلث لطعامك, third for your oxygen, 1/3 for your food, and 1/3 for your water. This is Prophet Muhammad ﷺ recommendation. And I am proud to have this recommendation since more than 1,400 years. What's the benefits of plant food? Plant food is high in fiber, lower intake of total fat and saturated fat, lead to be full, and lower fat and saturated fat and cholesterol, higher antioxidant level, and healthy body weight. This is a comparison of the Ministry of Health survey. They had a survey 2013 and a survey to 2019. And I will here talk about how it was shifted from the orange is that 2013 and the blue is the 2019. And we see how it's shifted from obesity to overweight. 2013, we have more obesity. 2019, they shifted to overweight. And I will stress to the two last column. The two last column is about, one is about physical, the last one is physical activity, and the one before the last is about fruit and vegetable consumption. And we have a high column. This is insufficient fruit and vegetable consumption, which is about 92.2, 92.6 or 0.7 in the 2013, and 93 in the 2019, which is almost the same. So we still have, from 2013 to 2019, we still have insufficient intake of fruits and vegetables. What we mean is less than 5 servings of fruits and vegetables. The last one is also insufficient physical activity, which is half an hour, 5 times a day per week. It shifted from 60% to 80%, the 2019. So we're still not getting the right physical activity and not getting the, as the two studies, the national surveys said. What do children need, or nutritional needs for children? I collect this schedule from Mayo Clinic according to age for boys and girls, 2 to 4, 5 to 8, 9 to 13, and then 14 to 18, calories, and then the food groups, protein, fruits, vegetables, grains, and dairy. I will not go through each one, but it's a collected schedule for you to have or to take a photo for this. And we know we start from calories from 1,000 to 2,000. And this one, depending on the child age, depending on the child sex, depending on the child activity level. So each one is different, but this is a recommendation from my clinic as a general. We can calculate the calories from different applications or from different sites. Ministry of Health have a calories calculation site. حساب السعرات الحرارية بوزارة الصحة موجود. Saudi FDA has a site for calories calculation. حساب السعرات الحرارية بالهيئة العامة للغذاء والدواء. Also here we have a USDA calculator down here I mentioned. Then we'll move to the age of 0 to 2 years, which is a child, the newly born to the weaning age. When we look into the breast milk composition, it's the best composition and it's the appropriate one. We see that it's a high carb, high fat, and low protein. Lactose is the main component. Comparing the human milk with the cow's milk, we know it's almost 5 times more protein. The cow milk is 5,000 more protein. And whey ratio. We know that the more human milk with the whey ratio. 7 times the casein is the cow's milk. Here we are comparing the fats. Saturated fat, we see the saturated fat is more in the cow's milk, and the mono and polyunsaturated is more in the human milk. Also for the minerals, calcium, iron, and all other minerals, it's for the human milk, it's appropriate and in some good proportion, whereas the cow's milk is different. What's an alternative for cow's milk? It's a soya milk. Soya milk is a good alternative for cow's milk, but there are some contraindications for this. It's a nutritional equivalent. The American Academy for Pediatric Soy Formula said that soy formula are safe and appropriate for full-term baby. So preterm, it's not recommended for preterm baby or low-weight baby. Nearly 100 years of use, best alternative breast milk. Adults who were given soy formula, there is no biologically significant findings in terms of general health or cancer development. Not in the first year. It's recommended not to take the soy milk in the first year. Breast milk is the best. After 1 year, it's totally fine. We can absolutely be part of the healthy diet, unsweetened, and it's from 1 to 3 years. Choose a nutrient-dense option, which is soy. The last question is whether it's a plant-based diet affects the children's growth. Does it affect the growth? The real story is any inappropriate diet is not, regardless of the source, whether it's a plant or an animal or junk or whatever, it's not it's not a healthy food. Any inappropriate diet, whether it's in quantity or quality or whatever. Study shows that focuses on a single food and not nutrients or a whole diet is the reason for that. Short follow-up. Usually studies with these things, they have short follow-up. Optimizing bone health. How to optimize bone health? Adequate calcium intake. Usually any child have lower intake of calcium. Weight bearing exercise. Exercise at this age is very important. Whether it's strengthening or moving or stretching, especially in childhood. Adequate vitamin diet is important. Sun is the best. Low sodium diet, avoiding excess dietary protein, especially animal protein. Lots of fruits and vegetables as a fiber for conservation and health. Optimizing bone health again in kids, get outside every day. It's very important to play outside and not to use the social media so much more than 2 hours. Play 2 to 3 hours every day. Plant-based diets and the calcium-rich food. When we say calcium is not enough, the calcium plant-rich food is the beans and the greens and nuts, seeds and the seeds. Do plant-based kids get enough iron? Usually iron deficiency is there whether you are taking plant or not. If you are not taking a variety of food, you will get iron deficiency. Vegans and vegetarians do not have higher rates of iron deficiency. Plant-based kids meet the RDAs of the recommended daily allowance, often more than the omnivorous kids. Higher intake of vitamin C will increase the absorption of iron 4 to 6 times. So it's very important to have vitamin C with the food when we eat it to increase the absorption of iron. Factors for iron deficiency. It's very low in iron. Usually milk, one of the questions we get in the exams or we take in the exams is milk, does milk have iron? Milk is a 0 iron and it affects the absorption of iron. Replaces calories from healthier foods. It's better to take fruits and vegetables better than taking dairy. Interfere with iron absorption from other foods. And the daily intake will be beans and greens and fortified grains. Do plant kids need any supplement? We'll say B12, the only source for B12 is animal food. So usually B12 is the one we need for supplement. Vitamin D, if the children get a sun sitting, then they will be okay, or if not, they are inside, they will need a vitamin D as a supplement. Probably omega-3, the iodine only when we are not using the iodized salt. If we are using the iodized salt, it's enough. Beverages consumption in early childhood, we know that are 0 to 6 months, at least 6 months of breast milk is the best or as a must for newly born children. Breast milk or formula introduced water from 6 to 12 and then start adding whole milk and adding a small amount of juice after 12 to at 1 year to 2 years. 2 to 3 years, water and milk and small amount of juice, 4 ounces, which means half cup, 4 ounces, which means half cup. 4 to 5 years, 2 to 5 cups of low-fat milk. When the children grow, they will shift from whole milk to low-fat milk. And then 4 to 6 ounces of juice, still less than a cup. Restrictions in sweetened beverages. We know that we have policies in taxes on sweetened beverages all, and with that, all of liver milk should be restricted for children, because when they acquire the taste of that flavored milk, then they will get to it, and then the transition of or toddler formula, برضو sugar sweetened drinks, soft drinks, energy drinks, sweetened water, all of these are risk factors for children. Drink with caffeine and low-calorie sweetened drinks. Plant-based milk only when medically indicated. always ask your doctor about plant-based milk. We have 3 types at the market, 3 types of juices. One is sharab, nectar, and asir. صح? Sharab, which is a drink, is only 10% juice. Nectar is only 30% juice. And the juice is only 70% juice. So read the label. It's very important to read the label, whether it's a drink or nectar or a juice. The whole food plant-based pyramid, we have here fruit and vegetable at the base, and legumes and whole grains after that, and the nuts and the seeds at the top. What do we mean we have when we say legumes? Legumes, we mean beans, peas, and lentils. And when we say whole grains, which means الحبوب الكاملة اللي هي احنا نقول oat, millet, buckwheat, كل هذه we whole rice, wild rice, brown rice, كل هذه whole grain. We know when we did the study 2013, the highest countries, حائل was one of the highest countries in diabetes. But Jazan was one of the lowest countries in diabetes. Why? Cities, I mean. Jazan is one of the lowest cities in diabetes because they are using millet flour and not white flour or brown flour. Consider these nutrient-dense foods. We know the groups, the fruits and the vegetables, and we know the importance of spices, these things, and the importance of drinking water, drinking plant food, tofu, and all plant food as basics. We conclude that we aim in a lifestyle medicine to limit your child calories from what? From added sugar or saturated. Check the food label to see the added sugar. Any juice, even if they say 100% fruit juice, check the label for added sugar. Saturated and trans fats, unlimited saturated fats. We should read the label again to see the BHOs, partially hydrogenated oils. We know that policy in Saudi Arabia now to quit the BHOs, but we still care about the saturated. And the more, when we choose oils, any oil that's hard at room temperature, it's saturated. Most oils, which is liquid at room temperature, it's unsaturated. Sodium is the most children everywhere have with chips, fries, and it's full of salt. So we should check the nutritional label. So we should, the risk factors are sugar, fat, and salt or sodium. And thank you for being a good listener. And thank you for giving me this opportunity. This is the references. Thank you.
Thank you, Dr. Hassa. It's such an important topic. Any question, please? Any questions?
Thank you, Dr. Hassa. I just want to share with you a real life experience. When my daughter, she is going to school, I suggest to her to get a snack full of what you are suggesting, fruits, vegetables, and so on. She went to the school and she came back crying in the, in the afternoon, but because all the kids, they just laugh at her. And she said, I will not take this anymore. I want to take as what they are doing. So my comment out of this, I think we don't need just only to spread this evidence-based knowledge that, as we know as a professional, we have to tackle it from different point of view. And maybe Dr. Saleh Al-Ansari, he has a huge experience in the school health. So I think from the school perspective, the psychology of the student, especially in those young ages, need to be taught differently. The media maybe has a lot of things to do in this. The stereotype of the child who is taking food from home is really being distorted. So I think we need to reshape the picture to the correct image with the healthy advice. So I want your comment. Thank you.
I agree with you on what you said, that it's, the children will be laughing. And the same happened to my daughter. I let her prepare her food by herself and choose what she wants. And then try to give her just recommendations of what she do. But I know this is a big issue, and I agree with you. And even wearing glasses, if a child wears glasses in school, they will laugh, not just the food. Anything strange, they will be laughing, you know. So my recommendation is to follow your child, to give him the confidence, and to let him go on what he's doing, in spite of what others are doing.
Thank you so much. I have a comment, if you allow me, please, Doctor. Yesterday, I had a funny story. And it was a dinner. I was very hungry. I selected a big portion food. And then when I saw Mr. Ahmed, he selected a vegetable and he's very young. I say, oh, I'm ashamed. So I try to hide from him, just not to see me, because he selected a healthy food more than I. So now, I think it's retainable. What we teach our kids and children, it will go back to us. Even so, you can see me, I have a little bit tummy, so I increase the weight, I gain weight. And then when I see the kids and the young, and they are more than healthier than us, they inspiring us. So do you have any comment about this, Doctor?
It's a habit. That's why we need to change our habits. So for Ahmed, it's a habit. For you, it's a habit. So to be close together. Yeah. Yeah. So you need to change your habits to be better. Yeah.
Shukran, Dr. Hassa. Thank you so much. And now we will move to the next presentation with Dr. Dina Neef. Dr. Dina will discuss about the Saudi Arabia Quality of Life program. It's an amazing topic. We have been talking about the quality of the life among all the quality of the life for children. So this topic will be the quality of the life program, housing and healthy lifestyle focus policy and the projects. And I think we will get some recommendation after this presentation. Dr. Dina, she's currently working at Diabetes Fellowship at King Saud University Medical City. Welcome, Dr. Dina.
Assalamu alaikum jami'an. I am truly honored and pleased to be here with you today. I will be talking about Saudi Arabia Quality of Life Program, healthy lifestyle focused policies and recommendations. Like Vision 2030. Vision 2030 is a turning point our country has witnessed. It is a remarkable transformation plan towards a better Saudi. It is truly a dream coming true. Do you know that this year, 2022, it marks the 5th year anniversary for this vision? As we can look around us, please, you can see whatever has been happening around us. It shows the commitment and the devotion towards achieving 2030 vision and goals. Speaking of which, to achieve 2030 vision and goals, there were 13 programs that has been established under the name Vision Realization Program، برامج تحقيق الرؤية. أهم هذه البرامج اللي تهمنا إحنا وتهم هذا المؤتمر ما يلامس أو يحاكي نمط حياة الشخص، ألا وهو برنامج جودة الحياة. باختصار، Quality of Life Program aims to provide all the conditions that make the kingdom an ideal place to live for citizens and residents, and aims for all the people to simply enjoy a healthy and a happy life. The program has two main pillars: enhancing an infrastructure and lifestyle, and has set targets and initiatives to make Saudi Arabia one of the most attractive countries to live in. The program has focused into two main axes اللي هو livability and lifestyle. Livability باختصار whatever comes under it, the basics of living, starting from housing, healthcare, public transformation, economy, security. Lifestyle, on the other hand, comes under it sports, heritage, culture, arts, entertainment, recreation, and social engagement. As we come at this point, we all agree that the lifestyle of an individual is composed of bits and pieces from the surrounding of this lifestyle, okay, which were defined by the 7 pillars of lifestyle, which Dr. Salih Al-Rajhi has spoken in the first session. Programs, initiatives, and events that have been happened under the name of Quality of Life Program has touched some of these pillars. Some projects worked on enhancing physical activity, some worked on enhancing MVA reduction and prevention, and so on. Like, where are we now? Where are we now from these projects? Let's take a quick glimpse on what's happening right now. Sports Boulevard now it's under construction. It is the amazing 135 kilometers across Riyadh. King Salman Park, one of the largest park in Saudi Arabia and in the world actually, is happening now in Riyadh. Green Riyadh and other green provinces such as Jalajal al-Khadra, Ramah al-Khadra, Sdair al-Khadra, all to increase greenery. Sports initiatives and events such as Marathon, Formula E, all to promote sports in the community. Charity initiatives, which has added a really valuable social value and a great impact in order to enhance social connectiveness. The Saudi Food and Drug Authority policies that has been set in order to reduce sugar and salt in food, fortifying food with vitamins and minerals, displaying calorie information of food and meals in the restaurants and coffee shops. Okay, I believe now that we all agree whatever has been done or under the process of doing is really amazing. But how about we have more? Our goal at the end is to optimize the quality of life more and more, from better to the best, ومن عظيم إلى أعظم بإذن الله. So hereby, I will present for you some recommendation in the name of lifestyle medicine point of view, in order we can aim to reach this target بإذن الله. By touching the recommendations for each pillar, I noticed that they all work as a domino effect. Each pillar has an impact on the other domino, okay? And with the last domino effect, and the last outcome is to have the best quality of life. Right. Let's start with the recommendation of the first pillar. How about we have more physical activity? How about we stay active as much as we can? How about we involve it more in our daily routine? يعني مثلا, if I decided to be physically active today, ما يحتاج والله I go to the mall, will I go to a park, will I go to one of the ممشى يعني تبعد عننا 20 كيلو. فرضا أنا ما عندي سيارة، فرضا I don't have the time، فرضا بكل بساطة الظروف ما تسمح، إيش ممكن نسوي؟ أشكر دكتور صالح الأنصاري, he brought it up in one of his sessions, in one of his lectures. we need to enhance our neighborhood, our comfort zone, our residential areas. How can we do that? Let's keep expand our imagination more and more and ask ourselves, how can we do that? Like, how about we have walking lanes, walking pathways, starting from our doorstep, starting from our very first footstep, taking us to different destinations, to the pharmacy of our neighborhood, to the grocery store, to the supermarket, to different destinations. And those walking lanes to be safe, shaded, secured, paved in order to enhance and encourage more physical activity. How about we have more trees in the neighborhood? Trees to increase the shadiness in order to enhance the walking in the neighborhood, to enhance the air quality, to enhance the temperature. Hence, we will have more physical activity. How about we get more gardens? Yesterday, I had a comment, and I was really pleased to hear that, because I agree as well that we don't have enough gardens or parks in the neighborhood. I know we have them, but maybe they are not enough. They are not fit for all the neighborhood residents. How about we add more fields for different sports, and let's be creative in that. Paddle, soccer, tennis fields. Let's be creative, and you can name it. Last but not least, how about we have one gym for each neighborhood, and this gym will have a free membership for each individual. في النهاية إن شاء الله ما راح يكون في عذر لأي أحد for not joining the gym. And of course, we need to increase the awareness campaigns towards physical activity. We need to involve the community. We are setting these recommendations, but we need for the community and us as well to react to this by using digital campaigns, the social media impact, advertising. And remember, no one size fits everyone. That's why we need to diversify the options around us in order to get everyone to be physically active. Like, moving to the second pillar, diet and nutrition. Our land is truly, we have treasure in our lands. We truly have what it takes huge landscapes, motivated owners, motivated and hard worker farmers. Why not we take an advantage for that? Why not having a financial governmental support for local farmers instead of importing expensive organic food, to utilize the local resources from landscapes to motivated hard workers, owners and farmers, so we could cut the cost on the government from importing organic expensive food, and to cut the cost in the consumers as well from buying these expensive products. As Dr. Rihab mentioned before, and she made it easier for me, food labeling. Food labeling, okay, translation to Arabic has been done, but how about we simplify it more, we clarify it more, and we do not include any jargons in that. Like, what do you think about the social media impact nowadays? I think social media impact is really astonishing. How about we use, or before that, social media influencers could really convince large segment in the society, either in a direct way by using advertisement to any specific restaurants, any meals from the restaurants or others, or in a direct way by displaying their routine publicly. So how about we target those people and encourage them to send the right message in dietary habits? Okay, recommendation number 3, we just talked about it. I'm glad that our guest is Mr. Ahmed in that. Like, what you eat is what you become. Younger generations are the future of this country. Teaching this concept in a younger age will be very, very beneficial, as statistics has shown really unfortunate numbers of chronic diseases in younger age. Now we can see type 2 diabetes, dyslipidemia, obesity in a younger age, which is really, really devastating. So our recommendation is, how about we start dietary habit awareness programs from younger generation, include lifestyle medicine curriculum in Ministry of Education, where it gets to be taught from a younger age and a younger grades going onwards. I'd like to pause here and share a personal story of mine. When I was back in high school, I was really not proud of my dietary eating habits. تخرجنا وخلصنا ودخلنا الجامعة. in my first year of college طلعنا للدنيا وتعرفنا على البنات. واحدة من الزملاء تعرفت عليها who happens to be my very best friend now. In our first break, my subconscious mind just went to get a donut. When I looked at her, I saw her holding a salad. I looked at her, I was very amazed. I said, Reem, are you seriously eating a salad? She said, yes, why not? I said, no one's around you. Your parents are not around you. No one's is forcing you. Why are you eating greens? This is really strange. She was really laughing and she said, Dina, simply because I got raised and I got used to it. Since I was a child, we did not have any junk food on our table. It was off the table. Junk food, fast food was not considered as a reward on weekends or reward in doing anything good. So it's really what she got used to. And this has been ringing in my mind, and I really saw the effect and the outcome of this when she got older. And we really need to stop overfed, undernourished situation, which is مو معناتها ياكل أي أكل يشبع خلاص تمام راح ينمو. لا، لازم نحرص أن الأكل يكون فيه قيم غذائية. طيب، هذه نقطة ثانية. And I'm glad it was bought in this conference. What do you think about our food traditions? Dr. Salih Al-Ansari shared a really lovely story with us on our first day. Our food tradition, للأسف, is all involved about الذبايح ومفطحات والموائد كل ما كانت included ما لذ وطاب كل ما كانت أزين. وللأسف it was maybe some of the communities you label a person as being generous if he added more and more and more on the table. We really need to revert cultural traditions and how to start from our own personal or from our own houses and our personal occasions. We need to redefine generosity into healthier ways. As the story, if you don't mind, Dr. Salih Ansari, I share it with them. Dr. Salih, he had a guest one before and he said, بشارك معك 10 كيلو مشي بدل ما أشاركك ب10 كيلو لحم. يعني هذه صراحة أشكرك عليها إنك سبقتني على الريكومنديشن. وبداها دكتور صالح. طيب، sleep health. Do you know that the National Sleep Foundation guidelines advise that healthy adults need between 7 and 9 hours of sleep per night? By the raise of hands, who is following this recommendation? من ينام 7 ل 9 ساعات في اليوم؟ ما شاء الله تبارك الله، بس يعتبر لسه يعني قليل مقارنة بالحضور هنا. طيب, do you know that sleeping less not only affect your ability to function, a body function and your brain to function, it also is a serious condition. It really leads to serious conditions such as hypertension, dyslipidemia, obesity, and diabetes. So it's really serious. Here we can see the domino effect. When you sleep well, you will eat well. We will not get hungry at late hours at night, and then you will lead to just an easy or fast cooked meals or أي من الجunk food أو الفاست foods. When you sleep well, you will stress less. When you sleep well, you will focus more. You will concentrate more. And so hence, we will get even lesser road traffic accidents. When you sleep well, we will have more spirituality. كما قال الله في كتابه الكريم: وسبح بحمد ربك قبل طلوع الشمس وقبل الغروب. وفي آية ثانية: إن قرآن الفجر كان مشهودا. ديننا الإسلامي يشجعنا على القوم بدري والنوم بدري. How can we achieve that if we did not sleep well? طيب, how can we achieve that? How about, يمكن ما يعجب بعض الحضور هذا recommendation, بس how about we close non-essential commercial services in an early hour. ممكن نبدأها من الساعة 10 أو الساعة 9. يعني shopping malls أي شيء unnecessary نقفله. هو ما راح يصير حظر, بس at least we don't give the people a reason to stay up late. Of course, we need more awareness campaigns. We need to direct digital campaigns, TV ads, school campaigns, pamphlets. We enhance and enforce the importance of sleeping early, health consequences of sleeping late, important role of healthy lifestyle on sleep health. When you be more physically active, you will get a better quality of sleep. When you eat well, you will get a better quality of sleep. We change the cultural habits. على سبيل المثال بدل ما we serve dinner on a late hour الساعة 11-12 we try to make it earlier تقريبا مثلا على الساعة 8 أو 9 نبدأها فيما بيننا. طيب, this is a really interesting recommendation. I'm really excited to share this with you. How about we promote this idea in Saudi Foundation Day. هذا اليوم احنا صراحة متميزين فيه وأنا متأكدة كل الحضور فخورين بهذا اليوم. How about أننا نحيي جميع عاداتنا وتقاليدنا. I'm sure our ancestors did not used to sleep up late. They sleep early. فبدل ما نخليها only targeted to fashion الواحد بس يلبس التراث كذا ليه ما نخلي هذا اليوم أن نحيي فيه جميع عاداتنا وتقاليدنا. طيب. Pillar number 4 substance abuse prevention. احنا طبعا from a lifestyle medicine point of view our aim دائما أبدا is to eliminate tobacco and other substances completely. So our recommendation is to follow the concept that is known as environmental prevention, focusing on changing the community conditions or policies so that the availability of substances is reduced as well as the demand. In the literature, do you know that 70% of substance abusers in Saudi Arabia were from the age of 12 to 22 years? I was really amazed by this fact. So we really need to introduce school substance use-oriented classes to these students. And of course, we include the other age groups and involve the community, taking advantage of the media efforts, community-wide awareness programs as well. الله يسعد دكتور صالح أعطانا statistics في بداية المحاضرة في أول lecture بس ممكن نذكر الجميع. WHO has reported in Saudi Arabia the percentage was 8.75 of total death was due to road traffic accidents. It is really a high percentage. And it was ranked, تخيلوا, it was ranked as 32 from all the countries in the world. طيب, I am sure whatever has been happening due to that اللي هو مثلا ساهر cameras والrules والregulations اللي قاعدة تصير والfines كلها ساعدت in decreasing the road traffic accidents, but not to the aim that we are aiming for. So what we really need to have is a mindset reframing in which we need to tell everyone that it is not about reaching your destination as fast as you can or getting to your destination without getting any fines. ما هي بسالفة انك تجمع قروشك وفلوسك في جيبك، لا. It's about getting to your destination safely. How can we achieve that? By continuous and enforcing the continuous safety awareness program, starting from the process of issuing the license and afterwards. Learning how to drive is a thing, but learning how to drive safely is another thing. So, as I said, Sahar camera is doing a really great job, but how about from one camera to another? The road rage اللي قاعد يصير، الناس تسقط على الناس، والعاد احنا حريم فبدينا نعرف وش قاعد يصير في الشوارع. واحد ما صار يستخدم السيجنالز، تصير مفاجآت صراحة عجيبة. How can we control this? I know high-tech initiatives has been doing a great job, but we need to do more. How about we double the presence of traffic officers aiming for more road control? Like, this is a really interesting recommendation I want to share it with. It is a fact that people do react differently. في أحد يجي على الصعيد العاطفي، في ناس على الصعيد العقلي. فهذه recommendation, along with the fine ticket any driver could get by crossing any rule or regulation, how about we include a customized message to the person based on the fine. مثلا, let's get creative. واحد قطع له أخذ مخالفة by exceeding the speed. طيب, تجي له رسالة من المرور تم إصدار مخالفة كذا كذا، أظن هي 150 ريال أو السرعة 300 ريال، ممكن واحد يقراها يقول اوكي طيب ان جتني فلوس او قروش بسددها ان شاء الله، يمكن ما تاثر فيه، حرفيا ما تاثر فيه. Why not we include a customized message in the message itself. مثلا we include a statistics on people died from speed. يمكن هذا تحرك مشاعره شوي ويتلحلح ويتحرك ويخاف مرة ثانية he cross the speeding limit. Another example, واحد مسك جواله وهو يسوق وجته مخالفة. كم المخالفة مسكت 500؟ طيب يمكن 500 ما شاء الله عنده قروش واجد وما تأثر فيه. طيب ممكن we include a fact or a phrase in the message that driving a vehicle while texting is 6 times more dangerous than intoxicated driving. تخيلوا. And this was reported by the National Highway Traffic Safety Administration. So be safe. ايش رايكم بالرسالة؟ طيب ممكن نربط الآن ما شاء الله كل شيء مربوط بأبشر ومربوط والأمور هذه كلها. ممكن نعرف إذا الدرايفر كان عنده مثلا عائلة أو شيء، نحرك مشاعره بهذا الموضوع. قطع إشارة مثلا for not wearing a seat belt. ممكن we include what is more important, seeing your family or not wearing your seat belt. طيب moving forward, morality and spirituality. كما قال الله تعالى بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. إلا الذين آمنوا. تدرون كم مرة ذكرت كلمة الإيمان ومشتقاتها في القرآن الكريم؟ أعطوني كذا يعني رقم. دكتور صالح قال 250. مين عنده رقم زيادة؟ يلا بي كريتيف، ارموا لي أي رقم. كم؟ 500؟ أخليكم كريمين شوي. كم؟ 800؟ صفقوا له. صحيح، ذكرت كلمة الإيمان ومشتقاتها في القرآن الكريم اللي هو معجزة من رب العالمين 800 to be specific 11 مرة. يعني لو أنت فتحت القرآن في كل صفحة إلا ما راح تجد كلمة الإيمان. وهذا يدل على أهمية الإيمان اللي مفهومها واسع وكبير جدا. يجي تحتها المفهوم اللي احنا يهمنا في هذا المؤتمر، الإيمان بالله طبعا أولا وأخيرا، التفاؤل به، حسن الظن به، واليقين بالله سبحانه وتعالى. وعملوا الصالحات. عمل الصالحات يعني مفهوم واسع جدا. من أهمها اللي احنا يهمنا في هذا المؤتمر مكارم الأخلاق. احنا يا رب لك الحمد عقيدتنا، ديننا، وطننا، ديارنا يا رب لك الحمد ربي ميزها بأشياء ما هي موجودة في ديار ثانية كثير وبلدان ثانية كثير ولا يهونون طبعا الجميع. ربي ميزنا يا رب لك الحمد بصلة الرحم، بر الوالدين، حسن الضيافة، الإحسان إلى الجار، حقوق الجار، وأمور غيرها مرة كثير. And all of these has enhanced into empowering وتعزيز الروابط الاجتماعية فيما بيننا. بس إحنا يهمنا في هذا البيلر كيف نقدر نعزز الروابط هذه أكثر وأكثر. How about we allocate a community center in each neighborhood. يكون كذا common center in each neighborhood to be يعني targeting مثلا gathering كل neighborhood residents into مثلا special occasions, religious occasions. How about we encourage those people more into مثلا sharing their success stories and مثلا aiming in any of these pillars. يعني مثلا واحد ما شاء الله نقص وزنه 50 كيلو يشارك بقية الأفراد بهذه القصة، فأكيد اللي ما حيعزز وحيشجع فيما بينهم. Of course هنا كمان يجي دور الكوميونتي as well in the other pillars. We increase the community awareness campaigns to enforce the importance of helping each other and do more volunteer work as it has a really rewarding and really satisfaction feelings from it. And this is not for human beings. This concept includes all creatures and planet Earth as well. أنا مبسوطة جدا من هذا المؤتمر أنه هو eco-friendly، فهذه بإذن الله بداية. بإذن الله we aim for more eco-friendly programs, conferences, events, schools and more to achieve that بإذن الله. Another concept in morality and spirituality, and it has been touched in this conference, we need to know that human being is more than just a flesh. Human being is composed of mind, body, and spirit. Meaning our wellness comes not from physical health, but from mental health and spiritual health as well. So it is important to be looked at a person that he is more than just a flesh. Here come the role, and I want to stress on that. For all healthcare workers to deliver the full holistic care to their patients, to not be robots only مثلا خلاص المريض يدخل يلا fill the prescription يلا اطلع, to not treat the symptoms, to look at the patient as a whole, to take care of the patient as a whole. الحمد لله جاء السب سبيشالتي اللي ركز على هذا الشيء اللي هو اللايف ستايل ميديسن. So why not to allocate all training physicians from all medical practices into having lifestyle medicine in their practice, as believe it or not, and it was touched before in this conference, it does prevent and it does reverse chronic diseases. As one doctor once said, we need to change the role of the patient from being passive recipient of care to an active participant in their own well-being and care. This great doctor is Dr. Salih Al-Rajhi. I'm quoting you, Dr. Saleh. We came to the very last pillar, stress management and mental health. Okay, so since it's the last pillar, the domino effect, we're going to see it here. It all comes to this. أقدر أشبهها بأنه هو البيلر اللي قبل الآخر pillar, which is the آخر pillar هو the best quality of life. So we need to optimize and increase the awareness of the surrounding stress relievers. لازم نعلم الناس إن إحنا يا رب لك الحمد عندنا تفاصيل بسيطة حولنا ممكن we define it as stress relievers. مثلا it is highly evident that any mood states and as short as 10 minutes, تخيلوا معي physical activity of as short as 10 minutes ممكن يعدل من المزاج والنفسية. I'm sure any of the people from here do that will agree on that as well. As many experts believe that exercise is as powerful in treating anxiety and mood disorders as antidepressants. تخيلوا. So our recommendation here is to do a holistic health pollution reduction, let's call it that, by including everything. يعني مثلا noise reduction, هنا يجي حتى دور urban planning والneighborhood. Why not to allocate كل scattered community أو عفوا commercial services هذه we coordinate it in one area so we بحيث أن تعم السكينة والهدوء في بقية الحي. يصير خلاص منطقة الإزعاج في مكان واحد. We do air pollution reduction. Factories to be distant from residential areas, implanting more trees, less vehicles, so less pollution. Enhancing each pillar will lead to stress control. I came to the end of my presentation and thank you very much.
Thank you so much for this presentation. And I'm sure there is a lot of recommendation, questions, and discussion for the kind of this presentation. Any question, please?
السلام عليكم. يعطيكم العافية جميعا. Thanks for this one very motivated presentation and very informative for you and also Dr. Hissa. And I have some message. أنا عندي وصلت من الندوة النسائية اللي أمس. Thank you very much. كل الناس من الببليك طبعا حملوني إياها. شكرا لكم جميعا. شكرا صراحة لما ساهمتوا فيه. أعتقد أنه إن شاء الله من ثمار هذا المؤتمر جميلة جدا أنه نخرج صراحة في توعية عامة للناس وبيلدينج أب الانفورميشن اللي عندهم البيرسبشن بشكل جدا متميز. فجزيل الشكر والتقدير عما قدمتوه. جزيل الشكر صراحة عن هالأمور اللي فعلا يعني عملتنا صراحة موتيفيتد هذا الصباح. ابتداء من الدكتور صالح والزملاء بقيتهم والمودريتور والبطل الجميل هذا اليوم اللي كذا أعطانا مسج جميل. فشكرا جزيلا لكم ونطلع إن شاء الله إلى الأجمل بإذن الله في other conference.
شكرا دكتور محمد الزايدي.
شكرا دكتورة ديما، حقيقة عرض جميل وفعلا بيعطينا تفاؤل انه في برنامج خاص بجودة الحياة جوة الرؤية، وهذا كلام مرة جميل. وهذا بس خلاني يخطر على بالي شيء. طبعا الاهتمام باللايف ستايل وبجودة الحياة والأفكار الجميلة هذه حقيقة مرة شيء جميل، إلا أنه أحيانا يأخذنا في اتجاهات كثيرة ومتشعبة وواسعة زي اللي بيتخصص public health. طب لما تتخرج تعمل إيه؟ public health يعني إيش؟ يعني حتتخصص school health ولا حتشتغل لي corporate wellness ولا حتشتغل في research في مضاعف؟ هنا أجي على موضوع نمط الحياة أو جودة الحياة، وأتمنى أن نفكر في الاقتراح التالي: إننا نقيم برنامج ولا ندوة ولا دورة ولا مش عارف إيه في صناعة النجوم، بحيث يكون عندنا نجم في كل قضية ويعطي هذه القضية الوقت والجهد والمهارة خارج العمل السريري. يعني مثلا أنا أكون طبيب عيون، مثلا في المساء ولا في الوقت الفاضي أنا عندي اهتمام بإصابات الأطفال والألعاب النارية والأمور هذه، وهي نظرة إلى نفس تخصصي لكن بوجهة مجتمع. قديش أقدر أسوي؟ وأنا حقيقة تجربتي في موضوع نشر الثقافة بالنسبة للمشي وكذا ممكن تستنسخ بطريقة أو بأخرى، ونتحول إلى شيء نسميه تفعيل الدور الوقائي للعاملين في المجال الصحي. هنا حنلاقي عندنا أبطال في سمنة الأطفال، وأبطال في إصابة الحوادث المنزلية، وأبطال في صحة المرأة، بس نيجي نقول لهم إيش، متى، كيف، أين، كيف تستخدم السوشيال ميديا، إيش المهارات اللي تحتاجها، إيش الدورات اللي إيش الانترناشونال كونكشن اللي تسويه عشان تكون بايونير تو ذا ايدج في الموضوع هذا. هنا أعتقد حناخذ الطبيب زي ما كان يقول لنا 80-20، نبغى ال 20% دي تكون هاي كواليتي ورايحه للببليك، بحيث نحسن جوده الحياه ونجد بايونير وبطل في كل اتجاه. ولو في مساحه للتواصل لاحقا حول هذا الاقتراح اقدر اسوي شيء مع بعض. شكرا.
حابة أشكركم جميعاً على your valuable comments. ودكتورة محمد وينه؟ بالنسبة لشكر أبد، هذا أقل الواجب وأقل شيء نقدر نعمله ونقدمه للمجتمع. بإذن الله بإذن الله نقدم أكثر وأكثر بإذن الله، ونقدر نفيد أكثر وأكثر. بالنسبة لك دكتور صالح I really agree with you on that. ونقدر نقول إن شاء الله يا رب كل مشوار عظيم يبدأ بخطوة إن شاء الله، وإحنا بدينا نبدأ بأول خطوات يا رب إن شاء الله، وإن شاء الله يعني نطمح بمستقبل مشرق بإذن الله وعظيم بإذن الله.
Thank you, Dr. Dina. There is one question from the online. Can we have the online question, please? دكتور عادل العتيبي. Okay. Dr. Adil Al-Ataibi, are you ready, please? The online question. Yeah, sorry, there is a technical issue here for the online question. But can I ask a question, Dr. Dina, about the quality program for in Saudi Arabia? Dr. Saleh Al-Rajhi, for the first presentation, he talked about the enforcement, and he gave us an example of, for example, the Sahel. Do we have any strategy we can do the enforcement for the healthy lifestyle? So we have Dr. Farhan Al-Shammari, the director of the Sahat Hail. I remember when, I think 2 years ago, there is a program called for weight reduction. I think Hail won the first profits in Saudi Arabia for the weight reduction among the employees in Ministry of Health. These kind of the programs for the weight reduction, for the healthy lifestyle, did you believe this can be changed for the quality of the life among the employees and other groups?
بس على اساس يكون السؤال واضح ان شاء الله بالنسبه لي، انت قصدك strategies according to accidents وال MVA reduction بخصوص ساهر او بشكل عام؟ حلو. اوكي. ممتاز. So speaking of which الحمد لله يا رب احنا عندنا حكومة جدا داعمة لنا، والدليل اللي هو انطلاق نظرة 2030 وما يشملها من 13 برنامج اللي كانت تحت برامج تحقيق الرؤية. أحد برامج اللي هو برنامج جودة الحياة هو حرفيا يلامس اللايف ستايل ميديسن بكل السفن بيلرز، في strategies aiming for MVA reduction، في strategies to increase the physical activity، في strategies aiming for diet and nutrition، enhancing diet and nutrition. هذه كلها واضحة بالنسبة لنا. طبعا ما شاء الله كانت تقريبا اللي قاعد يصير الآن كلها ميجا بروجكتس كبيرة، ويعني أحيي الحكومة عليها. بس التوصيات الآن اللي احنا قلناها maybe شوي covers simple details that would really change a lot of the behaviors اللي موجودة among us. فبالعكس التوجه نحو يعني تحسين جودة الحياة من اسم البرنامج، برنامج جودة الحياة. الله يعافيك.
شكرا دكتورة دينا. في سؤال هنا.
السلام عليكم. يعطيك العافية دكتورة. The presentation is very amazing and I would like to share you my experience when I travel the world. I've traveled to Japan, I've traveled to Switzerland, I've traveled and I would like I wish it will apply in Saudi Arabia. For example, in Switzerland, let's say McDonald's. Okay, it's a restaurant, it's a fast food thing, but they don't sell large meals. They sell only medium and small. That's a public health rule, yes, to prevent the obesity and to prevent the chronic disease so far. And also in Japan, okay, we will open trains and buses in the future, but anything new that it's open in Saudi Arabia, we as Saudis are afraid from anything new. For example, in Japan, there is a train specially for females at night to prevent the harassment at night. I hope it will be applied in the future. So me as a woman, I will go out freely and feel safe. I'm so proud in the vision of 2030, and I hope it will be better and better in the future. Thank you so much.
أختنا نوف رفعت توصيات ممكن ندخلها كمان من توصيات المؤتمر هذا. شكرا لك على your valuable comments. شكرا لك.
We have got the last question here.
Assalamu alaikum, Dr. Dina. My name is Ahmed Saigh. I'm a general practitioner, and I just want to make a notice of since, alhamdulillah, we're having this quality of life program running, alhamdulillah. I'm just curious about, since lifestyle medicine is mostly based on diet and eating behaviors, is there anything running through a life quality program regarding running a healthy restaurants, opening, taking initiatives in running healthy restaurants, rather than that we're seeing lately of a lot of fast food chains running, or even had burgers restaurants, and a lot of them are opening recently. So are we, inshallah, in the future seeing any initiatives in running or supporting any healthy restaurants in the future, inshallah? Thank you.
Thank you very much for your question. زي ما ذكرت سابقا quality of life covers تقريبا a quality of life program covers تقريبا كل 7 pillars of lifestyle medicine. And as I showed you from the quick glimpse in quality of life program is an umbrella targeting تقريبا كل المؤسسات والهيئات والinstitutions اللي covers each pillar. فمثلا بالنسبة للدايت and nutrition هنا يجي دور السعودي and drug هيئة الدواء الغذاء هنا يجي دورها وبقوة. فالآن صار في they have implemented some rules and regulations اللي هي مثلا زي ما ذكرت displaying الكالوري information على كل product. هذا يزود الوعي أكثر. تمام. صار في توجه أكثر للهيلثي ريستورانتس للهيلثي ستورز. صار في توسع كثير. وبرأيي زي ما يقولون يد واحدة ما تصفق. الحمد لله الحكومة جدا داعمة والمجتمع يا ربي لك الحمد بدأ الوعي عندنا يزيد بكثرة. فالحمد لله إذا اشتغلنا كلنا بيد واحدة بإذن الله we're gonna aim for that بإذن الله.
I think we have 2 minutes. Any question, please? Okay.
Yes, hello. As we talked about a person's habits regarding healthy diet based on the story that you've shared regarding Reem, if I got it correctly, that was happened to your best friend. What do you think is the best way to educate a person, or let's say a child? Is it enough for them to just practice those at home? Or what else should you recommend to raise awareness in order for the younger children to get used to it when they get older or while growing up?
Thank you very much for your question. What's your good name?
Aiza.
Aiza. So thank you very much for your good question. It was bought, and I'm really glad it was bought before, from comment Dr. Muhammad al-Mansour with his doctor and Dr. Hissa around the habit itself. It starts as a habit. So subhanallah, yani, we get born the beliefs, we're not born with the beliefs itself. We create it among the days and we're living, you know. So whatever has been happening around us, whatever the things that we've been taught of, yani, who said that we have to give as a reward the fast food or junk food, it has to be as a reward? Or who has related fast food being as a reward as an activity in the weekend? We were not born with such concept or such belief. So it all starts as a younger age, as I stressed on, as we grow older. So my recommendation that I really stress on is that you work from a younger age and to try to make it as a habit as much as you can, and simply do not put junk food and just maybe quiz their wellness on that, or is she gonna take the candy or not? No, do not make it available as much as you can in the food and in the house itself, you know. I hope you got the answer.
Any question or comment, recommendation? Thank you so much for listening, and thank you Dr. Dina, Dr. Hissa. شكرا وتحية خاصة جدا لضيف هذه السيشن اللي هو الأستاذ أحمد وبالمستقبل الدكتور أحمد. We conclude to thank Mr. Ahmed for his guest for this session, and he will be a doctor in future. Allah يحفظه ويخليك. Okay, now the next moderator, my colleague Hamdan al-Baghawi, and will moderate the session.
Thank you, Dr. Talal. Assalamu alaikum. Good morning, everyone. My name is Dr. Hamdan al-Baghawi, and I'm Associated Professor at College of Nursing, حائل University. First of all, I would like to thank Dr. Farhan, Dr. Saleh al-Rajhi, and their team for their great job in this conference, such a productive conference. We are really lucky to have it here. And we hope so, inshallah, it will continue in future. And also, I would like to thank you guys for sharing your knowledge with us. As you know, it's part of our responsibility toward our community and society as a healthcare provider. So may Allah bless you. So let's start our next session by introducing our next speaker, Dr. Khalid Abdul Karim, to discuss about the lifestyle medicine application and team-based care training and practice. His current position as an Assistant Deputy Minister of Primary Health Care, a consultant in diabetes and family medicine, the chairman of the Family Medicine Department in the Ministry of Health. He is an assistant professor to diabetes and family medicine at Al-Imam University. So please welcome Dr. Khalid. By the way, Dr. Khalid, he got his PMA from Frankfurt School in Germany. So I must welcome him in Germany. And I said, welcome in. Is it correct?
شكرا جزيلا. السلام عليكم. بسم الله والصلاة والسلام على رسول الله. Thank you for having me today here in this conference. It's always nice being and visiting Hail, and I'm really and truly honored to share some ideas and what's going on in the Ministry of Health right now about the primary health care and family medicine in general. Before I start, I want just everyone to imagine that there is a city decided to stop emergency departments in their hospitals. They said, we don't need emergency departments. And any patient who's sick, if the patient is really sick, will call the ambulance and will be taken to the hospital directly to be admitted to the hospital. Maybe the physicians, if you get sick enough and you visited them, it happened that you are having an appointment with this physician might decide to admit you to the hospital. I think there is an impact in the community. The community wouldn't be happy. We don't meet their need. When they get sick, they need an access to the service. So if you narrow the access, we will have some sort of, let's say, challenge, some sort of struggle to get the service. Let's imagine as well, the same city, they decided not to do any surgery in their hospitals. And they said, if the patient needs to get surgery, we will transfer the patient somewhere else. I believe surgeons wouldn't be happy to work in that city. They only see like an outpatient and inpatient, but they don't operate in the OR. I believe primary care in the kingdom went through a lot of stages, and it was maybe the foundation of the health system. And we all remember when we, the older generation always mentioned that the primary care were called Sahiyah. It was the foundation of the health system. Then there was like an advancement in the hospitals, going to have secondary and tertiary hospitals. And we are really proud about the level of tertiary hospitals that we are reaching in the kingdom right now. With the primary care, maybe it didn't get developed over time, although there was a lot of investment. We have a good network of primary care centers reaching to 2,300 BHC all over the kingdom. But there is something wrong. The community, the same community affected by shutting down the emergency room, in our example, they are not really happy about the service in primary care. Let's admit it. Or they don't know the role of primary care, and I feel this is even worse. Family physicians, most of them, they don't feel that they are practicing family medicine as it should be. So what's going on? What is the mistake, or what is going on wrong in our system. We know all that we are going through a transformation in the health sector in general, and Ministry of Health will stop being the operator, regulator, and payer. It will stay as a regulator of the health system, while we will have the provider as a different entities, and the payer will be a different entity. This is going to make the transformation in the health care much, let's say, faster and toward the needs and aligned to the vision of 2030. What does that mean in the primary care? In primary care, we identified that most of the challenges that we have, it's not related to the resources. It's not related to the access. Yes, we have issue maybe with trust, but we have issue with the approach. Our approach is really reactive. We sit down in our clinics, in the primary care centers, and we expect the community to come. And those who are not coming to the primary care, we don't feel accountable about their health. And this is the way in every specialty, not only in the primary care. The other specialties, they have their outpatient ambulatory care. It's not their job to reach out the community, but at least they should maintain the follow-up if there is a patient having a certain or serious disease. And in case they miss this patient, it's their job to communicate with that patient and to bring and to make sure that the care plan is really implemented. This is sometimes even missed in the secondary. So we looked more in the primary care and we found the challenge is the accountability and in the leadership. If you fix the accountability and everyone in the primary care feel that certain group of people, they will be evaluated based on their proactive and reactive, preventive and therapeutic approach, this going to improve the health of the nation in general. And we need as well to have leaders in these units to train, to observe, to advise, to support these models. So we came with a model that was introduced early on 2022. And we know that what happened in early 2022, it was, let's say, the start of the pandemic. And we can say that most of people in the Ministry of Health were really busy. Myself, I was busy, and I was really truly honored to be in charge of certain projects like the vaccination program, mass testing, and fever clinics. But at the same time, we didn't lose our focusing on the primary care, and we got a real support from His Excellency Minister to start what we call it a team-based care. And then we had the label, we call it طبيب لكل أسرة, to make it much easier to understand the concept while we still keep the role of the whole team work in the primary care as what I'm going to explain right now. So we decided to start to have what we call it the concept of empanelment. Empanelment, it's the same concept we see maybe very clear in UK, in Canada, in Australia, where you have your own physician. And this physician is accountable about your care. So you register yourself with this physician. Every physician will have panel of people registered with him. So the concept, we call it empanelment in general. So we decided to have a team instead of having only physician. If you have only physician, you will ignore the role of nurse, the role of the case coordinator, the role of the other staff. So we said the minimum requirements of that team is to have physician and nurse and case coordinator. In case that we have a challenges in having coordinator, we will repurpose train the staff existed in the primary care center to get more skills in coordinating the care. Coordinating the care means that you will reach people, you will contact them, you'll make sure that they are following their care plan. In case they have a referral to the hospital, you'll make sure that they are following with the hospital. And the health coach, we don't expect to have a role of health educator, but at least we have the minimum information, minimum skills for the nurse and for the physician who is communicating with these, with their panel to improve their lifestyle, to advise them to stick to their care plan. And here I see the lifestyle medicine will benefit a lot from this module or this approach. Lifestyle medicine will be a pillar in that approach. We are not focusing on disease only. We are not focusing on control of chronic disease only. We are focusing on preventive and having a comprehensive approach, a biopsychosocial approach. So we believe if we have this team and we empanel 2,000 to 3,000 persons to that team on average, this team will maintain the continuity of care. They will have an impact on the wellness, lifestyle, chronic disease management, as well as they will have a clear access to the community. And let's imagine that always you have a physician and nurse looking after you, talking to you, reminding you, and at the same time, the other direction, if you feel that you have a question, rather than asking a physician that who doesn't have or she doesn't have any information about your health, you'll ask someone who is having like a full history about your case. We will enhance the connection through this model. We designed the model in a way that we will week, like for 4 hours, to go through the charts and communicating with the panel they have. They have a lady, she's at the age of breast cancer screening. They have a lady, they have a man who's at the age of colon cancer screening, a patient who's obese, a patient who was advised to have physical activity, and they call him to make sure that they are doing the right and plan and they are committed to their plan. All of these going to happen through that team. Does it end here? No. We expect that the coordination and care and integration of the care will be met in that module. And we will apply all the programs, lifestyle, medicine, diabetes program, bronchial asthma program. We will have the guidelines. It will be given to the team. The team should provide the service as per evidence, as per guideline, and you'll be able to measure the impact. Physician and the nurse, on the opposite, will feel proud. They will feel their effect. Rather than sitting in the clinic and having a lot of people coming to you, and the only KPI is number of patients visiting your clinic, and you have no clue whatsoever about your impact on their life, about your impact on the community. So your role will be very clear through that model. Does it end here? No. We need always to look at the whole picture. It's not as easy as what I mentioned, and I will go through the other components of the program. But I want to say why we selected this model. We didn't invent something new. It is applied in other countries, and it was before introduced to be applied in the country, and they called it at that time طبيب أسرة لكل أسرة. At that time, we didn't have enough family physicians. Now we have expansion in the residency training programs. In the pipeline, we have a good number of family physicians, and not being to wait until we have enough family physicians, we will kick off. We will have the existing system. We have more than 7,000 physicians in the network. So they will be trained to run these programs and will be helped by family physicians as well and other specialties. It sounds like I'm ignoring the lifestyle medicine or preventive medicine. No, I'm going to talk about it now. This model has proved itself. A lot of countries applying this empanelment concepts. Some countries, they have more than 90% empaneled population with physicians. And we noticed this during the pandemic. In UK, for example, it wasn't difficult, usually in, let's say, before we start any project and in the vaccination program. We had some session with the international experts before we kick off. And Saudi Arabia was one of the first countries introduced vaccination on the 17th of December, 2022. And when we started at that time, we had discussion with UK, with US, and we remember in UK, they were relying on the family physicians and the primary care, let's say the primary care itself and the GPs there, where they approach the group they had. They know the high-risk people, so they start as per the criteria. And every physician, every nurse working in that practice know clear their role. So that was their building block and their starting point. In our case, we don't have the people registered, so we had to have these mega sites, a lot of, let's say, services provided until we reached in one day of providing more than 600,000 appointments in one day. In one day, we could vaccinate 480,000, more than 1% of the population in the kingdom in one day. And we are really happy that we could achieve a good coverage. It would be much, much easier for us if we have a provider who can really approach and he can prioritize the risk groups, and we cover the vaccination program in much, much easier ways. The benefits are really clear. And the way they panel, sometimes it depends on the geographic location, the nearest center near to your house. Sometimes it's voluntary. If you like just to register with a physician that you like, you can do it. Other countries, based on your insurance, if you are having an insurance with a certain company, you will be able just to register with certain physicians based on their contracts. Some cities or some countries, they just empanel those with chronic disease. And actually, when we started, I had a lot of discussion with my colleagues, family physicians, talking about, no, let's just focus on those with chronic disease. They are missed, they have complications. I said, if we apply this, it means that we are ignoring the healthy ones until they get sick, then we have a very late intervention. No, we have to empanel everyone. And let's start with that. Not to shock you, we started the pilots like any other project. We went to a certain region, and I would always thank this region to support us, although it was in the middle of the pandemic. So it happened in Al-Qasim. And we empaneled 5,000 person in 5 teams in 5 different regions. The basic data showed that 60% of that group are diabetics. Does that mean the prevalence of diabetes in Kingdom is 60%? No. It means that we just retain and follow and reach those with chronic disease, and we are ignoring the healthy ones. And when we dig deep in that 60%, we found most of them, they don't have recent blood work. And those with the recent blood work or blood pressure, we found them uncontrolled. Just a benefit of having just a focus and concentration and looking at a group and having the physician accountable in a certain group, we could pick up all of these issues. As a physician, you have the patient, you treat him very well, you do whatever it takes to treat him during the clinic. But you don't have a clue about what happened later on. In this approach, no. This patient is registered with you. You need to make sure that everything is going on very well. And you need to follow the plan, you and your team in that. The benefit of having such an approach, very clear. It decreases the referral to the hospital. It decreases prescription. There is a better adherence to the protocol and guidelines. There is decrease in the mortality due to stroke and hypertension. There is a significant increase in patient satisfaction, better continuity of care, and there is a better communication between physician and strong relation between physician and patients. It improved the collaboration between hospital and specialized services with primary care. It decreased the admission and decreased the walk-in service and visiting the emergency. By all means, it is really helpful, and we are right now capable to do that. Yes, we were interrupted during the pandemic in our transformation journey, but we could start, and we had a lot of, let's say, gain from the pandemic itself. And we remember the role of صحتي app, the role of توكلنا right now. Leveraging the technology is very important. And this is the one that we are utilizing right now. And we will go really big and depending on the technology in our model. His Excellency, in a press conference related to the budget, the national budget, he mentioned that everyone will have, citizen will have a physician to take care of his health and his family. The evidence was always supporting our planning, and we evaluated other experience, and we learned from their mistakes and from their achievements. A lot of evidence, a lot of resources will talk about the panel size, the way how to communicate, how you measure the risk index for every group, how to reward, all of these things. I advise everyone to read and to look at this, because this is the way we are going to change the care, the primary care and the health system in the coming years. If we look even in the US, they don't have a universal coverage, but they start to have what they call it, it's a group practice where they apply the principles, and they apply now even training for that and setting the strategies and principles. And we have the patient-centered medical home, which somehow similar to what we are talking about, and that will achieve all what we are talking about, the principles of comprehensive care, patient-centered, coordinated care, accessible service and quality and safety. And they as well have a very clear evidence that applying these models will have a better outcome based on that. A lot of evidence, a lot of outcomes. I'm not going to go through this. Now, as we speak, what is our target? What have we achieved so far? In the report of the national budget, which was mentioned as 1 out of 5 achievements of the Ministry of Health, we could register 2.1 million person in our approach during 2022. And His Excellency Minister Engineer Fahd Al-Jladi, in the budget conference, he said that our target to reach 10 million registered population by the end of 2020. Is it easy? Is it only just registering people? If we are going to do that, it's really very easy task to do. But it is much, much complex. We set our targets to be in every BHC. And our target by Q1 to have it in 75% of the BHCs, and in Q2 to have it in every BHC. The other one that we need to reach and register and to create teams to reach 5,000 teams at least by Q3. And to keep registering population until we reach 10 million of those with eligibility to be treated in the Ministry of Health by the end of the year. The good news, parallel activity with this was to introduce the idea and to make it embedded in every other system. So we approach Sibahi to be part of the accreditation process. You have a primary care center and you don't have this approach. It means there is a mistake or you don't meet that criteria. The other thing that we want to adapt program where we report the performance and it's a pillar to be measured for the region or cluster performance. And the beautiful thing that we went to the health sector transformation program to introduce the empanelment concepts. What does that mean? It means, and that got approved, and that's now accepted by all other sectors, private sector, other governmental sectors, that this concept of having everyone in the country having his own primary care team, that you can talk to them, you can communicate with them, and they will be in charge about your targets, preventive, lifestyle, as well as the chronic disease, and coordinating your care is the model that we are implementing right now, and it will happen in the kingdom, inshallah, soon. To go and to reach this, it's not really easy, and it's only building teams and registering population. We want to approach the target group and to conduct basic assessments. Now, in every HIS, in the primary care, the Ministry of Health, we have that clear page where you are going to assess, and it is a mandate on the team to conduct a basic assessment for everyone registered in your panel. By the basic assessment, you'll be able to know what are the chronic diseases, what are the risk factors. We ask about sleep, about diet, about healthy behaviors, about physical activities. We ask about the chronic disease. We ask about your mental states, anxiety, depression. We ask about your behavior. And this information will be a very important and valuable source to know and to get to know the community better and to design your plans and to set your priorities. It's not only doing the assessment, you will do the intervention. So it's a mandate on you if you have like a certain, let's say in your panel, there is kids, they should all of them get the vaccination. For the teenagers, there is like a certain, let's say, assessment or intervention to be done to the teenager that will be counted, and you have to do that intervention. If you got it from the basic assessment that certain number of the group in your panel are having anxiety or depression, you should do something. Chronic disease should be monitored, should be controlled. So if you measure, it's not only having a diabetic patient or looking only to the A1C as a control. No, we want to make sure that you are doing and you are testing for microalbumin, We want to make sure that you are referring your patient to the ophthalmologist. We are looking at the standards and looking at the output and the output. Using different data sources, and as what I mentioned, now, after COVID, we are much, much stronger with our tools. So we have the new HIS rolled out now in Hail, and we are rolling out in other regions. We have Sihhati app where we can leverage communication and assessment through Sihhati. And speaking of Sihhati, now if you are registered, if you are out of the 2 million registered already, the HISs will go to the repository or storage of data that we will have all the data in that repository as a registry, and Sihhati app will read from that. So if you go to Sihhati app, you will find an icon called Tabibi or My Doctor. If you are already registered, you click in, you'll see your physician and your nurse. You'll be able right now to book an appointment, virtual visit or a physical visit. The new enhancement coming soon, if you didn't register, you'll be able to browse the nearby BHCs and you'll be able to register with a physician. Physician and nurse and any other team member will be recognized. Their name, their picture if they want, will be in app. You will be visible as a physician. The enhancement coming after that, which is coming in 1 month from now, instead of, we need to communicate with them. And one of the challenges with what we did so far, they said we can't communicate with them. The landline, we can't call mobile phones. We don't want to use our mobile phones, and we respect this. So how are you going to communicate with your panel? In the app itself, we have the feature of chats. So I will be able as a physician to send a message that will show in Sihhati to my patients to give him an advice, to remind him to come back for certain tests, or to give him or reassure him about the result of tests, rather than having a lot of visits coming back and forth to the BHC for certain. Or the communication wouldn't be only for the physician, even the nurse can send. Any team member in that group will be able to chat with the panel, and it's one of the KPIs that we measure the activity of the team with their community. They need to reach them out. You will be able to broadcast a message. If you are in a flu season and you want to promote a flu shot for them, you will be able to send like a broadcast message to tell them that there is send like an educational material, or to remind them to get the flu vaccine. Maybe even you can send and tell them that I'm going on vacation and Dr. X will cover me during that period. You need to respect that kind of communication. From the patient side, or the person, not patient, they will be able to send messages. You don't need to reply on the same time. We know we want to respect the time for the physician and the nurse, but within like 5 days, you need to react to that message. So instead of searching in Google, talking to a physician they don't know, going to a clinic for just a question, they will be able to ask their physician about what they need. So we evaluate until we reach to the measurement and evaluating the outcome. Do we expect to see an outcome in 1 or 2 years? It's impossible. We are measuring the output, we are measuring the satisfaction, and we are going by the quadruple A's, which is patient satisfaction and experience, and the staff as well satisfaction. We wouldn't ignore the staff. They are the main, let's say, game changer in this project. Second thing, we need to look at the effective care and then efficient care. So in effective care, the standard of care, if it is done, as per evidence, we expect that we will reach to our target. UK BDS, the well-known study done to make sure and to know what is the best level of glycemic control to reach to prevent complication, after 10 years, they were able to conclude that the good control in a certain level was good for microvascular complication, but they couldn't find an evidence or clear evidence for macrovascular complication until they waited 10 more years to get that conclusion. So we don't expect actually to have very clear outcome on certain indicators or mortality or morbidity, but we will have indicators on a standard of care met, a less referral, satisfaction, and having the system much, much better. As of now, we registered 2.6 million. We have 2,273 teams formed so far. And we are every week conducting a random call. We didn't have the app yet up and running to make sure about the communication. So we call through 937 and we ask those registered, do you know your team? Is the relation as active or not? It's not easy to say that I'm going to conduct this project and everything will go smooth. Every region, we have meeting with every region every week, okay, through the team to identify challenges. And certain challenges will be funded, will be supported centrally from the ministry, and certain challenges within the region, and we ask the region just to solve it. There is a 35 parallel activity or project to that team-based care. And team-based care, I believe it is the single intervention that got ourselves exposed in front of ourselves. We assume that we have primary care and the customers will come and they will get whatever they find. No, we want to set the standard of care. We want to challenge ourselves. And now we find and we feel the gap. Not every PHC is having tests for lab. There is struggle to have referral to certain services at the hospital. The referral system is not really helping. The appointment system has certain limitations. The communication between the primary and secondary care is not there. The communication tool between the primary and the community is not there. So that's why we are conducting all of these activities, and we have monitoring to that, and we report to His Excellency about the performance. It's a huge project. A lot of people are working with us in this project, and I say that everyone is welcome to participate. And we initiated what we call the future leaders, where we want all residents, all physicians who feel. And this is what Dr. Saleh said, you need to have stars. We need to have stars, champions, to help, to give advice. And starting with a high level without having much of details during the 2021, we learned, maybe we had a delay in launching the digital solution, but we learned from regions that they have a lot of creativity. We found in Jazan, for example, they went to the tribe leaders and they introduced the ID for them. And they were visiting pharmacies, going to the mosque, introducing the idea. They have the best registration rates in team-based care. And we found a lot of creativity. And that's why we really observe and we learn from what's going on. Second intervention, it's having a leadership. There is a gap. You don't have a leader of primary care that you listen to them, see what are the challenges, you follow the performance with them, and you need, like what's happening with the hospital, you have a chief medical officer and you have departments or chair of departments. We need to have this in primary care. Otherwise, we will not be able to conduct any activity. And that's why we introduce what we call the network. And it's part and it's an initiative through the team-based care. And it's now a mandate. And we are detailing it with the clusters, starting with 3 clusters, then we'll roll it out in the other regions and clusters to have this bigger unit in primary care to know and to compare and to see their performance to the community they are serving. This is going to give a support to physicians, and this is going to give a support to the other medical specialties in primary care were not part of the team-based care. It's really difficult for us to have pharmacists in every TBC. You don't have enough number. And they wouldn't actually have a good, much of work to do in that team. You can't have a dietitian, psychologist, lifestyle physician in every team. But in that network, you will have someone who can serve many teams. And this is their role, will exist through that model, where the team will maintain the relation, but they will get the help and the support from those part of the network, and they have indirect impact on these things. You have someone in your team who has really difficulty, the health coach couldn't reach to a better, let's say, outcome in diet, you need to refer to a dietitian specialized, giving further intervention to help to reach to a better outcome. Then they will bring the patient back to you, and the relation will continue. You'll need to have coordinators to coordinate with the secondary care. A patient having epilepsy with a treatment stable with a neurologist, they just need to see the neurologist once a year. Usually these kind of patients get seen, lost in the system. Neurologists, they don't feel that they need to see them every 3 months, and they run out sometimes their medications, and there is no one is coordinating their care, integrating the services, making sure that they are doing very well. No one is accountable. The system is accountable. But when you dig deep, you don't find anyone in the system is accountable. That's why we need to observe these people and to give the right care for them. These networks will be grouped together in region, but like we are talking about with an eastern region, they need to have zone, مثلا خبر, zone in Jubail. It depends on the choice of the cluster and the region. Then we will have what we call it cluster. And what we are doing, it's something maybe, I don't know if we have specialized physicians, but we are keeping accountability on the hospitals as well. For your community, register with teams. And there is referral from these networks, a certain service in the hospital, let's say neurology. And there is a gap in neurology. The community not being able to get the service because you don't have enough neurologists. While at the same time, you have a lot of vascular surgeons, but you don't need them. It means that there is a planning issue, and it's your accountability in the hospital to provide the right, human resources to serve the community. And this is the way we are going to have the KPI from primary care and from the community on the hospital as well. We wouldn't just surrender that we don't have enough physicians and we stop there. No. We have to evaluate. And it would reach to evaluate the performance. If you have a specialized physician who has only one clinic in the week, while there is a long queue from the primary care to get the service in the specialized care, this is not acceptable anymore. And this is what transformation is about. It's cost effective. We have to have efficient care. On the same time, we will control the unnecessary referral from the primary care. If we provide the right interventions, investigations, images, medications, we will reduce the referral. So we need to empower family physicians and provider. At the same time, we will observe this relation from both sides. So there is accountability on both sides. And this is the way it works. We have an approach and we have the model of care. And please look at the model of care, read about the documents. there is initiatives, there is system of care, and there is level of care. And if we look, primary care become at the fourth layer of that system. We start with activating the person. We need to have the person himself taking care of his or her health. And based on that, the lifestyle medicine is really playing a major role with a lot of interventions. And even we are leveraging Sahhati app as well to have what we call self-care tools, to have certain surveys, to give advice, even games. We might have games and competitions for the young generation as well to enhance their lifestyle modification. Then we go to the healthy community and the activities in the healthy community where we reach schools, we reach out the population, we present. I don't want the family physician only to look at their role. It's number of clinics, and that's it. If you have less patients coming to your clinic while you are reaching the target, I feel this is what success look like in primary care. While you are reaching out, you participate in community activities, and taking care of the nearby schools, as well as this going to be happening with all other specialized people in the network. Virtual care should be leveraged and utilized in the primary care. This is what we aim to have. We want the primary care to be expanded and reaching the community. And the most hated, for me, I hate what we call it, the primary care are the gates keepers. I've never remembered that I was entertaining staying in a gate. I don't look at the gate, I look at what is inside. So if we consider the primary care is the gate and we are the gatekeepers, it means we don't have a major role. And the healthcare is beyond the primary care. Person-centered medical home, it's a home. So healthy ones and those with chronic disease should live in the primary care always in their life. Your relation is existed and continuous always in the primary care. As well, there is a relation between the medical team and population. There is accountability. And this is what we are doing actually in our home. We have a relation and we have accountability. And based on that, we are achieving the target together and we celebrate our success together. Even the primary care will go to the hospital. We don't want to have that wall between the primary and secondary care. The more engagement between the primary and secondary care will be of the best interest of the system and the patient. We always keep principles in our mind. We don't want to be reactive or driven by initiative or driven by a quick win. Principles and start always from the community and individual needs, what they want. Principles related to the principles and known principles primary care, having an access, continuity of care, comprehensive approach, coordinated care, getting the satisfaction, effective and efficient care, equitable care, all of these principles should always be kept in mind. We consider the approach, which is a model of care, and we consider what is already existed. You can't wipe and criticize whatever is existed right now and saying it was, a system failure and you are introducing something. There was challenges solved right now, and you are lucky enough right now when we start that we have a better, let's say, resources than before, and that's why we are moving forward a little bit, and we still have certain resources, certain challenges that someone else will come and to continue and to overcome until we reach, and always the journey wouldn't be let's say, summarize in 1 or 2 or 3 years. Flow of patients is very important. We need to reach to the community. We don't want just to sit. Primary care is not a facility-based, it's a community-based. So this has to be always changed. And the community point of view regarding primary care should be changed. And the physicians in the primary care should look at this in a different way. And soon we will go with a campaign to introduce this model, but we're really waiting the end of pandemic and the vaccination and all the other challenges. And I remember I was presenting to the health system transformation program. And I told them that while I'm introducing this, I'm trying to reach to all the BHCs, there was someone in the ministry is really opposing all of my activities and preventing me to expand. And that guy was myself being in charge of the vaccination program, because I was having conflicts of interest. I need to go and expand. So we were turning and switching some primary care to be vaccination centers, having primary care as Tatamman Clinic. And Tatamman Clinic, by the way, it was a very good example to show how strong our system is. Tatamman Clinic, at a certain time in the pandemic, on month of May, we felt that there is a pressure on the emergency rooms. When we start having more cases, people were really panicking. First case was discovered on March. Cases increased during April. And we start feeling there is a pressure on the hospitals. So we're given order to open what we call fever clinics. So we rolled out 238 clinics in 5 days. And we felt there is, and all the hospitals, even the university hospitals, they told us, what you did, there is something changed. The emergency rooms, not full anymore, like what happened in the previous weeks. Now, we just announced shutting down fever clinics. And inshallah, by next week, we will just merge the activity within the primary care activity. We end that chapter with record of 5.5 million visits to the primary care, to the fever clinics, with only 1.5% referral to the hospital. So it was a good relief to the system. Thank you so much, and sorry for being really talking too much.
Thank you very much, Dr. Khaled, for your informative presentation regarding the Ministry of Health projects and plans. Now we will open the question session. Also, the Zoom participant can ask by raising their hands. So we will start here.
Thank you so much, Dr. Khaled. Actually, I'm really glad to hear this. It is the dream of all family physicians that they are really believing in their specialty. عندي عتب وعندي سؤال. العتب, why don't you tell us about this earlier? And maybe you just answer in the end. But really, people, they don't know, especially the people in the field, from different sectors, not only the MOH. So this is number one. Number two, my question is about the access. You mentioned that anyone can register in any of the team that he choose by going through the app, while the model that's been proposed in the clusters is that the clusters will go through geographical distribution. So is that contradicting? So I just need your elaboration. Thank you so much.
Thank you, Dr. Mohammed. And I'm very happy to see you. It was a long time no see. And we're colleagues for presidency training. بالنسبة للعتب, yes, we want not to announce in a way that we need just to tell everyone about that we are just aiming to do something. We need to take it gradual. Even the communication plan will be gradual. And by the way, this was applied even in the vaccination. The communication was based on the phases that we are reaching. So it is studied not to overpromise, not to overload the system, not to promise something not yet existed, and to set the expectations right. Yes, لكن I would say احنا مقصرين. الفترة اللي فاتت احنا we have to present especially to the medical community our plans. لكن يمكن البانديميك كان really يعني not because we are busy لكن حتى احنا we felt that الناس ايضا busy في الميدان. So they don't have يعني the appetite right now to digest and take المعلومات. الثاني مسألة يمكن registration. Most of خلينا نقول regions they have one cluster. They will be registered in one cluster except جدة فيها 2 clusters والرياض فيها 3 clusters. هذه within the regulations اللي بتكون. لكن as of now احنا we are starting with what we have right now that there is a free access. But it wouldn't continue like this. It has to have certain regulations to monitor and to يعني arrange access إن شاء الله. ما أبغى أستخدم بهذا الشكل. لا يعني في الأخير there is يعني بيكون في regulations واضحة إن شاء الله.
شكرا دكتور خالد على this very informative and promising talk actually. It's a great move and inshallah we're gonna make all of the health it's going toward the vision of 2030. I like a lot of things in the approach. There is virtual and online, and this is really we're gonna decrease the impact on the primary care. So who's really need to be seen, he can come to the center. And also finally we find someone talk about quality of care other than quantity. So number of patients, yes, this is indicator, but the most important is quality and patient-centered care. And if this is gonna be highlighted, we're gonna be a lot of things to be changed as train the staff, and as you said, that the person who is gonna communicate with the persons in the healthy and non-healthy people. الصحة they did the Meccan program and they have health coaches, and one of the rules of this health coaches to reach the community. So if they are really doing their rule and well trained, they're gonna be very great member in the team. My question regarding the insurance. Now there is توجه من الصحة يصير في insurance for every for لكل مواطن. Is it included for healthy people also? Because smoker patients, we're going to need medication, for example, obesity patient, all these lifestyle issues. So it will be included in insurance or not? This is for insurance. And that's it. Thank you so much.
شكرا دكتور. بالنسبة للإنشورنس, yes, it is universal coverage. Everyone will be covered. There's basic needs to be covered, and if there is any further intervention would be done through that. There is a better governance, better costing, billing to observe, and to have the system more efficient. Regarding what you said for health coach, yes, and we have من الجراduate تقريبا 400, if I'm not mistaken, are really effective and active members in this team-based care. And we are getting the benefit right now from that, and we are really expanding with the health holding company how to repurpose and to recruit more. What you mentioned الله يسلمك على موضوع what you found انه السؤال الاول يمكن quality of care versus the quantity. Yes, I wouldn't be celebrating certain regions saying that we had 1 million visits in primary care over the year. This 1 million is missing a lot of people, healthy even ones, are not being approached. And what we are calculating now, it's not a visit, it's an encounter. Physical visit would be an encounter, virtual clinic or visit would be an encounter, a chat or text would be an encounter. We meet that. The purpose is the communication and maintaining the care, not to have someone coming inside the center. تفضل.
دكتور خالد الله يعطيك العافيه، حقيقه عرض مره جميل ومتفائل ورائع حقيقه. بس بستحضر مره كنا في اجتماعات تحقيق الرؤيه الصحيه والتحول الصحي، وجاء الكلام عن الصحه المدرسيه وكيف نقدر نحسنها، فجلس خبراء على الطاوله كثيرين، وفي الاخير خرجوا بتصور، قالوا والله احنا صناع القرار قال اشتغلوا احلموا نقدر نسوي اشياء كثيره مع بعض. فاذا بهم يقترحون ممرض او ممرضتين او ممرضين لكل مدرسه. جلسنا على الطاوله، قعدنا كل واحد بدا خلاص التصويت على نرفع التوصيه ولا لا. في الاخير كلهم رفعوا ايدنا قالوا مره ممتاز. بس انا قلت لهم مره مو ممتاز لانه كده بالشكل ده تبغوا لكم حوالي 24,000 وظيفه جديده عشان تحطوا ممرض في كل مدرسه. خلينا نفكر نرجع ورا مش عارف ايه. صار نقاش على البدائل على السؤال كيف وضعنا مع الكلفه عندما نخلي كل هذا التيم بيز كير رائع وجميل جدا في الرياض وفي شروره. كم حيكلف وقديش حنشتغل على مدى كم سنه عشان نوصل؟ هذا السؤال. السؤال الثاني ماذا سيحدث لو تحسنت الخدمه بشكل مره جميل الى درجه انه جانا عملاء اكثر ومراجعين اكثر، وحقيقه لانه السمعه لما تكون مره ممتازه في القسم حيجيك اقبال مره عالي، خصوصا وان المجتمع مليء ببعض المشكلات الصحيه زي ما انت عارف الضغط والسكر، في بعض الناس ما هي لاقيه مواعيد في المستشفيات، فلما تلاقي رعايه رائعه زي كذا حيصير عليكم اقبال. هنا حنتكلم عن فلو مره عالي، فالكوست والفلو كيف حنسوي فيها بعدين.
طبعا في transformation احنا we are talking about this is a piece of خلينا نقول activity موجوده. قد تبدا الكابيتيتد بادجت للتجمع، والتجمع as per number of الناس الموجودين مسجلين فيه حتكون في بادجت معينه من المانديت على هذا التجمع to serve the primary care as it should be based on principles و KPIs تحقق good patient experience, a certain level of care acceptable and having certain targets. فهي mandate على التجمع انه to serve the community في primary care. واحنا يمكن دكتور انت لانه في مركز سؤال ثاني الان لا البادجت حتكون للكوميونتي. انت you are serving community you are not serving your hospital. وبالتالي انت لازم الريسورس حقتك مبنيه على هذا الاساس. there is target وعندك بادجت وفي جهات تحاسبك عشان انت to reach this. بالتالي مثل ما ذكرت دكتور ومثال جميل واشكرك عليه مساله السكول هيلث. سكول هيلث is an example لاكثر من اكتيفيتي. احيانا احنا as a physicians we are looking always for the best for our patients and we look at the evidence and it's like a wish list that you want to have everything all the medications. لكن لما احنا we look at it on national level we'll bankrupt the system. We can't have all of these في السيستم، وحتى ما لها احيانا الايفيدنس ولا الامبروفمنت على النيشن ولا you will save one extra من 1 مليون مثلا، ولا ما لها اثر على الكواليتي اوف كير بشكل كبير. وبالتالي always هذه الانترفنشنز will be studied من health economics من experts، حتى انه دائما ما تكون هذه المودلز اوفر لودنج السيستم ولا تسوي تعمل بيرن على السيستم. احنا الكونسبت اللي احنا بدينا فيه ليس to initiate something rather than utilizing existed workforce not being utilized the right way. احنا based على النمبرز اللي عندنا already في الرعايه الصحيه احنا عندنا حوالي 7,000 طبيب موجود في الرعايه. if you empanel 2,000 you'll be able to have 40 million. طبعا مو بهالدرجه احنا نحسبها، طبعا لازم تكون عندك. Still we need to recruit more physicians. We need to improve the staff and train them. We have more nurses as well. While التجمع الان بكره انت عليك منديت. based على البادجت اللي عندك والكوميونتي انت مسؤول عنها you might find yourself that عندك overstaff او understaff. So you need to recruit more. You need sometimes to outsource ولا to have a contract for a certain function مثلا until you bridge your gap. أو you might find this أصلاً outsourcing is much يعني خلينا نقول cost effective مثلاً بطريقة أو بأخرى، بس not وليس ابدا على حساب الكواليتي اوف كير، ولا على حساب الاكسس المواطن، ولا حساب التجربه الرائعه. واحنا شفنا حرص الدوله في اللقاحات مثلا، كان من الاشياء احنا نبغى نوصل لنمبر on the same time في عز التحديات يقولون لنا لا تخسر الاكسبيرينس. It is not acceptable ابدا ان يكون عندك مركز فيه تكدس وازدحام وتجربه غير جيده. هذا توجه، هذا ضمن جوده الحياه وضمن الرؤيه، والحمد لله بدينا نشوفها في بلدنا كيف الامور كلها الحمد لله قاعده تتحسن في كل مجال قاعدين نلمسه، وبالتالي هذا من ضمنها. وفعلا you aim for the better and you keep always in your mind the costs، وانه اهدافك فعلا applicable reliable easy to be measured، وانه كل البلانز حقتك ويل ستراكشر، لا تكون فقط انيشيتيفز بدون لا تكون لها تخطيط صح. الفلو اسلمك الله الان احنا نعرف عدد المستفيدين في القطاعات الاخرى، عدد المستفيدين السعوديين اللي عندهم هيلث انشورنس، وموجودين الانشورنس ايضا اللي بيكونوا في الترانسفورميشن انشورد من الناشونال بروجرام. انت بيكون عندك فلو، يو مانج فلو اكوردنج للنيدز، بيكون عندك دائما كل كلاستر والفوركاست اللي عندهم they will study their population through population management يعني health management activities. لين احنا نعرف، وعاده انت ممكن في certain كلاستر عندهم نيدز مختلفه عن كلاستر اخر، ولذلك انا حتى سعيد وانا اشوف الكلاسترز الان في certain كلاسترز في عندهم مدينه طبيه، بينما كلاستر ثاني يقول لا انا بيس على انا فريق الكوميونتي ام سيرفنج اي دونت نيد مدينه طبيه بقدر ما اني انا عندي secondary care hospitals وعندي good primary care coverage whatever it takes يعني، او ولا there is a need tertiary care I'm contracting with the nearby cluster to offer treatment هذه، وبينهم billing معين يشوفون. فهذه studied وفيها كثير من يمكن الاشياء اللي انا عاد هنا اتوقف ما اقدر اكون فاهم فيها اكثر او عندي معلومات اكثر، بس اللي اعتقده واللي اعرفه انه ما في سيرفيس من حق مواطن لحق له العلاج وهافينج فلو فجاه is يعني متوقع، لكن نتخيل انه انا اذا كان عندي efficient system I don't need to bring everyone to the BHC. I communicate with them, I use virtual care، حقلل الزيارات غير الضروريه. الحين احنا في كل طبيب يمكن يجي احيانا كثير يمرك العياده، بعدين تكتب له تحاليل، هو طلع من دوامه عشان يجيك العياده الاولى، بعدين يطلع من دوامه عشان يسوي التحليل عشان يجي صايم، بعدين يجي بعدها يشوف الريزلت معاك. هذا ياخذ عياده وقت على غيرك، وقت منه ياثر على عمله، ياثر على يتعبه، حتى توصيل اولاد المدرسه، اشياء مثل هذه. لكن if you have better communication مع الشخص، قد احيانا حتى اذا everything is good اقول له خلاص انا بطلب لك التحاليل اللي انت ما طلبتها من زمان، روح سويها بشوف الريزلت معك، مو دائما تحتاج انه يجيك باذن الله تعالى. So I don't know who has the mic.
السلام عليكم. يعطيك العافية دكتور. Presentation is very amazing. I have a question. I'm a general practitioner. I work in a hospital third cluster in Riyadh, an emergency department. So when I see patients regarding the acute cases, there are patients unfortunately come like as if it's a family clinic. Of course, as you said, that our objectives is we want patient satisfaction and our satisfaction as doctors. But unfortunately, those patients visit hospital as if they are molds. They take this medication, I'm not satisfied, let's go to another hospital or another clinic and take this medication and take this medication, which in the future causes complications or more acute cases, unfortunately. So, look, I understand that each cluster, I'm talking about the cluster, keep aside the hospital like National Guard or the private hospitals. Let's focus on the cluster so far. In the future, will be a united system because there are patients lie for the sake of taking new medications or to be satisfied to themselves. In my hospital, there's the other hospitals, another system, which might be like, I don't take the full history from the patient. Okay, I'm good at taking history. I can know if the patient's like or not, but like not 100%. You know what I mean?
Say always يعني احنا we are taking the side of the patient always. And usually sometimes you find patients coming so frequent because patient is complaining. There is a question not being answered. There is some sort of anxiety. There is a hidden agenda. Sometimes this unclarity in the system will force people to have this double dipping. With a better approach, being more close to our patients, and maybe applying one of the principles that we talk about, Stoughton Davis in the communication, and you remember this family physician, they know this approach when they said, modify the health-seeking behavior. When you explain to your patient, the one who's following up, who trusts you, that you don't need to come. I remember one patient told me that, okay, I'm going to come to you to do this checkup test after 6 months. And they said, no. I said, why not? I have a good insurance and it will cover. I used to work in the private before. So I told him, you don't need to come. I know you have a good coverage, but you don't need to come. It doesn't add anything to you. He said, are you sure? I said, yes. I said, okay. So he was coming because there is a lack of knowledge. He felt that if he comes like every 6 months, although it is really a burden on him and overwhelming his schedule, but he felt that he should do that. As a physician, you explain. In your setting, I accept the challenge that you face in an emergency room, and maybe because of the lack of maturity in the primary care right now, the first department will feel the effect is the emergency room, with optimizing more service, defining the role of urgent care, emergency room, primary care, scheduled clinics, walk-in clinics, will modify the flow in a better way. I don't know where the mic is.
شكرا دكتور على المحاضرة الجميلة. وأنا عندي سؤال بخصوص as a family physician, we work in team-based care. So what is the dietitian in this team? I think it's important if we want to activate the person and involve all our community. And we know it's important to engage all the community if we want to practice lifestyle medicine. And we start with the healthy patient before that we're starting in the patient with the chronic disease. So my question, do you think it's important to involve the dietitian in our team? As we know, the health coach is involving, and I'm a head of postgraduate here in the حائل health cluster. So I'm working with the health coach program under supervision of Makken. So this is my question. We need a dietitian in the team-based care. So do you think there is a plan in the future to involve the dietitian in this team? Thank you.
يعني I want to be quick. زي ما أنا ذكرت في النتورك you will be able to have, وهذا اللي احنا نشتغل عليه to design it. You will have mental psychologist to dietitian كذا. لكن you don't need always in every team. It wouldn't be cost effective to have a dietitian مثلا every team. Like you need to have a physician and a nurse, and you will train the existing team to be like a health coach that can be at being advanced to the level of being a health educator or dietitian. You will have a shared source or resource among the teams. أو ممكن dietitian will have a different clinics and different VHCs every day will visit somewhere.
خالد، أول شيء أود أشكرك على حضورك وجودك معنا اليوم. حضور مهم جدا وبرزنتيشن مرة ممتازة ما شاء الله. I have 5 points. One, all related to lifestyle medicine. One is your lifestyle medicine approach interventions uses the lowest
amount of resources, maybe no resource, just we need to train people. That's all we need to do. So in lieu of this point is that, can we, in coordination with you, pick a pilot area like we did before, and we train these people and measure the outcomes? You know, we have multiple. We are introduced this morning the KCI, care indicators that you kind of alluded to before, and I think I talked to you about over the phone about this thing, and we're gonna study it this year, inshallah ta'ala. One of the focus areas, and I'm hoping to see more focus on it, is wellness care or maintenance care for healthy people. In addition to reducing the burden, pharmaceutical burden, chronic disease burden, and pre-disease, which is reversal of disease. And we have a lot of evidence that we can reverse, and we have Dr. Wayne Dysinger here, who was one of the experts in this area, reversing like pre-diabetes and hyperlipidemia, as you know. And I think empowering family physician, which is privileges, and I'm hoping that will expand over time. I'd like you could comment on that. And also, hopefully one of the recommendations from this conference was including lifestyle medicine, vital signs, as part of the medical record or HIS, including whole nutrition, plant-based nutrition, exercise, sleep health, and also stress management and life management, in addition to smoking and substance abuse. And we included in our country motor vehicle driving and accidents, because it's a big killer in our country. That's it. I would like to get your comments on this point.
Yes, you are always welcome. We want to empower teams to give them more skills. يعني في اللايف ستايل ميديسن yes we don't need to have يعني specialized هذا بيكون جيد. The second question was يمكن او third question إذا ما كنت غلطان اللي هو having activities. كنا أصير ضيعت السؤال بس لو الويلنس يس احنا هذا يمكن ذكرناه انه واحد من الكي بي ايز الاساسيه على التيم is not only to treat someone with chronic disease، لا انت تعمل التارجت حقت الهيلثي ones. الثالث اللي هو مساله انه to have forms. احنا سوينا basic assessment form بس it's difficult to have very extensive form للphysician انه to cover question for everyone wouldn't be practical. لكن احنا we can have build it in our existing HIS. It wouldn't be mandatory on the team to fill it always. لكن based on a certain target مثلا 10% you should do based على احنا طبعا discussion نسويها، او ممكن نستفيد من الريزيدنتس الانترنز اللي نقول له تعال انت you join this team بدل ما نجي انت في التيم هذا عندنا patient are there وبيشنت كثير منهم لا في البيوت وhealthy ones. You will call them. You will conduct هذا السيرفي will be recorded في ال HIS and this is what we are trying الآن في الصحة المدرسية. الأشياء لما تطلب عندنا الزيارات الفحص الاستكشافي تمر أولى ابتدائي ورابع وأولى متوسط وأولى ثانوي، كل مدارس المملكة تسويها في السنة. ويأسستم على كل ايج جروب له أشياء، ناخذ المعلومات ونبدأ شوي struggling في عملية الفولو اب. لا الآن you use a version خلينا نقول موبايل version of the HIS. You will have an entry بعدين تروح للتيم. التيم عندي طفل في سكوليوسس. I'll bring in هذا الطفل وأتابعه وإذا يحتاج أحول المستشفى أحوله ونشوف إيش اللي صار. وبهالطريقة هذه.
Last two questions because we run out of time. Dr. Wayne.
I just want to thank you for your presentation. It was wonderful. It seems like it's an exciting time for Saudi Arabian healthcare. And I congratulate you to coming to a lifestyle medicine conference. And first time I'm seeing lifestyle medicine as part of the foundation of care for a whole country. So a couple questions. First, you mentioned the core team is the physician, the nurse, and then you said a clerk/coach. So I'm curious what kind of training each of those three people are going to get in lifestyle medicine. And then just a quick comment. We have data, and I'm happy to talk to you about it afterwards if you'd like, that a primary care approach, a lifestyle medicine-based primary care approach decreases healthcare costs by 40%. compared to a typical primary care approach. So it would seem like it is a good investment to make sure all three of those core people have some kind of lifestyle medicine training.
Thank you so much. Yes, about the team, we have the minimum accepted, and we expect that we will enhance the teams with more training, adding more, let's say, we need to have a health coach and case coordinator. But the minimum we are starting with is a physician and a nurse, getting just to register people and approaching them, doing some assessment. While as we go with making the intervention, we are training the people with, we let them to know how the system works, to let them know how, what are the interventions needed, to give them a special skills through Meccan program, for example. We train them through certain programs, and if there is a lifestyle medicine as well programs, we can let them engage in that. Programs might be a fellowship, master's, course, online. We want to have very easy things, and we can have an advanced one. Now we are initiating a platform for training where everyone should register and go through assessment, and it will be part of the assessment of the team. We wouldn't accept someone working with the patients with no enough minimum accepted capabilities. It has to be there. The other thing, we're now providing these platforms, it's as a zero cost, so we can engage materials in these platforms, as well as we are conducting right now, because we don't have the platform ready, like a Zoom meetings and lectures. If you want Dr. Saleh to design something, you train the team with us, so they have it like in every session, you are welcome. So all of these are really open for discussion.
Okay, thank you, Dr. Khalid, for coming here to Hail and give this presentation. My name is Tamer Shimri. I have a question. I don't know, like, I hope that you can answer me. It's the activation of the, we know that most of people, just following Dr. Saleh's comment, most of people usually go to the private community pharmacy, but another not. So are there any plan to benefit from the community pharmacies, like to like aware people about the disease and preventive and lifestyle medicine? Because I know not all people go to the physician, not all people see a physician. So any plan to activate this? Thank you.
You remind me about an initiative that we need to, now احنا عندنا وصفتي to prescribe medications. وصفتي is a breakthrough صراحة. بعض الchallenges الموجودة الآن، لكن كانت always primary care, there is a challenge في supply chain. دكتور صالح شاف supply chain بس في التطعيمات، فكيف لما يكون عندك items كثيرة. And the result of missing one hypertension medication for someone يعني old ولا lady ولا كذا، ممكن إنه يرتفع البريشر ويصير عنده stroke or something like this. فطلع تطبيق خلينا نقول ابروتش اللي هو وصفتي، انه يوز الكوميونتي فارماسيز وتعمل البريسكربشن. ان شاء الله الامور حتكون افضل وافضل فيها. كانت فكره انه نعمل educational material prescription، يعني وانا اكتب لك البريسكربشن ادويه السكر، اكتب لك بريسكربشن عن الماتيريال وتطلع لك في الرساله. كانت انيشيتيف قاعدين يشتغلون عليها، بعدين اجلوا على موضوع يصير عندنا صحتي، كيف الاشياء بتدمج مع بعض، وصار في برايورتي طبعا مع الابز واللقاحات، لكن this is a very valid one. بل كان عندنا انيشيتيف من جهه بس عاد يمكن يبغى لها وقت وتحتاج كوست، why you don't prescribe exercise، بحيث انك في بعض البيشنت مو كلهم يصير عندك كونتراكت مع جيم معين عارفين كيف يعطونهم الاكسرسايز، وبالتالي بريسكرايب هذا الاكسرسايز يروح يسويه. هذه كانت ايضا ما هي بروجكت، بس ممكن في المستقبل نجي هنا طبعا مع التحدي حق الكوست، لكن ممكن انت يو بريسكرايب اديوكيشنال ماتيريال في الاكسرسايز، انك تقول يو نيد تو ووك بالطريقه الصحيحه، العدد الصحيح، سترينث اكسرسايز، وهذه الاشياء. ممكن فيديو الان ايزي بس تعلمه، ولينك يضغط اللينك. everyone has a smartphone almost الان، فممكن ياخذ هذه حتى بريسكربشن تصير ازمه. فاحنا we have to think outside the boxes. عليكم اليوم مره ثانيه.
Thank you very much, Dr. Khalid, for your time answering the questions. So now we will switch to my colleague's moderator, Dr. Marwa, to start her session.
Assalamu alaikum. Our dear colleague, with you, Dr. Marwa Abdulsamad, Public Health Consultant, Doctor, Fellow of Faculty of Public Health, Royal College of Physicians. It is an honor to be the moderator of this session. It will be the first part of this session will be online. Our speaker for this session is Dr. Rabbani Tariq. Dr. Rabbani is a lifestyle medicine physician, public health specialist. He is joining secretary, Indian Society of Lifestyle Medicine. He is a certified lifestyle medicine core competency program. He is also a faculty of European Lifestyle Congress. Dr. Rabbani will discuss with us the health disparity solution, bridging the gaps and in the rural health, and also the classical medicine approach to health management and maintenance. Let's welcome with Dr. Rabbani.
Thank you, everybody. First of all, can you please somebody confirm, am I audible and is my camera working?
Yes, doctor.
Thank you. So, as I've been already introduced to the forum, I'm going to talk about health disparities solution, bridging the gaps in rural health through lifestyle medicine. Now, first of all, let's understand whether there are health disparities existing in the world. Okay, so they are also referred to as health inequities, which have garnered an increasing amount of attention from physicians and health policy experts. Basically, there's something related to differential access to medical care, to treatment modalities, and disparate outcomes among various racial, ethnic, and socioeconomic groups, which has been in fact validated by numerous studies. Now, most of this is being picked up in the primary care side. It's being picked up in the preventive healthcare services, not limiting to that only, but yes, obviously existing to the tertiary care setup as well. Now, we are going to basically highlight some dimensions and the extent of these health inequities. There are significant socioeconomic disparities existing in this healthcare setup globally, as well as regionally, country-wise, region-wise, district-wise, division-wise. These socioeconomic disparities in healthcare are important for a number of reasons, dear friends. They pose a significant moral and ethical dilemmas for the healthcare system. To some extent, certain countries, certain nations have an abundance of healthcare facilities, cutting-edge technologies and pharmacotherapeutics or other assets that envy the rest of the world. Now, if we talk about in terms of these health disparities, there are issues related to social justice, opportunity, and quality of life for patients, for communities, for larger populations, and even nations at large. A close allied concern is the nation's economic well-being, mostly related to the health expenditure of the gross domestic product with respect to that particular country, which is both directly and indirectly tied to health status of the population as a whole. Again, if we look about these health disparities, the root cause lies in some inadequacy, some inaccessibility, or a poor medical care that further exacerbates this increasing difference in the overall quality of care that is experienced by nations, by regions. Now, if we go with an example simply to understand this disparity, as per the infant mortality rate, the life expectancy, the prevalence of non-communicable diseases. We have come across established in literature, published in literature, that in certain socioeconomic, ethnic groups, racial groups, there is much more infant mortality compared to the other groups. Similarly, the life expectancy is higher in certain groups and lesser in the other groups due to various reasons, which is not limiting to only socioeconomic background, but some other connected factors, which might be like the race, the ethnicity, the cultural differences, even the lifestyle choices, the age of people, the sexual orientation, the lack of access, personal, socioeconomic, and environmental characteristics, which is an established fact that yes, disparities are there, and they have been there right since inception of medicine. Now, this is a database from the World Bank website, and if we look over here and compare the mortality rates of infants, rather the infant mortality rate, we see most of the deaths or most of the mortality in those countries where there is a lower GDP spent in relation to health. Similarly, if we move on and see the life expectancy at birth, the life expectancy at birth is again higher in certain countries which have a higher expenditure of GDP on health as compared to relatively other countries. So which is basically a global health disparity, which is existing all over the world in different regions and the different continents. Mortality from non-communicable diseases. If we talk about lifestyle medicine with people around 30 to 70 years of age, again, there is a disparity, and we see such kind of mortality happening higher in certain countries where there is again a meager amount of expenditure of GDP in terms of health. Basically, if we look towards these populations in health disparity, they are the so-called undeserved or the underdeserved or the whichever comes across those categories, which basically come across these different issues related to health inequities. Even if we look for one of the leading health expenditures on health in the world, we see the almost 5.7% of an expenditure is being done by a state annual paycheck on health. While as relatively, if we compare the other expenditures that are being done in a very developed country, we find there are higher expenditures on other things which are incomparable to the health expenditures. Now, there was basically a report that was published in around 1985, the Heckler report, which substantiates, yes, there are health disparities existing in one of the higher income countries existing in the world. And they were categorical and clarified these things that yes, the poor health status, the poor outcomes, and the constricted access to medical care have been there for more than 300 years. And there's a wide disparity in access burden of death and illness experienced by certain sections and other minority Americans as compared to the nation's population as a whole. The report even emphasized that 6 medical conditions between the blacks and the whites accounted for 86% of excess black mortality, and the fact that close to 45% of deaths up to the age of 70 years. And certain 6 conditions that were mentioned in that report were cancer, heart disease, diabetes, infant cirrhosis, and so on. So again, if we lay down the stress over here, what I want to infer from this is basically it's mostly related to non-communicable or the chronic diseases. Now, there are disparities even to a tertiary level healthcare. For example, in the cardiovascular care, it depends on the patient's input, who's at the helm of affairs, who's at the chair, the socioeconomic, cultural influences, how is the person interpreting it, how is the intervention happening. There are certain prejudices and stereotyping obviously involved. Now, disparities are mostly related to the cost, the accessibility and affordability, and most of all now to a larger extent in different countries related to the health insurance coverage, which has basically created problems in the universal health coverage, availability and accessibility to all. In fact, there was one of the speakers or one of the persons from the audience also mentioning with regard to the financial model. And in fact, Dr. Wayne also mentioned the financially sustainable models in lifestyle medicine that are required. And let me tell you, dear friends, the elimination of these health inequities for minorities would have reduced the total cost by approximately $1.5 trillion over a 3-year period. So this is one of the justifications that can be put forward to understand why lifestyle medication, lifestyle medicine, or rather primary healthcare needs to be modified in such a way to address these health disparities. These health disparities obviously are dependent on the determinants of health and have a multifactorial causation. And whenever there is a rolling out of a strategy, even coming from the lifestyle medicine, all these factors needs to be taken into account. And what exactly is going to be the role of lifestyle medicine in bridging this gap, and the main focus of attention for this deliberation is basically being discussed now. So it's around 65% of the world's population lives in a country where overweight and obesity kill more people than underweight and malnutrition. So we have a two burden of diseases globally happening. One is the acute side of the diseases, another is the chronic one. But again, we see the major chunk is because of the chronic diseases, and it will continue to grow because of the poor lifestyle, the sedentary lifestyle, and other associated factors that are creeping in all societies and all the acculturation that's happening globally all over the world. So the 6 leading global risks for mortality that are common to low, middle, and high income countries as well. Okay, they are related to lifestyle modifications. They are related to the diseases of chronic side, like blood pressure, tobacco use, high blood glucose, again, physical activity. Now, 70 to 90%, the most common and the deadly chronic diseases, okay, including diabetes, coronary artery disease, stroke, and cancer, could have been prevented via tobacco cessation, avoidance of overweight, moderate physical activity, and healthy diet. Now, there is already certain mainstream programs, residency programs, which are, or health programs, national, international health programs, agencies, international, national, regional, working on these in terms of public health initiation and campaigns. But there is something still missing on the ground. Now, what is the need for this health equity-oriented lifestyle medicine? Okay. So the worldwide lifestyle risk factors disproportionately affect these diverse, low income, or the vulnerable populations. And this has been already established, and there are a number of studies in literature which talk about this. These adverse lifestyle exposures, as already mentioned, are related to various risk factors which are related to socioeconomic backgrounds, ethnicities, and variable reasons. Now, based on these preventable and unnatural causes, lifestyle-related health disparities are basically unjust and really have an issue with respect to the morality for a society. Now, preventable and modifiable risk factors for cardiovascular diseases, diabetes, and blood pressure drive differences in health status. Now, indeed, researchers have calculated that if levels of blood pressure, blood sugar, body fat, and smoking were controlled to optimal levels in vulnerable subgroups, disparities in cardiovascular disease deaths would be eliminated by 80%. That's huge. 80% is a huge number for a reduction of any number of chronic diseases. Now, preventable health disparities were basically a threat to economic sustainability, and they continue to be so, and affect the well-being of all residents. And one estimate even suggests that US health disparities cost more than $1.24 trillion. So these disparities are existing over there. Now, although proven to treat, prevent, and reverse lifestyle-related chronic diseases and its precursors, narrow lifestyle medicine prevention efforts could basically inadvertently widen these health disparities. So the focus of the primary care and introduction of lifestyle medications, the lifestyle modifications at this very primary level is the need of the hour. And especially to those susceptible populations where these modifications can be incorporated at the primordial level. Now, this phenomenon has been occurred with cardiovascular disease prevention efforts. In United States, there are a number of programs, as have been mentioned since yesterday as well. Somebody discussed about the CHIP program, Dr. Onish's details, and everything of that sort has been mentioned. So what basically is the connect? Now, if we see there was a mean serum cholesterol and prevalence of tobacco use, which dropped in most high-income countries, whereas prevalence of certain chronic diseases and lifestyle risk factors actually increased in certain lower income groups, again, due to acculturation, modernization, and other factors which are related to it. Now, what are the levels of intervention where lifestyle medicine can come into play in order to reduce this burden of chronic diseases, as well the as per the levels of prevention as well. In the ecological model, in the public health concepts that we understand, there is always a top-down approach or the bottom-to-up approach. Now, these things need to be taken concurrently. I was happy to see that there has been a multi-model approach started in the kingdom. And yes, we need to start with the public policy in terms of lifestyle medicine incorporation in the mainstream curriculum. Community building up of partnerships, relationships among organizations, whether government, non-governmental organizations, they need to take up certain pilot models, certain village models, wherein these behavioral intervention trials can be conducted, and certain organizational setups, for example, in already running hospitals, in already running institutions, any kind of government or non-government offices, building up of a health promotional campaign related to lifestyle modifications needs to be rolled out. And this all has to start concurrently, not only from the health policy making level, but the other interrelated levels. Now, if we talk about the interpersonal levels, wherein there will be a huge contribution of the lifestyle medicine professional team that was already discussed, which includes penetrating the setup of existing healthcare or the social niche of the community. And that includes the family, the friends, the social networks, and of course, the mass media, the social media, which needs to come into play to promote health. Now, individuals, obviously, which have been there to some extent, wherein there have been problems where most of the lifestyle modifications are being put as advices rather than prescriptions. And most of the time, what happens, these advices are put up as vague statements. Like, for example, a patient lining up in a clinic, they are being put up with advices that you need to reduce your weight, you need to reduce oil, or you need to reduce this kind of stuff in your diet. But until and unless it's not put smartly as per the lifestyle medicine core competencies, I'm afraid the patients are not going to follow, the clients are not going to follow, the population is not going to follow. So this particular ecological model of hitting in a concurrent way in order to reduce these disparities is the need of the hour. One among these disparities and addressing this model, one among these models that were used in US and to some extent with some other names in different parts of the world is community engaged lifestyle medicine. Health equity pathway. Now, this basically runs in terms of the same basic public health and preventive medicine concepts, that is engaging the community. Now, it's not only that lifestyle medicine would be part of a hospital where a doctor or a lifestyle medicine physician would be dealing with patients who require lifestyle modifications. Now, lifestyle data or lifestyle vital signs is like what is happening every other moment. We sitting in this particular conference and talking and discussing things. We have been sitting for some long. We have had interactions. We have had some health promotional events. I was checking on the social media and it's a fabulous thing. How do we promote health? Okay, so that's one of the interventions that needs to be encouraged. Now, building health equity is a goal, and that is within the scope, reach, and obviously the mission of lifestyle medicine, and it has to be in an organized and a collective effort rather than an individual clinic based on the approach. Now, again, if it's feasible at the local, national, and global levels, that's basically idea, and that's how it should be rolled out. Now, that's why I, in fact, raised a question yesterday in the conference that how all the global organizations, the societies of lifestyle medicine can bring this mission forward. Because we have been coming across in the conference since yesterday that there's westernization of diet, there's westernization of lifestyle, there is more of modernization. So until and unless this global drive is not taken concurrently, I'm afraid there are going to be these health disparities that are going to continue for long. Now, in these CELM, practice of preventive chronic diseases and promoting healthy lifestyle behaviors, again, as I mentioned, should be in a collaborative, multi-stakeholder, and a community engaging approach, especially focusing those vulnerable populations or as per the health needs of those particular populations that needs to be addressed. This was basically started in a Rio Grande Valley. And as I mentioned earlier, that these kind of concepts have been running in lots of places of the world, but has been obviously, the name has been coined by the Rio Grande Valley side. And again, nearly what they found out, nearly half of the population, that's 45%, was obese, and more than a quarter had diabetes. And the specific CLM objectives were to some extent that engagement, evaluation, and education, the health educational promotion of lifestyle modifications in that particular population. And the collaborative development evaluation process for this particular CLM framework is something based on capacity building partnerships and building health outside hospital. If we talk about building partnerships, that's not only related with the interpersonal or interdepartmental or interdisciplinary connections, but obviously there has to be certain programs which focuses on community-based engagement, for example, promoting health in the socioeconomic groups which are vulnerable, related to determinants of poverty, food deserts, community safety over time, and again, through different levels. Now, we've talked about building health outside hospital. That's already like happening through the public health preventive medicine residency programs, taking up those pilot projects and rolling out this lifestyle modifications in a vigorous and a rigorous health campaigning model. Now, as for this community engagement lifestyle medicine approach, it will not only have long-term outcomes and long-term achievements, but yes, there can be to some extent short-term achievements as well in terms of modifications that get incorporated with a ripple effect in the overall health situation of that particular region. Now, the specific principles that are related to the CLM is community engagement, multi-level and intersectoral approaches, and the cultural responsiveness. Another important factor that needs to be done is introduction of these lifestyle medicine in the residency programs, and which would in fact help us to build up health professional teams, train certain people in order to roll out lifestyle modifications or lifestyle medicines in a smart way. As I say smart, I mean to say the specific, measurable, attainable, and relevant, and a time relevant or a time limited achievable targets in lifestyle medicine. If we look about how this lifestyle modifications and wherever it can come into play, it's basically the connection between the clinical care and the community setting as well. The coordination of care with the already existing healthcare staff that we have through the community health workers, multi-level approaches, intersectoral partnerships. Again, in the community settings where we have a prevention and lifestyle education projects running, the residency projects that I mentioned that also need to incorporate the lifestyle medicine side, the coalition building or the trust building measures in interdepartmental consults, wherein there would be community outreach programs for reduction of non-communicable and the chronic diseases as well. For example, health promotional campaigns happening in a community wherein certain grocery stores would be mentioned, would be counseled with regard to the health promotional aspects of diet-related foodstuffs that they can purchase. Somebody was talking about the frontal package labeling, and it's one of the dynamic concepts that is being right now happening subcontinent, where we have come across studies have basically published that there are very less number of people who actually go through the details, the ingredients of that particular packaging. Something of this sort needs to be rolled out in the community health awareness programs. Now, if we look towards the clinical care, the prevention and the lifestyle consults in an interdisciplinary team need to be established. It's not only certain chronic diseases that should be connecting through an endocrinologist or through a cardiologist. Now, most of those patients or clients attending these particular specialties should also get in touch with a lifestyle medicine physician. And this interdisciplinary support is required and is the need of the hour to bridge this gap of health disparity, because that will be at the tertiary care level, at the secondary and the primary care levels. That is the community setting approach that we need to adopt. But again, for improvisation of this overall setup, we need a continuous quality improvement happening, which is ultimately the road towards health equity and improvisation of health. Now, what is the prescriptions for lifestyle medicine practitioners? Now, although originally developed as health equity framework for the border communities, but most of the times what we come across in the public health concepts that some innovative ideas that were developed for difficult or hard to reach areas, they to some extent can be applied to certain other regions and had wonderful, brilliant results. So similarly, of this sort, these particular engagement programs would help in to incorporate and to promote health on a greater extent and reduce these health disparities. As I mentioned earlier, it doesn't have to be at a single clinic effort, but an overall development of the full curriculum as well as the community engagement. Now, this is some of the short-term, a snapshot of the short-term, medium, and the long-term outcomes. And this has been taken up published research already by Dr. Kaleem, and they focused mostly on the organized focus groups in terms of community engagements or community organizations where different stakeholders, they need to be connected and they need to promote and make this vision visible to the clients as well. On the medium term, there needs to be setup of social media frameworks. There needs to be engagement strategy. For example, most of us didn't know what exactly Facebook and Twitter would be doing like some 5 to 10 years back, right? So with the evolution of certain health promotional websites or health promotional social networks, there's something by the name of Spark where they promote the health promotional events or lifestyle, healthy lifestyle related stuff. So some things of this sort needs to be encouraged in our local context. And the longer term outcomes, the policy decisions with respect to, for example, somebody was talking about the restaurants that the different food stuff is being sold out over there. See, this all started in different ways. Even in terms of a reduction of addictive substances, for example, tobacco and smoking. Okay, so the health policy rollout took ages to reduce, to some extent, the consumption of cigarettes. Although it's still happening and we are again in a concurrent phase to do that, there's always a tug going on between two sides of reduction and increase or consumption of such substances. But similarly, such kind of strategies need to be devised and divided in the long-term, medium, and the short-term outcomes. The most important out of this is basically the cultural responsiveness, that whatever we come across, whatever we roll out has to be customized as per the local need, as per the emergent need of that very population, wherever these are going to be rolled out. Now, there are some initiatives that the Indian Society of Lifestyle Medicine, and there are basically some initiatives that are going on in the Indian subcontinent in order to promote lifestyle medicine. Now, one among them, and there is one ATWAS project, that's a behavior intervention trial that's going on, and it's in pipeline to be published. Again, what needs to be done is observance of preventive and public health programs with far-reaching audiences. Now, Indian Society of Lifestyle Medicine has been conducting monthly webinars, workshops, and journal clubs promoting lifestyle medicine, wherein we have participations not only from the members of the society, but far wide reach audiences. It's open to all and anybody can join in so that they understand what basically this campaigning of lifestyle medicine is about. We've been in touch with a number of organizations, collaborating with them and signing MOUs with respect to common minimum agendas, starting lifestyle medicine grand rounds. Although for the last 2 years, we've been hit by COVID, and because of that, it's mostly happening virtually. And in future, we have an intention to start it face-to-face as well. Development of lifestyle medicine guidelines in a customized manner. And again, there are some organizations, there are some countries in the lifestyle medicine setup which have taken a leap almost ahead of other countries by a decade or so. So we've been in touch and we've been in talks with the Lifestyle Medicine Global Alliance, and we've been requesting them that such kind of resource setting, wherever such resources have been developed, should be shared with the sister organizations so that an equitable and a reduction of health disparity to a greater extent happens. Again, accelerating research in the lifestyle medicine among diverse groups, and there are a number of projects already running. Although there have been some projects which have been there already published, but they did not have a nomenclature of lifestyle medicine into them. We're trying to incorporate and bring in as many research projects into this lifestyle medicine, because obviously as per the population, the Indian subcontinent holds a major chunk of the population. Again, I'm a strong believer of use of technology in lifestyle modification or medicine. So I believe in coming times, we have a data-driven approach. And as of now as well, we have a huge data-driven approach, especially related to lifestyle medicine, vital signs. We didn't have this concept of the step counters, the sleep hygiene related in terms of data calculations, wherein devices are easily available simply on your mobile phones or any wearable technologies, whichever is available, which can be connected or passed on to a lifestyle medicine team or a physician and a professional. And I believe those initiatives should be taken up globally. And obviously, we are also trying to incorporate such kind of stuff in relation to our website, wherein those participants, those clients and other physicians or the team members, they can use and take up these tools and techniques. Okay, so questionnaires, scales, whatever can be made easily available for development of a curriculum and incorporation of that particular curriculum into the mainstream medicine curriculum. Research projects, as already mentioned, and obviously the diplomate programs by the International Board of Lifestyle Medicine. We're in process with and in consultation with them. We're looking forward to development of lifestyle medicine programs for the Indian subcontinent as well. So these are some initiatives that the Indian Society of Lifestyle Medicine has tried to take up and build upon and roll out for the Indian population. Now, these are some published research papers with respect to the lifestyle medicine concepts, some technology related, some development of customized questionnaires. There is some systematic review that we took place with respect to non-communicable diseases. Now, if we talk about more and stress upon how lifestyle medicine specifically can improvise in terms of reducing these disparities in chronic diseases. See, for example, there are certain core competencies already existing in lifestyle medicine. There are certain already nutritional health programs running in different countries already, which are health promotional related to nutrition. Now, this needs to be interconnected. The lifestyle medicine model and the existing health awareness programs or health programs or the policies which are already existing, that needs to be incorporated at the nutritional level, wherein obviously reduction of consumption of trans fat, fatty acids, the frontal package labeling, awareness about nutritional or diet intake of whichever type of diet is being consumed by the consumer. Such kind of campaigns need to be promoted so that that helps in reduction of health disparities in a promotional way. One disparity is at the curative part. We're in lifestyle medicine, it's a dual thing. It's both at the primordial, primary prevention, then it's at the level of secondary and tertiary prevention to some extent, the management of non-communicable diseases. And nutrition plays a very important part to that. Again, in the physical activity part, I believe there should be a promotion of environment that is being provided to populations. It's not simply providing guidelines and doing activation of campaigns wherein we are promoting physical activity or we're talking about physical activity. But yes, governments and non-governmental agencies need to come together and roll out an environment, a smart city concepts, wherein physical activities are easily possible without pollution, which is readily accessible, available in the form of gyms, parks, which basically promotes health, which basically encourages people to come out of their places and go on a physical activity rather than simply talking and discussing physical activity and rolling out the guidelines. With respect to stress management and emotional wellness, we have been coming out of this pandemic since last 2 to 3 years now, and we have come across that there are people who have basically dealt with stress-related problems and emotional issues. So this is the right time to incorporate this lifestyle modification or the lifestyle medicine in order to improvise, in order to educate people more of towards how to manage their stress. Sleep hygiene, rolling out and connecting it with the mental health in terms of lifestyle medicine core competencies. Again, avoidance of risky substance use and smoking cessation. So these particular core competencies needs to be promoted, and obviously they certainly help in reduction of the financial burden on the health setup of a community or a socioeconomically different or a vulnerable group. Now, again, the most important factor that is beneficial in lifestyle medicine is the non-drug modalities. So all of which is being discussed because it basically requires more of a training from a healthcare professional, induction, behavioral intervention, assessment as per the behavioral change and or the phase of change in which the person is. So it doesn't lead actually so much of financial burden on the clients or the customers or the population. So it's a wonderful concept which can be incorporated in the public health and brought together and rolled out so that we reduce a huge burden of morbidity and mortality on the healthcare system. And again, which promotes the social and the relationships, including happiness. Now, what do we have as challenges ahead? Now, despite this progress in the health equity by renowned organizations all over the globe, there is much work that needs to be done. There are still ethnic and health disparities that are there and have been there since ages. Those particular areas need to be identified. Those particular regions need to be identified and to make them more prioritized in order to reduce their disparities. Again, in the medical education, there has been an enormous evolution and progression in all sides, but still there is published literature that we find that there are disparities within the healthcare system, within the perceptions, or with the prejudices that needs to be reduced with the improvisations of curriculums and quality checks all over the world. And again, there is an emerging era of health reform. There is this privatization, there's this commercialization, this pay for performance reimbursements that needs to be taken care of in order to reduce this health disparity. Now, again, if we promote health in form of lifestyle modifications, I'm sure that lifestyle medicine will be able to reduce this disparity further and promote health. And the most important thing that if these disparities are not addressed now, they are going to increase with time and having far-reaching consequences. So we need to take care of them at an emergent and an immediate basis. The roadmap ahead and my suggestions would be from the Indian Society of Lifestyle Medicine as well, that integrating lifestyle medicine with the public health and the preventive medicine at the population level, integrating lifestyle medicine in all possible medical specialties in clinical settings, as well as in the community settings in the previous slide, and then advocating the cause of lifestyle modifications through behavioral change models at all the ecological models, which I've mentioned already. Then transition of urban environments to promote lifestyle. So it shouldn't be restricted to just discussing and rolling out guidelines, but yes, we need to promote those environments and give them to our population where they are easily encouraged towards such modifications. Impart lifestyle medicine education in mainstream medicine exclusively, and shifting of a lifestyle medicine approach from advices, which has been there since last 2 decades, to lifestyle medicine prescriptions in terms of physical activity, in terms of diet, and other core competencies of lifestyle medicine for individuals as in a clinical setting, as well as populations in form of implementation of guidelines which exist, which are existing in public health and preventive medicine. But the most important point is rolling them out and implementation and making the environment sustainable, that they are basically implemented. And with this, there is an event that Indian Society of Lifestyle Medicine is hosting this March on 25th to 27th. It's a virtual walkathon through which we are connecting the whole world, and we have sent invitations to lots of global organizations where we are encouraging that people should register, and we have given these 3-day slots where people can come up and join and take out some time from their busy schedule and go for a walk. And there are different slabs that are being provided wherein there is like 5 kilometers. Click their images or selfies or whichever they like, and then send to a particular email address. And with this, we want to connect and promote the global lifestyle medicine campaign. This is me, Dr. Rabbani Tariq, your resource person for the health disparities concept. If there are any questions, any clarifications, any collaborations that anybody will be looking forward to, please contact me at this particular email address. Thank you. If there are any questions
Thank you,
somebody
Dr.
wants to ask.
Rabbani. Any questions? No question? One question here.
Thank you, Doctor, for this very informative and great talk. I'm Dr. Nesreen, family medicine consultant from King Abdulaziz University Hospital. Actually, I enjoyed your talk regarding the approach that you are using, community engagement and coordination and clinical care. And all of us believe that lifestyle is multisectorial, as you mentioned. So health sector alone cannot do the great job. We have to have all sectors together. I like that the engagement of residency training lifestyle in residency, and this is gonna really decrease the burden of trained staff later on in the clinic. But my question, there's any measurement before and after introduce this lifestyle training in the residency? And if there is any cost or sponsor someone regarding that, because you mentioned that you are doing workshops and webinar monthly basis. So it's paid by which sector? And you introduce the lifestyle service separate in clinic, or it's including in family medicine or primary care? Thank you so much.
Oh, thank you. Thank you for a certain interesting question. I would address them one by one. So with respect to the engagement in the residency programs, what I meant to say that they should be inculcated, that lifestyle medicine should be inculcated in the already existing programs in the preventive medicine and the lifestyle medicine. Now, if we compare like what has happened before and after introduction of these programs, see, lifestyle medicine in most of the countries has been in a concurrent evolution phase. To some extent, in the western side, in the Loma Linda University and other universities in the US, they have come across certain programs. There are the fellowship programs. There are certain diplomate IBLM programs that are already running. But a full-on course medical residency program recognized by the board of a particular country, I've not come across any as of yet. But what I'm trying to say, yes, we need to have such a program, which would be certainly beneficial. As for example, they have this American Board of Preventive Medicine, to some extent in the clinical side as well. There are also the community and the family medicine programs running in different countries. But lifestyle medicine has a specific approach. It's not only dealing with the public health concepts, it's dealing in an individual clinical setting, and which is data driven now. Earlier, there were vague advices coming up, please reduce your weight, please do this and that. But now it's more of a prescription based, mostly smart based, like based on some principles. For example, in the physical activity, we have the FIT principle. In the diet, we have the TAF principle. So this is the difference. The names and the nomenclatures were there already, but we put them in a smart way now, and definitely it's going to have a difference. Although to some extent for last 5 to 10 years there had been certain programs running, okay, wherein people would, or the clients would come in and they were gone through that particular training of 2 to 3 weeks in a particular setting. And yes, of course, they came up with some changes. Now, after they leave that particular setting, what is essential is a continuous follow-up, sensitization that may be required in order to maintain that particular lifestyle modification. Second, yes, we have been running the workshops, the webinars, and the journal clubs. No, it's not sponsored, and it's some good people like those who are interested in lifestyle medicine. They're coming forward and they want to volunteer and take this mission forward. And they're doing all pro bono, and they're doing out of goodwill in order to promote lifestyle medicine, because they all believe, and we all believe, that lifestyle medicine is a change which actually hits the root cause of the disease, and not simply the symptomatology or the etiology or a symptomatic treatment of this and that symptoms of the disease. So it's being done without a cost as of yet. I hope that clarifies and answers the questions.
This is Salih Rajhi. Thank you, Dr. Rabbani, for being with us today from India, Indian Lifestyle Medicine Society. I congratulate you on all the work you've been doing so far. And just to let you know, we're having some headways, alhamdulillah, in Saudi Arabia. And the Ministry of Health is working with us. And now we are slowly inching in a lifestyle medicine concept, and hopefully soon training. And waiting also for good news today, hopefully with the society itself. I think you can mirror what we are trying to do. I think some of us ahead of the others, and hopefully we'll share experiences, and maybe we need to have a conference between the societies around the world to discuss where everybody is, what can we learn from each other, and how can we support each other. Thank you, Dr. Rabbani.
Thank you. Thanks a lot. And thanks for having me here. Bye-bye.
One more question, Doctor.
Hello, Dr. Tariq. This is Dr. Hayat Zahran from Princess Noura University. I would like to thank you about this comprehensive talk about lifestyle medicine core competencies. You did mention that there are a lot of initiatives. One of that you are talking about the programs. And my question is, do you have any experience in undergraduate curriculum development in this matter? I do believe that if we are start early as possible in the medical school, then we reach to a good outcome in the future. So do you have, from your view, any experience? Thank you so much.
Yes. Basically, when the new EXCO, the recent EXCO took up the Indian Society of Lifestyle Medicine, the first most thing that we took up is writing to the National Medical Commission with respect to introduction of lifestyle medicine curriculum into the mainstream undergraduate curriculum with respect to the preventive medicine side. And we've been working, and we put some thoughts, and we've shared a number of modalities, module-based improvisations of lifestyle medicine curriculum in terms of preventive medicine. We've shared with them, and we are in close discussions with them with regard to this. And we're hopeful that soon you will hear the good news. But yes, we have put forward the lifestyle medicine curriculum at the undergraduate level, not at the postgraduate level as of yet. But yes, at the undergraduate level, definitely we have done that.
Thank you so much, Doctor, for this valuable and interesting presentation. Thank you, our dear colleague. We will take 1 hour for pray and the lunch break, and we will be back again after 1 hour.
Thank you. Thank you. Take care. Allah Hafiz.
Thank you, Dr. Rabbani. Goodbye. See you next
Goodbye.
Just for those who are representing universities, just to remind you, we are working with حائل University in creating the academic programs, medical school here, and also the other healthcare schools or colleges at حائل University. Those who are from other universities interested in this approach and interested in embedding lifestyle curriculum into their own schools or colleges, you could contact us. And the Saudi Lifestyle Society is very close to being born, and it will be the official source of this information, and also trainers, if you will. And we welcome also new colleagues who will be taking the exam this year, inshallah. Thank you, everybody.
Thank you, everybody. We will come back again after 1 hour to complete our session with Dr. Samir. Thank you. ready for completing our fourth session today? Our next speaker for the fourth session today, Dr. Samia. Dr. Samia she is currently working as consultant of the family medicine at Haiel region. She is designated institutional official in the Haiel Health Cluster. The Haiel Health Cluster's head of postgraduate medical students in academic affairs. Ambassador of the change of the academic affairs in the Haiel Health Clusters, and trainer in the Family Health Department. Let's welcome Dr. Samia.
السلام عليكم. صراحة سعيدة جدا بوجودي اليوم في المؤتمر العالمي لطب نمط الحياة، وبالذات إنه أنا بشتغل في حائل. We know or maybe you don't know the highest prevalence of diabetes, it's here in Hail, not in other region. So it's 31% the diabetes prevalence. So that's why it's important to start our conference of lifestyle medicine here from Hail. I'm so glad to be one of the member to starting the lifestyle medicine here practice. Today I will talk about the lifestyle medicine practice model, optimizing lifestyle medicine clinical practice. Okay. Our objective for today, overview of the clinical practice in lifestyle medicine, the American College of Lifestyle Medicine to implement medicine in primary health care, overview of the community collaboration model and community engaged lifestyle medicine model, overview of the whole person model as a success model in the lifestyle medicine practice, overview of the lifestyle medicine solution care model and effectiveness. Also, we'll make an overview of the complete health intervention program and effectiveness, effectivity in decrease the cardiovascular risk, optimizing lifestyle medicine practice model, implementation of the lifestyle medicine practice model in primary health care, and also the fact of the lifestyle medicine practice in Saudi Arabia. So overview of the lifestyle medicine practice. The lifestyle medicine practice actually, it's a practicing and caring for the patient from the side of the lifestyle. We can manage his or her communicable disease. So it's all about the creating a practice, caring for treating the patient, depend on evidence-based medicine. And to practice the lifestyle medicine, it's depend on the lifestyle medicine pillars and understanding the competencies. So yesterday and today, we understand part of these pillars and competencies. The challenge for today in how to shift our lifestyle medicine principle and pillars and competencies to the practice. And do you think we can take these pillars and goes to the clinical practice of the lifestyle medicine in our primary health care or our hospital? Do you think? Okay. So we will start now with the American College of Lifestyle Medicine. Maybe all we know or we hear about the American College of Lifestyle Medicine. It's formed since 2005. It's a professional organization caring for or focusing on the lifestyle medicine practice to treating the non-communicable disease. The American College of Lifestyle Medicine is established assessment form, short assessment form as a comprehensive assessment used for the taking the lifestyle medicine, taking lifestyle medicine principle as a data for applying the lifestyle medicine in clinical setting by a practitioner. So as we see here, this is the lifestyle assessment short form. It's just asking about the overall health. We're asking about the nutrition, exercise, weight management, sleep, and also we assess the mental health, smoking, substance abuse, and motivation. As Dr. Today, before we take a break, Dr. Khalid Abdel Karim, he say we should to engage or activate the person in the lifestyle to care for his lifestyle, to encourage the other community. So one of the important model here we have it is a community engaged lifestyle model. So we need to engage the community to start really the practicing the lifestyle medicine. It's by engage the high-risk community member and the stakeholders in the lifestyle medicine intervention. It's multi-level approach and build reliable long-term health equity and engage the population of the lifestyle medicine clinic. So every one of these models, we will talk a lot of models today in the lifestyle medicine. So every one of this model, it's take يعني a long lecture. Not just a short, but just I give you an idea about the importance of the community engagement. And as Dr. Khalid Karim, he said, we should to start to engage the community if we want a real practicing of lifestyle medicine. And also this conference, it's يعني example for engagement of the lifestyle medicine in our practice. This picture shows how it's important to engage and educate and evaluate the practicing of the lifestyle medicine. So we'll start by clinical care, prevention, lifestyle medicine consultation, the community health worker, and the community setting. So just it's give us the healthy lifestyle, healthcare value, and health to prevent health literacy, and give more education about the health and community capacity. This is all it's laid to improve the health. Also, we have a community collaboration model. Also, this model, it's containing one clinician and one administrative person. It's just use a small space in the clinic, not more than 30 to 60 minutes. The most advantage for this model, it's low cost and also blend the lifestyle medicine consultation and with the primary healthcare practice. So this is what we need actually from our primary healthcare to work in the lifestyle medicine. So we need something practical and not take a lot of team members. As we see here, all we know this model of care, but usually we see it in one picture, not separated. So if we see now this model of care, how it's when you are separated the model of care pathways from the layers. So we see the layers now is starting by activated person from the social and psychological part and physical part. And after that, we see the healthy communities. After that, the virtual care. So the important here, before we start to go to the primary health care, it's important to activate the person and the communities by doing such this conference and activities in the to educate our community in the lifestyle, how it's important, and also it goes to the virtual, as Dr. Khalid Abdul Karim said today. Really, I like the project he do it about the virtual care through the Sihhati. He introduced introduce the lifestyle maybe through the Sihhati application. Also, we have the whole person model. This model, it's a comprehensive approach. It's near from our approach in family medicine, psychosocial approach. It's taking history from 5 domains of the person, from mental side, from emotional, social, environmental, and spiritual. Also, we have an evidence for this approach. It's working. It's in 2014, the randomized control trial. It's done to approach whole person approach in self-management in type 2 diabetes, and they are receiving the Inspire manual by 6 modules, key information about the diabetes and managing using whole person. So the study, they show empowering the change of the behavior and self-management of type 2 diabetes. So it's work. And also description of the longitudinal study from 2003 to 2010. It's about the persistent pain. And we see a decrease of the referral rate and decrease of the waiting time and increase the use of the personalized pain management. This model, it's just one of the model we can use it in the primary healthcare. And I think as a family physician or any family physician, he can use it in the primary healthcare, and it's easy to merge it during your practice. The physician have cited inadequate confidence and lack of the knowledge and the skill. It's major barrier to counseling patient about lifestyle medicine intervention. Do you think this is true or? Yes, it is true, because we need to start to implement lifestyle medicine training program as Dr. Saleh, inshallah, he's the pioneer in this side, and we need also to increase the knowledge and the skills, and to find to introduce the lifestyle medicine intervention. This is the lifestyle medicine solution care model. Assessment called the patient profile. It's team-based approach. It depends on provider and health coach, medical assistant, practice manager, multiple contract provider like a dietitian, personal trainer, counselor, and life coach. It's interact by phone and email and through the text message. That's why I back to the model of care layers, and I say for you how it's important to introduce how to start by activated person and engage our community. Then we use the virtual care to introduce our practice of the lifestyle. In a study in 2010, it's they do like a home care, comprehensive home care based care model for outpatient cardiac rehabilitation through the mobile phone. And in 6 weeks, they are just recording the daily blood pressure, smoking, exercise, and daily steps and sleep hour and weight. And they found this model is effective for self-management in cardiac rehabilitation patient. Also, we have the famous one. It's a SHIP model, اللي هو complete health improvement program. It's an intensive lifestyle medicine intervention focused on the patient diabetes and heart disease and hypertension, reducing overweight, obesity, and reduce risk of for cancer and osteoporosis using whole planet-based food, physical activity through 18 sessions. It's containing video, lecture, and class discussion for 45 minutes. And also here we use a virtual care for delivering our message. A cohort study between 2007 and 2009, they introduced the SHIP in 284, showing significant to lowering the BMI, diastolic blood pressure, total cholesterol, and triglyceride. And they are seeing how to improve and maintain a biometric for the patient for 3 years later. The job for caring for patient and provide guidance on how to adopt and sustain long-term habits is a significant challenge. So every patient, they are introduced or starting the lifestyle, he should to sustain until he find the result in the end. So the optimizing, really we can say the optimizing lifestyle medicine practice model, it's a comprehensive, it's multidisciplinary team. Sorry. It's need a lot of work. That's why maybe the Ministry of Health now it's work on team-based care and model of care, and how they are engaged these two models and to work together to give us a finalization of how we start this optimizing lifestyle medicine practice model. The collaboration with the patient and families develop action plan in the lifestyle medicine practice and health promotion. It's one of the competencies of the American College of Prevention Medicine and American College of Lifestyle Medicine to practice lifestyle medicine with interdisciplinary. So the interdisciplinary team, it's important here to start our optimizing lifestyle medicine practice. And if we wanted to introduce this primary healthcare to the primary healthcare, the lifestyle medicine practice, it's really a big challenge to introduce it, but it's not ما في شيء مستحيل يعني زي ما بنقول. Just we need interdisciplinary team, and also with time limitation, it's a challenge, but we can give it يعني within virtual care. I think it's big idea or great idea to introduce it. The cross-sectional study, it's done about the implementation of the lifestyle medicine promotion in primary health care, showing intervention staff was significant, more positive toward effectiveness of the lifestyle medicine promotion. So I think all we agree for that, and we know it can be the lifestyle medicine practice in Saudi Arabia. I think Dr. Ayman Afifi, he's give us yesterday a piloting study about how to implement primary health care in the military hospital. So maybe in our Ministry of Health, I think we are still under process or piloting, inshallah, in the future, with leading us Dr. Salih Al-Rashhi, inshallah, in the future. I think it's near, inshallah, to happen. And also, Dr. Nisrin Al-Hamdi, she has a great piloting study in her family medicine clinic in the university hospital. And also, there is الجندي المجهول اللي في المؤتمر دكتورة رنين. دكتورة رنين طبعا أنا عرفتها الآن في المؤتمر، وما شاء الله she applied lifestyle medicine في تبوك University. She's have a great result. I hope she's share it with me inshallah in the future. I hope دكتورة إن شاء الله we see your result inshallah in next conference inshallah. And ما ننسى إنه حكومتنا الرشيدة عملت طبعا كثير من المبادرات يعني عشان تحسين الصحة وجودة الحياة، واللي تكلمت عليه دكتورة يمكن زميلتي دكتورة دينا في المحاضرة في الصباح. طبعا واحدة من المبادرات اللي هي 2017 الخادم الحرمين الشريفين يوافق على تبني أن تكون الصحة العامة سياسة أولوية وجميع الأنظمة والتشريعات لمكافحة الأمراض والوقاية منها. أنا بالنسبة لي هذا النظام يعني واحدة من الأنظمة اللي حتكون فاتحة. طبعا هو صح إنه since 2017 وإحنا يمكن شفنا كثير من التغيرات، مثلا التاكس على السموكينج، على نفس السيجرت، التاسك على المشروبات الغازية، الأشياء المضرة بالصحة. But maybe we need يعني a lot of تشريعات يعني خصوص أشياء specific، يعني بالذات الأشياء اللي هي زي البروسيسد فود والأشياء اللي هي unhealthy، وممكن على الجانك فود نشوف عليها إن شاء الله في المستقبل. I think هذه لو بدأت وكانت في المجتمع، وزي ما قلت لكم إنه if we want to يعني introduce a real lifestyle medicine practice, we need really to start by our community and by activate the person by himself to be يعني زي self surveillance، يكون على نفسه ويكون هو مراقب على نفسه. فلو احنا زرعنا هذه الثقافة ولو بدأنا من مجتمعنا، وأتوقع إنه إن شاء الله بإذن الله هذا المؤتمر هو بادرة خير. وأنا جدا سعيدة إنه هذه البادرة بدأت من أكثر منطقة موجود فيها نسبة السكري اللي هي منطقة حائل. وأنا سعيدة الصراحة إنه بدأت من هنا، وأتمنى إنه فعلا in the future نشوف باقي المناطق فعلا يكونوا يتبنوا اللايف ستايل ميديسن كونفرنس، وحتى at least يعني as a workshop يعني. شكرا لكم، يعطيكم العافية.
Thank you, Dr. Samia, for this valuable and interesting presentation. Any question? Any question for Dr. Samia?
Thank you, Dr. Samia, for your great talk. My question regarding the community collaboration model that you just shared with us, that only need one clinician, one administrator with 30 to 60 minutes per session, very low cost, and it's really affordable. We can do it. Any evidence regarding this type of model to be applied?
Actually, these models, when I take this topic and give it to me, Dr. Saleh Al-Rashfi, it's really, there is a lot of models. It's just a new model, and they are, إحنا كلنا we know it's a new branch in medicine, the lifestyle. We still, there is models, and the studies, it's very يعني sufficient, it's still sufficient. So inshallah إحنا by our own, inshallah I hope إنه we can do a model through the الجمعية السعودية لطب نمط الحياة. inshallah we establish it soon, so we can inshallah try to do our model, and we do a study for proving that. And also Dr. Nasreen, also I'm not forget you are having mashallah a lot of studies, so maybe this is a proof for you in the future.
Just to let you know, for those who are interested, I have 2 lifestyle medicine clinics, one combined, both combined with family medicine and obesity medicine. So what I do, I use now my preferred initial management plan with every patient is lifestyle modalities. And patients usually, when you give them the choice, they will go with lifestyle. Patients, they said, oh, no, I could do it without medication. Yes, you can. There is some things you could do without. But as far as the practice model, I think initially do with what you have. Do not stress it out, because stress is not good for you. When we did introduce obesity management in Saudi Arabia, there was nobody. So the provider or the consultant was the physician, the nutritionist, the exercise physiologist, everything. Now it's expanding. So we'll probably follow the same thing. يعني النظام السعودي خذوا طالب شوي شوي.
Any other questions to Dr. Samia? في online question.
السلام عليكم ورحمة الله وبركاته.
One question from our colleague online.
Yes, do you hear me?
Dr. Adel with us from online colleague.
Yes.
Can you hear us, Dr. Adel?
Yes,
Okay.
I can hear you.
Okay, you can ask
So,
Dr. Sam.
Dr. Samia, you mentioned that Hail has a highest prevalence of diabetic patients in KSA, correct?
Yes. Yes.
Okay, what's the reason behind this high prevalence? It is because high risk factor like lifestyle, or because of high surveillance and screening program?
I think the cultural lifestyle here in Hail, maybe me and Dr. Saleh, we are live يعني for a while, and still I'm not from Hail actually, but I'm living here for 1 year and a half. So I can say ما شاء الله أهل الكرم, and they give us يعني ما شاء الله a lot of متفطحات و a lot of food, and also I think السويت ممكن والتمر. إيه.
One of the biggest issues in Hail and other parts of Saudi Arabia is portion control. Usually, instead of 1 portion, you get 10 portion per person. A lot of food. And it has to do, there is a history, so just people who don't know. In the past, in this area of the world, there used to be a lot of hunger. So when a guest comes, it's a festivity for the whole neighborhood. So when they cook food, they know they're not just feeding the guests, they're feeding everybody in the neighborhood. So usually when they go eat, the main guest will take small portion of food and he will get up. So everybody has to get up. So you have to eat quick, be very fast. So on each meal, maybe there is 7 groups of people will go into the same, like if this buffet now, you will see lots of people in, they finish out, then the next group, until they finish all of it. So you're feeding the poor, the old, the sick. There is a lot of people who need help. The problem is that this need is not there anymore, but the habits that came from this need continued. And you see it not just here. If you go into, and even in Turkey and other places, even Central Asia, you'll see the same habits. But maybe the best experts is right here, Dr. Abdulaziz.
Thank you. This is why I explained actually to when I visited Baqa about this, and I think we should keep it because it's modify it and try to make it as small portion. We can keep the big dish then, but we can take in our small dish with variety of foods. At the same time, we keep our tradition because we can't go against this. So the best way is not to make the challenge, but to accept it and modify it. And everybody, when I suggest this to Baqa people, which they are very, very generous, they said, okay, that's fine. We can allow it, but we can take our portion. That's fine. Then I ask them to start. Why we don't start this for next ceremony? They say, well, okay, we'll do it.
This generous in high population, but I think, as you say, it's we need a modification. We need to يعني at least مثلا السويت اللي هي فيها يعني فيها high sugar تكون يعني with مثلا protein bar مثلا بدالها أو حاجة يعني تكون more healthier. I think this is yes والله we need. Because I think most important thing
I think it has to do with mindset management and how people look at food and how they evaluate food, and also their self-worth and value when it comes to presenting something. And modification, portion control, increase awareness about sugar problems, and also large amount of food, and also night eating is a big issue.
Thank you so much.
Thank you so much for important presentation again.
Thank you, Dr. Adel, for asking. Thank you, Dr. Samia. We finished this our fourth session today, and now we will move to the fifth session with Dr. Ibad, the moderator of this session.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. By the show of hand, if you're working in the academia, can you please raise your left arm? Lovely. And if you're working in the health sector, can you please raise your right arm? If you're anything in between, just give me an A, okay. Okay, I would like to extend my sincere thank you for everyone here for sticking around and staying for our final and last session this afternoon. Our last session is titled Lifestyle Medicine Education from Literature to Saudi Context. Our speaker is an associate professor in family medicine and a consultant as well. He's a member in the curriculum development, also a member in the research unit at King Saud University. Please help me welcome the one and only Dr. Muhammad Al-Mansour.
السلام عليكم ورحمة الله. أنا أشكر الزملاء في حائل. يبدو أنه الكرم الحائلي اللي تكلموا عنه الزملاء جميعا لم ينتقل لأهل حائل فقط الكرم، وإنما انتقل لهم الأدب. وجدنا الدكتور فرحان في أول يوم يعني أفجأنا بالبيت الشهير لحاتم، وأنا ذكرني بقول ذو الرمة لكن بسوي عليه موديفيكيشن لما قال إذا غير النأي المحبين لم يكد رصيص الهوى من حب ميت يبرحوا. أعتقد أن كلنا وقعنا الآن في حب حائل، فممكن نقول إذا غير النأي المحبين لم يكد رصيص الهوى من حب حائل يبرحوا. يسعدني ويشرفني أن أكون معكم اليوم. Actually, I'm really glad to be with you this afternoon, and they make me they squeeze me in the last session, but this is really my pleasure, and I'm thanking the organizing committee. They gave me this chance in the last moment, but we want to present to you what Dr. Saleh said, that we want something on the ground, we want data, we want something being done instead of just keep we should do. So I hope this is a very small portion of something on the ground. Now, thank you, Dr. Iba, to ask about who's here from academia, and I think my talk will be more of repetition of some what's being said by Dr. Ahmed Al-Sulami, Dr. Saleh Al-Rajihi, Dr. Wayne also talk about lifestyle medicine, and also our speakers for today, they touch on lifestyle medicine education, our brother from India. But I will talk about the undergraduate in depth and some of more of literature review. So our talk today will be mainly about lifestyle medicine education importance, why it's important to talk about it, and some international experiences, some just focus on lifestyle medicine competencies, and a lot of talk being already presented about this. And we will present our data, okay? So when I'm preparing for in the literature review, a lot of articles being there. So I selected those for medical education. And I'm apologizing from other health care providers' educations. There are plenty of publication. So because of my specialty, I focus on medical education. So in 2014, this article talking about lifestyle-related diseases are now leading cause of death on the planet. As we all know from the day one in this conference, it's been illustrated and everyone agree. Modern medicine needs to address those underlying causes in a different way. But what really shocked me, 2020,
we have this study being done and showing that how the disparities, like Dr. Tariq said from India, how the disparities of the skills in education and our physician can affect the outcome of some of the lifestyle interventions, especially for obesity and others. Now, in academic lifestyle education, it's been illustrated in the literature in the last 20 years that it is important, it is important, it is important, because it is tackling a huge burden on the health system. The study showing that medical education, lifestyle medicine is necessity, intense intervention to allow health providers to learn how to effectively and efficiently counsel their client or their patient. So they could not deliver the message unless they understand it and they know how to deliver it. I like this continuum, and Dr. Sulami, from the day one, he brings us the ACLM continuum. It's almost the same, but from a different perspective, that we are not tackling only the lifestyle medicine education only in the postgraduate or on the career development. Also, we should tackle it early in the undergraduate level. But what I like about this, I'm sorry for this, you cannot see the downside of the picture. So the upper side is talking about lifestyle medicine education. The lower one is talking about lifestyle medicine interprofessional education. So it's not only the medical, it's everyone. Education should be involving the lifestyle medicine. And I like the continuum model, sorry. Now, the big players came on the table. American Heart Association, they start to realize that it is working, it is important. Everybody, as they stated in their statement in 2016, that we proposed the framework for US medical school dean and program director to integrate learning objectives that will improve lifestyle counseling competencies among future physicians. So this make the move more toward a high level. One of the studies being done in 2013 that showing that physicians and other providers need to develop more competencies in lifestyle medicine. So it's not only just knowing the concept and the awareness. No, they should develop some competencies in how to teach the patient about lifestyle medicine. And also they talk about the CME for the practitioners, not only for the graduates or undergraduate practice. One of the good studies, I will just bring it to your attention. They choose 28 physicians and they make some intervention in a matter of educating them how to improve the lifestyle of their client or their patient. And they found a very nice, high significant improvement in the outcomes in a matter of hyperlipidemia, obesity, and hyperglycemia. It is a small study, but it is one of the plenty of studies that can be on the ground. And I'm happy that we have here success story, Dr. Nisreen, and our last speaker, she mentioned Tabuk experience. I hope we can see it, inshallah. Now, this was also shocking for me that 10% of US medical educators perceived that their students have these capabilities of dealing with the lifestyle issues. And what's really shocking more that they stated that 47% only of them, they think it's important. So this ring a bell in US medical education, and they start a lot of move. Maybe Dr. Wayne also can comment on this later. A lot of move pushing forward toward this. And one of statement that was really directing toward this, that the American Medical Association House of Delegates, they stated clearly that medical school curriculum reform must include training on lifestyle medicine. And they put a lot of other details. I don't want to bother you. This picture, I think you saw some of it in the first day, 2004, the American College of Lifestyle Medicine established, Institution of Lifestyle Medicine in Harvard Medical School, Loma Linda University, they take the lead in this regard. And 2010, the physician competencies for prescribing lifestyle medicine is being published in JAMA. And this one was like a cornerstone in the literature to base any educational part later on. As I said, in Harvard, they choose and opt to go from compulsory course to a parallel course that undergraduate student from different specialties, different health specialties that can take this course, and the faculty also from different specialties can teach in this course, which is really interesting. If you want to just Google it in the website and search for their experience. University of South Carolina, also they take the lead of that move, and they put it as a compulsory part of their undergraduate curriculum. Okay. So what about Europe? I just bring for you here one example of Dutch undergraduate medical education. They propose what they call it self-course, which is student experienced in lifestyle and food. And they propose it to be 25 contact hours over 10 weeks. And they measure some of the effects, not the long-term impact, but some of the effects regarding the knowledge, attitude, and self-efficacy toward nutritional counseling. So they stop on the level of the student themselves, their abilities, and it could be extended toward what's the impact, real impact on the community. But it was a great move. Now, I will just bring to you some of, because we are talking about literature, some of the nice and let's say out of the box experiences. One of the study I found it very interesting that they in 2015 they published a study from US and showing that we should move out of the box in our thinking, and they proposed what they call Teaching Kitchen Healthy Lives. It was a program being presented in US medical schools, engaging and enrolled a lot of medical students. The beauty of that, they go out of the classroom like what we did in this lovely conference. They go from the classroom toward the real life, toward the kitchen, toward the working place. Different activities helping the education and also accountable for the society. A lot of innovation came out in the literature, like the collaborative learning activity, the implementation of interprofessional nutritional workshop. So a lot of in each element of lifestyle medicine competencies, there were some work toward this. Most of my literature was from US because we are sharing with them the burden of non-communicable diseases, the heavy burden of non-communicable diseases. And one of those initiatives was the Advancing Lifestyle Medicine Education in Undergraduate by a collaborative group. And Saudi Arabia at that time, 2016, was one of them. Maybe Dr. Saleh was the one at that time. And now I think it will be improving more. One of our regional, and I hope that Dr. Rihab was with us, but from UAE, I like this experience because they go from a problem discovered in 2000. They found in University of Emirates that a huge percentage of obesity, bad habits, let's say, in their medical students. And they said, we should do something about it. So they did some intervention, which is implementing the lifestyle medicine course from the year one of the clinical school, and they link it very well, as you can see in the second picture. They link it with some activities, the regular activity in preventive medicine, community medicine, epidemiology. They make all of these assignments, all of these projects, helping the lifestyle medicine component. So that was very helpful, and they published in 2007 their results. It was not toward the education component, but it was toward how healthier our students changed. But I really like their way of thinking, and this could be one of our way to go. Now, what did we do here in our local study? In 2021, February, we formulated a research group. And I'm really glad that one of the research group pioneer, Dr. Hayat Zahrani, is here. I hope she's here. Dr. Hayat, thank you so much. So me, Dr. Hayat, and Dr. Sadim Jammaz, Dr. Abir Al-Zibin, we shared this interest. What is about our studies? What is about our local medical schools? So we formulated a research group, and we divide our project to phases. So we completed phase 1 almost, and we are waiting for phase 2 and 3 to go further. Our focus was education in medical school, and I hope, inshallah, we can go beyond medical school to the other health care schools. And our aim is to explore the status. We don't have any data talking about in depth how much and how depth we are teaching lifestyle medicine in our medical school. So this is our target. Let's know the ground first, then build up on that. So our method, we just send a questionnaire to our 37 medical school. We have 37 medical school in Saudi Arabia, public and private. And we ask the program director, the curriculum manager to fill those survey with some details. And we ask about different questions, as you can see. What I'm going to share with you today is the preliminary result. So please stay tuned. It will be published if we finish all. We are hoping that we reach 90%. We reach now 83% response rate from our medical college. And واحدة من بركات المؤتمر, 2 of our deans were here, and I catch them, and they will finish the rest. They will push us, inshallah, to 90%. So just last night I checked, we reached 86%, but we are hoping that we reach more than 90% to be for medical school. So what did we find? Most of the respondents, I mean, the one who filled the questionnaire, they were experts in the field, and most of them either vice dean or head of medical education department or unit. Most of those schools, they are teaching the problem-based, the hybrid, or the outcome-based, i.e. the new way of curriculum. And the others is most of them, they are teaching both male and female students. So what is the main result? So actually, this main result is going with our hypothesis that lifestyle medicine is under-taught in our medical curriculum, unfortunately. And also the awareness of those, let's say, leaders in medical education, in our medical education field or colleges, most of them, they are not aware about lifestyle medicine competencies. If you ask about lifestyle medicine, they will say, okay, yeah, maybe. But if you ask about competencies, it goes down. Then the course, if we ask a specific question, do you have a course or module or block that teaching lifestyle medicine? Only 4 out of the 29 saying yes. So that means 86% saying no. we don't have. Okay, so this is a very clear data. Now we go in depth about lifestyle medicine competencies. We divided to 9 domains according to ACLM domains. Just we try to put it in clusters, and we found, I don't want to take more time, I want time for discussion, but we found that nutrition was one of the competencies that has some fair contribution as a part of the course mostly, and few of the respondent or few of the medical college, they have it as a separate course. Okay. Also, we found that tobacco cessation, weight management, also sharing this almost the same. Interestingly, that the health, wellness, and coaching, we find one college teaching it, and physical activity has also one medical college teaching physical activity. But as you can see, most of the answer is toward no, as we just say in the first and the main results. But when you dig more, you find that the common thing is being that taught or at least discussed: nutrition, tobacco, and so on. But the others, nobody's talking about, especially the mindfulness. If you talk about the emotional wellness, alcohol use, we assume that we don't need to talk about it, but believe me, we need to talk about it nowadays, and our society is changing, and we have to keep with it. So some more details about what about the credit hours. As academician, we are really keen about credit hours because it has a lot of implications on number of staff, number of courses, and so on. So credit hours was showing that the physical, the alcohol use, physical activity was the highest, and the nutrition was within the range, around 5 to 7 credit hours for each. And regarding the contact hours, which mean how many hours per week you are teaching this specific competencies, we found that the sleep health and physical activity is leading. When it's coming to the age of the course, how long you've been teaching this, we found nutrition as for a long time there, and emotional wellness also, it was there for a long time. So some of those data need to be more investigated, and we are planning to do some qualitative part to dig more about this, to make sure that we are talking about valid results. Duration, how long this course is. Nutrition is taking a long time of the duration, and this could be that it is longitudinal and schedule, let's say, all over a long time. If we are talking about program learning outcomes, again, this is academic jargon maybe for some of you. Each program, that's mean MPPS program or nursing program, it has outcome, general outcome. And in our medical college, we are lucky in Saudi Arabia that we have Saudi medical framework, Saudi Meds framework, which is the PLOs for most of our medical college, 17 PLOs. And we found that physical activity, sleep health, nutrition, and weight management is very well linked and matched to the PLOs of our medical curriculum. CLOs, the course learning outcome, I don't want to bother you with more jargons. And let me now talk about how do we teach those components of lifestyle medicine. We found, as we expected, that most of our teaching is toward lectures. So lecture is the most common used instructional method or teaching and learning method, followed by small group learning. And this is a good way to go about discussion. And the clinical teaching came in the third rank, then large group session and practice or practical lab. When it's come to the assessment, again, the famous one, is the famous one all over, the MCQs. Okay, so MCQs, multiple choice questions was the common one to be used, followed by short answer question or short essay question. OSCE, which is a sort of clinical examination or clinical competencies examination was the third one, and so on. So what does all of that mean for us in lifestyle medicine? Simply, I put it in 3 lines. I don't want to take a lot. Lifestyle medicine is under-taught in our medical college as a whole concept. What I mean by a whole concept, all of those 4 days in this conference, we learn a lot about lifestyle medicine. It's not only that sentence that's been taught when we were a student, that non-pharmacological, pharmacological, non-pharmacological lifestyle intervention. It is now a science. So with this, I mean, depth and breadth also of lifestyle medicine competencies and concept, we need to incorporate it in medical school. There are fair distribution of lifestyle medicine competencies in the curriculum, but in a scattered manner, as we just saw in the result. And lecture MCQs dominating the teaching and learning and assessment, and this should be changed to more of a practical things, like something that they are living with, because it is living science. Now, what can I recommend or conclude at the end of this presentation? I can put it in 3 or 4 points, and Dr. Saleh maybe he already incorporated in the recommendation of this conference. Lifestyle medicine education is a necessity, not a luxury. This answered Dr. Sulami first question in the first day, maybe. Saudi Medical School should incorporate the comprehensive concept of lifestyle medicine. And lifestyle medicine competencies are matching the Saudi Meds framework, and also it's linked to the model of care, as we just learned in this conference. So we are moving with the momentum. So as an educator, we should keep with the momentum. We should get our graduates ready for this momentum. Lastly, I really like that we are going in lifestyle medicine in the interprofessional, collaborative, and community-based approach, instead of isolated teaching for physician, isolated teaching for nurses, isolated teaching for dietitian, and so on. When we come together, we want to work as a team. As Dr. Nasreen, she's successful. Maybe she's lucky that she's lucky by people. They understand and they are motivated toward this, but it's not the case everywhere. We want something standard, that everyone talking the same language, aiming for the same. My deep and sincere acknowledgement for my research group, as I said in the beginning, Dr. Hayat, Dr. Sadim, Dr. Abir, and we are from 2 different, from nutrition and from family medicine and education background, University of King Saud University and Princess Noura University. We hope this group will be getting more of members to just expand the effect of those data. And thank you so much. You can scan this barcode and contact me if you wish, if anyone interested for a further work. Thank you so much.
Thank you so very much, Dr. Mansour, for this lovely presentation. I think it's safe to say, inshallah, إنه كان ختامها مسك بحول الله تعالى. Any questions for Dr. Muhammad?
السلام عليكم. فعلا ختامها مسك. شكرا دكتور محمد. Thanks a lot for this initiative. And if you allow for me, I will be more than honored to be part of this excellent effort in your research group. Actually, I was discussing with Dr. Hayat. I have a simple suggestion for you, which may help from individual effort till we have a complete established curriculum for lifestyle undergrad study. I'm suggesting, again, it will be an educational jargon because I'm an educationist also, the SPICES model. So student-centered, problem-based, integrated, community-oriented, and then elective. So if you have an area, every one of you of this prestigious group in your medical education institute, you can invent this start and publish. I think other institutions will feeling jealous to share in this movement in Saudi Arabia.
Thank you so much, Dr. Ayman, for this comment. I think it's important, and it's in our mind that we will not stop on describing whatever is there. We should move forward to establish some sort of intervention in a level of education, like what you said, course. And I'm really happy that if we can make it like a nationwide, international, interprofessional course, it will be great. Like what happened with the patient safety. If anyone interested in patient safety now, it has been disseminated as a national course, and all the medical schools, they are adopting it because it's part of NCAA accreditation. We can do with this. Yes. Thank you.
شكرا دكتور محمد. شيء ممتع والله انك تتحدث عن طلاب الطب ودراسة الطب. أنا عندي سؤال، السطر الأخير اللي تحت هذا إيش معناته؟ هذا السؤال سألناه ممكن يجاوبنا بعدين. سؤالي أنا حقيقة أبغى أرجع جت فترة كنت مهتم بالموضوع ده وقعدت أعمل شوية سيرش، لقيت إنه في بعض كليات الطب تعمل شروط لدخول كلية الطب، من ضمنها موضوع الفتنس، إلى درجة إنه بعضهم يطلبوا فحص طبي مختلف في الفي ماكس او يعني اللياقه البدنيه عند الشخص القلبيه التنفسيه يحسبوها بطريقه، بعضهم يسووا له فحص البوش اب والسيت اب ويطلعوه على السير يقدر ولا ما يقدر. فما اعرف كيف نفكر فيها دي. بس اللي اهم من كده قصه تاريخنا العظيم. كان في شيء اسمه شيخ المهنه، شيخ النجارين، شيخ الحدادين، شيخ البنائين. هذا عنده نظرة خاصة تلمس موضوع الأخلاق والمظهر وبما في ذلك السلوك، بما في ذلك الالتزام بالصحة وغيره. فما أعرف يعني بغينا عصف ذهني عشان لا نجي نجدول الأمور بطريقة مرة يعني منزوعة من الروح، إلى درجة أننا حنلاقي طبيب مدخن وطالب طب مدخن ويتخرج من الكلية ويسمين ويتخرج من الكلية وما أعرف إيش كمان السلوكيات اللي موجودة، يقزع شعره بالشعر المقزوع هذا اللي القزع وما القزع ويتخرج من الكلية. فما أعرف يعني دي يبغى لها نظرة شوية out of the box. آخر شيء كويس إنه يكون جزء من التوصيات إنه الطلاب دول يقدروا يؤثروا على مجموعة مرضى. واحدة من الأساينمنت مثلا إنك تمسك له 50 مريض 30 مريض وتفتح لهم واتساب جروب وتناقشهم في ال5-6 إيليمنتس حق اللايف ستايل. هذه تديله الخبرة إنه هو يأثر في الناس، وعادة اللي يأثر في الناس يكون هو نفسه يتأثر، لأنه كما يقول الشافعي عن العلم يزيد بكثرة الإنفاق منه وينقص إن به كفا رددت. وشكرا.
شكرا دكتور صالح. الدكتور صالح دائما you are bringing something that is out of the box. So أعتقد يعني وضع كرايتيريا لقبول الأشخاص بناء على their own خلينا نقول healthy behavior. It is maybe it could be enforcing, but it's a very advanced step. Need a policy maker decision. The other point about our history, I'm trying to just translate. I think absolutely you are right. We have a huge historical background, and I'm interested in philosophy of science. And I found a lot of advancement in matter of how our ancestors in Al-Farabi, Mawarzi, they did a huge job in making standards. So, for example, there were something called al-muhtasib. محتسب في الطب، المحتسب في الزراعة، المحتسب في الري. That's mean he is the accreditation person for those people to be either accredited to continue the career or not. إجازة. So I think we have a lot of examples, and from our historical background, scientific historical background, let's say, we can adopt it, we can put it on the ground, we can touch our culture by those means. So yeah, I agree with you. Thanks, Victor.
Thank you.
Yeah, last point, sorry, Doctor, I'm sorry. Last point about the impact. I think this is very good, important point. A lot of our medical schools, as I know, they have projects, either in the community medicine or research project or different courses. Some courses need some assignments. So if we agreed, like what they did in UAE, they agreed that they direct the student toward lifestyle topics toward this. So you will find a lot of efforts, a lot of data, a lot of impact being done with the usual and regular activities that they should do it, the mandate. Thank you.
Thank you. I just have a comment. You know, like we are trying to incorporate the lifestyle medicine, you know, like within our curriculum, and but I feel it needs a bit of modification. We cannot just take it as is and just absorb it. We were discussing yesterday or the day before yesterday, if there are, you know, like certain forms that we can use and adopt and to be unified maybe for the kingdom and start using it. For instance, you know, like asking patients about sleep or certain herbs that they're taking, their health perspective, you know, like have they been screened before about any diseases? Have they done CBCs? How many times have they done a screening for CBC or screening for pap smears for women? You know, I think this needs to be modified, and, you know, we need to have our own forms, our own perspective from, you know, like lifestyle medicine.
Absolutely agree with you. Thank you for bringing this. So I will not take Wayne's prescription that 2 days in a year eating meat. If I say this to our community, they will never come back to me again. So absolutely agree with you. We have to customize the things according to our culture, and also it should be matching the evidence. So we should not be, and we should build up our own evidence, but meanwhile, we should just modify it toward the language we are talking. Like Dr. Abdulaziz said, that the food that we are eating, we should name it by its name, and either in the education level or in the practice. So I totally agree with you. Yes.
شكرا دكتور دانيال. Dr. Dan and I work together, and we think alike, you know, establishing our norms in our society and learning from other countries and other societies. First, thank you, Dr. Muhammad. Nice lecture, nice presentation. And I'm very glad to have you on your team, the Lifestyle Medicine Research Team from Princess Noor and Prince Saud University. And just this is more kind of comment than an announcement. We will be forming a group to create a curriculum to train, among which the Ministry of Health, primary care physicians. This is an introductory curriculum. It's not an in-depth course. And Dr. Wayne agreed to help us in hopefully getting the courses available through the American College of Lifestyle Medicine, hopefully the 40-hour or 100-hour. We will let you know when we get something substantial, not now. We will not promise you anything now, but we will be working on it. So those who are interested in joining this group, please let me know. Just send me a message through WhatsApp, And Dr. Muhammad and his group are part of this, inshallah.
Absolutely.
Because we need them in order to have people who specialize in professional curriculum, establishment.
Thank you, Dr. Saleh.
Thank you, Dr. Muhammad. I just, highlight one point that the new assessment, the medical assessment now guidelines included lifestyle among the medical history. Even in, probably we need actually to adapt some national, but now within the medical history of each patient, you should write something about our lifestyle because it's actually reflecting the wellness of this patient.
Sorry, Dr. Abdulaziz, you mean is it mandated by the
Now the new guidelines.
The guidelines, yeah, okay, okay. I promised Dr. Aibad that I will finish 3 o'clock, but you are keeping asking question. I will stay. Okay.
Sorry, I have 3 comments and then 1 question, but I think you maybe just partially answered my question. So the comment is, first, I mean, it's a great presentation and it's nice to see this kind of data developing. But I thought it was actually quite good that 4 medical schools already have a lifestyle medicine curriculum. That's not bad considering the age of the lifestyle medicine movement. I also thought that it was quite bad that there was so little nutrition education. I think you can, if you really believe in lifestyle medicine, you could make a case that you should have as much nutrition education as you have pharmacy education. And then the third comment was, OSCEs are a great tool to test lifestyle medicine. So it's nice to see some medical schools are doing that and hopefully more in the future. The question was, what kind of national testing? I don't know what kind of national testing you have here to get certified as a physician, but that's sort of the gold standard. And it sounds like maybe you're saying that that is coming. Obviously, if a medical school knows that their graduates are going to be tested on lifestyle medicine, then they're going to get that lifestyle medicine curriculum. But I don't know, I'm interested in more comments on that.
Thank you so much, Dr. Wayne. Actually, I totally agree with you that we need to build up this capacity according to the most important priorities. And to be honest, when we start this quick survey, we thought that the answer will be 0 for a lifestyle course. But we were really glad that we have at least this small percentage, but it is the start. So I think it could be like a spotlight that we can increase it over, and this is really interesting to go further. For your question, I think you are coming from some of the literature that composition in a matter of the subjects and categories can affect the medical school curriculum as a retrograde manner. So I totally agree with you. We have here Saudi medical licensing exam. It's almost similar to USMLE. It is mainly for knowledge part, and it has a categories. And I think you made a great point that we need to tackle this through Saudi Commission of Health Specialty, because it's the regulatory body. And hopefully we can put it to Dr. Saleh as one of our recommendations, that the Saudi medical licensing exam should have a portion, let's say agreed portion on lifestyle medicine competencies. We should not say only nutrition or whatever. So let's say competencies. And from there, you can go backward to the medical school and say, okay, now you have mandate to graduate student to match this exam. This is gonna work.
Just so you know, someone donated, several people donated a lot of money. There's now 1,000 questions.
Oh, That's great. Yeah. Yeah, absolutely. That's a good point, and thank you. I'm really happy to share with you because I have some connection inside the Commission of Health Specialty. They will be glad if we put the proposal and we give them solutions, not only saying talks. Thank you. So
I will be taking the last question. If you don't mind, just put up the final slide where there's the contact information of Dr. Muhammad. If there's anyone who have any further questions or inquiries for Dr. Muhammad, just contact him, please. This is the final question.
Thank you, Dr. Muhammad, for this very conclusive and informative, actually, talk with evidence. This is the most important thing. And for data that it's showing there is a partial courses related to smoking, nutrition, all these, that's good. But still, again, as lifestyle specialists, you have a concern. What they are teaching them regarding, because what we are talking about lifestyle, it's a wellness mindset. Wellness mindset means when you are seeing your patient, the first thing you ask about is lifestyle. And you are not dealing with lifestyle as prevention only. It's a therapeutic intervention. So if this mindset was teachable in the medical school or not, we don't know. If they are talking about smoking, what type of material they are using? If they are talking about nutrition, what type of material they are using? So this is our concern, really. So I don't know what type of study we can use to just see the outcome of this we are seeing diabetes increasing, obesity increasing, hypertension increasing, with all increasing medical student graduation annually. So maybe we need to do, I'm agree with Dr. Ayman, if you have piloting, we can choose whatever college and do piloting with a curriculum of lifestyle as a parallel curriculum, or as Harvard using parallel curriculum with the medical school, or as a workshop in other also area, whatever way, but to make sure that this type of curriculum we are using, it's really lifestyle mindset, and we can measure the outcome after that. I agree with Dr. Wine. Maybe to be effective, you can use like giving them some suggestion regarding the assessment and all this issue. But you know, we were student before, and we know if you have an MCQ, can just open the previous, taking the answers, and that's it. So it's a way to start, but we have to have a structured thing. And thank you so much.
I think I agree with you, Dr. Nasreen. Thank you so much. I don't have an answer for how depth is those competencies being taught. As I said, we just touched the surface, and we can go in depth with the research team and anyone who's interested, that we can take a qualitative study to ask the people, ask a student, ask the faculty how they are doing things and how they believe about it. It's a long on the first stage, let's say. So I think you are right. We should keep this momentum going, and with the time, if the practice is building up the needs, so the education, the regulation, everyone will respond. So it is like a circle. Thank you.
Thank you so very much, Dr. Muhammad. And with this, ladies and gentlemen, we will conclude our scientific session for today. Please have a lovely evening and enjoy the rest of the activities, and enjoy Hail.
People are asking about the translation at the bottom of the promo logo of Hail conference. This is the old Arabic letters. It's called the Lugha Thamudiyya. And it's just saying Hail Lifestyle Medicine International Conference. So that's what it says. If you like your name to be written in old Arabic text, you could ask for it. People will help you out here. But this is the very old. This is thousands of years old. And you could see it in the mountains right here in Jubba.
Kufa and also some other places. Also, if you go to Al Ula and also in southern Saudi Arabia and also in central Saudi Arabia, you will see it in old ruins, and it's very interesting. So. The 6,000 or something, yeah.